So can you try one more time?
Yeah, now I can.
All
I
right.
can. I can. Can you see my screen now?
Yes, sir.
I'll just run the slide once.
No.
Hi, good afternoon, everyone. I'm Dr. Ankit Dedia from Mumbai. I'm an interventional cardiologist, and I have got this opportunity through MCure to present this important topic that we are discussing: the dual pathway inhibition with rivaroxaban in adjunct to aspirin in coronary artery disease. So this is what we are going to discuss today: the outline, the coronary artery disease, and the risk for ischemic events, the management strategies with antithrombotics, the recommendations and trials, Compass trial in detail, and the conclusion. So if you see that patients over the period of long years, patients with coronary artery disease remain at high risk for ischemic events. By the REACH registry, if you see here, the risk factors only at the beginning is 9.1. With every year, this risk increases. And a 4-year outcome of this mammoth number of patients, of 64,000 plus patients of more than 45-year-old, if you see the cardiovascular deaths, the MI and the stroke risk increases to 21.1 from 9.1. So every year this risk increases. So these patients of coronary artery disease are always at high risk for ischemic events. And here you clearly see that arterial thrombosis and antithrombotics, if you see here, the platelet aggregation, the thrombin, where the places where aspirin, the P2Y12 inhibitors act, and the DTI, that is the direct thrombin inhibitor, and the factor Xa inhibitors, all these factors, all these drugs play an important role in preventing these thrombotic or ischemic events. So here we clearly see the antithrombotic treatment strategy in patients with coronary artery disease. Yes, after an MI, that is a if you see the algorithm on the right side, the admission with MI and treated with DAPT, that is, patients are loaded with aspirin and clopidogrel, angiogram is done, patient is either taken for PCI, conservative management, or CABG. These patients always are up for a dual antiplatelet therapy for a period of 1 year. Once this 1 year period is over, we should note that if in case of any indication for oral anticoagulation, it's like atrial fibrillation, high risk features of for life-threatening bleeding, anemia, the bleeding risk should be taken into consideration. And if there is no bleeding risk, these patients should be considered for aspirin plus rivaroxaban 2.5 milligrams BID after 1 year of DAPT is over. Or if suppose there is a stable coronary artery disease patient on aspirin monotherapy, but history of multi-vessel coronary artery disease or MI is there, yes or no, then in case of yes, the patient should be assessed for additional risk factors like diabetes, peripheral artery disease, kidney failure, heart failure, or prior non-lacunar ischemic infarct or stroke. In case of presence of any of these factors, this patient is a clear-cut indicator for aspirin plus rivaroxaban 2.5 BID. So when you're considering antithrombotic treatment in patients with coronary artery disease, what is the balance that we are looking at? We are looking at the ischemic risk versus the bleeding risk, and various factors play an important role in this. Whereas patient's characteristics, that is the age, the sex, the race, history of ischemic or bleeding events in the previous timeline, clinical presentation, that is whether it's a chronic coronary syndrome versus acute coronary syndrome, comorbid illnesses like chronic kidney disease, diabetes, peripheral artery disease, or heart failure, co-medication, need of oral anticoagulation treatment for various other illnesses or any drug-drug interaction, and lastly, procedural aspects, whether the patient is undergone PCI versus CABG, radial versus femoral access, invasive versus conservative. So all these factors play a big role in deciding the antithrombotic regimen for our patients. So as per the new guidelines recommendation for a second antithrombotic to aspirin for selected patients with chronic coronary syndrome, if you see here the 2019 ESC guidelines have clearly mentioned adding a second antithrombotic drug to aspirin for a long-term secondary prevention should be considered in patients with high risk of ischemic events and without high bleeding risk, which with a class of 2A with a level of evidence of A, and in case of moderate risk, it is class 2B. So when do you decide high risk versus moderate risk versus low risk? If a patient is classified as a high risk patient when patient is having a diffuse multivessel coronary artery disease with at least one of the following characters, that is diabetes, recurrent MI, peripheral artery disease, or chronic kidney disease with eGFR between 15 and 59 ml per minute per 1.73 meters square. That is the high risk category. When in the low risk category, the diffuse multivessel coronary artery disease becomes one of the characteristics, and among these 5, any one present in the patient puts the patient in a moderate ischemic risk category. So in such patients, new guidelines recommend 4 options for dual antithrombotic treatment, that is addition of 75 milligrams of aspirin plus any of this, that is clopidogrel 75 milligrams OD, that is most indicated for patients post-MI in patients who have tolerated DAPT for 1 year, prasugrel 10 milligrams OD for post-PCI patients who have tolerated DAPT for 1 year. But in these patients, clearly you consider additional cautionary factors of age and weight, rivaroxaban 2.5 BID, a post-MI for more than 1 year, or multivessel coronary artery disease. But in case of creat clearance should be kept checked. Ticagrelor 60 milligram BID post-MI patients who have tolerated the DAPT well for 1 year. So in these patients, if you see, best treatment would be rivaroxaban 2.5 milligram BID as per the COMPASS trial. So here, always when a patient comes to us with ACS, that is the arterial thrombotic event, that is the first acute phase, is the time duration when the platelet activation is the strongest, that is 1 to 3 months. But beyond that time, over 3 months and above, the thrombin-generated thrombotic events are more. And that's why we divide this phase between acute and chronic, where acute stage always should be treated with double antiplatelet therapy, that is the dual antiplatelet therapy, versus the chronic phase beyond 1 year of your STEMI or of your PCI. You should consider putting the patient on dual pathway inhibition, that is antithrombotic plus antiplatelet, anticoagulant plus antiplatelet therapy. So here clearly saying that antithrombotics for secondary prevention trial based, if you compare, there are multiple trials, that is CAPRI, Charisma, Pegasus with 19 milligrams ticagrelor, Pegasus with 60 milligrams ticagrelor, and lastly but not the least, COMPASS trial with rivaroxaban plus aspirin. So where clearly you can see the MACE event was significantly in favor of rivaroxaban plus aspirin. There was a clear-cut indicator that MACE events was much less as compared to the other trials, and the stroke events were much lesser, 42% reduction. Cardiovascular death was 22% reduction, and MI, which was not significant, but there was a 14% reduction, so much so forth. So COMPASS is the only antithrombotic regimen trial showing significant reduction in all-cause mortality. So clearly showing that in chronic coronary syndrome patients, all our patients who are at risk for ischemic events should be on rivaroxaban 2.5 milligrams BID if there is no bleeding risk for our patients. Coming to the timeline, that the evidence which support the use of rivaroxaban 2.5 milligram BID, there are various trials. If you see here, Atlas ACS STEMI in 2009, followed by Atlas ACS STEMI 2, which was 15,000 plus patients. Then came the Pioneer AF trial with AF patients with PCI undergoing PCI. Then came the Gemini trial, and finally the COMPASS, which was a mammoth trial with 27,000 plus patients with coronary artery and peripheral artery disease. And clearly, these patients were shown to have unstable coronary artery disease Rivaroxaban 2.5 BID reduces the MACE events significantly as compared to aspirin alone. So yes, just putting up light on the COMPASS trial, which is the cardiovascular outcome for people using anticoagulation strategies. Yes, this was a double-blinded trial with 27,000 plus patients with stable coronary artery disease and peripheral artery disease were randomized. Patients were put on aspirin alone, 100 milligrams daily, rivaroxaban 5 milligrams BID, and rivaroxaban 2.5 BD plus aspirin 100 daily. Patients were followed up for a median of 1.9 years. This was the inclusion criteria. If you can see here, the coronary artery disease patients had to be involved if they had a previous MI within last 20 years of or multivessel coronary artery disease or multivessel CCI or multivessel CABG was done. Patients with CAD must meet at least one of the following criteria, that is age more than 65. Age, if less than 65, then more than 2 vascular beds or more than 2 additional risk factors like smoking, diabetes, eGFR of less than 60, heart failure, non-lacunar ischemic stroke of more than 1 month earlier duration. This was in coronary artery disease, where you're comparing with peripheral artery disease. Patient would either have a previous revascularization, previous limb or foot amputation for arterial vascular disease, history of intermittent claudication, and one or more of the following factors, that is significant peripheral artery stenosis of more than 15% documented by angiography, or patients having coronary artery disease plus a low antebrachial index. So these patients were randomized, and overall a 24,000 number of patients were enrolled with advanced chronic coronary artery disease. So these patients were seen to have multiple comorbid illnesses. And if you see here, 20% of our patients in COMPASS trial had coronary plus peripheral artery disease. 69%, a staggering number, had a previous MI. 37% had diabetes. 22% had renal impairment. And 23% had heart failure. So this was the comorbid representation in COMPASS. And you can clearly see here, when cumulative hazard was compared with aspirin versus rivaroxaban plus aspirin. So definitely rivaroxaban plus aspirin was having much more benefit with reduction in MACE events by 24% as compared to aspirin alone. And that's why the primary outcome was 24% lower with rivaroxaban 2.5 BID plus aspirin than only aspirin alone. So here again, clearly showing that MACE events were overall, there was a significant benefit. Here again, you can see clearly the primary outcome with the CV death, stroke, and MI was much lower in COMPASS in 2.5 BID plus aspirin versus aspirin alone. Even in the secondary outcomes, if you see the ischemic stroke, MI, acute limb ischemia was much lesser. Secondary outcomes were better. Stroke, all type was much better with COMPASS data, and major bleeding, yes, with both, whether it's aspirin plus 2.5 or rivaroxaban alone versus aspirin, more or less, there was bleeding risk was more or less the same. So clearly the clinical implications of COMPASS were switch to dual pathway therapy from DAPT after 1 year. Therapeutic use and clinical benefits of dual pathway therapy in both coronary plus peripheral artery disease is significant. Dual pathway therapy in PAD, that is peripheral artery disease, from its initiation after the lower extremity intervention and continuing through long-term prevention is important. So the NICE guidelines in 2019 have recommended that rivaroxaban plus aspirin is a recommended strategy when you're considering to prevent atherothrombotic events in adults with coronary artery disease or symptomatic peripheral artery disease who are high ischemic event rate. Result, that is aspirin plus 2.5 milligram BID rivaroxaban in stable patients with history of MI, peripheral artery disease, or multiple risk factors. Always consider these patients after risk assessing of bleeding tendencies. As per recommendations, dual pathway therapy may be considered for preventing atherothrombotic events in adults with coronary artery disease and symptomatic CAD. It seems to be switched to dual pathway therapy from DAPT in our chronic coronary syndrome patients. Thank you. With that, I would like to end my and if there are any questions, we are free to answer. Hello. Hello.
to the Industry Symposium at the CSI NIC. I am Aparna from Medtronic, and for the next half an hour, I will be your host for taking you through some of the most exciting device technologies that we have in the field of CRM. So firstly, we have this topic which was never unnoticed in any device symposiums today, which is the conduction system pacing. And we have Dr. Shanmugh Sundaram with us, who is the consultant interventional cardiologist and electrophysiologist at the Velamal Medical College Hospital and Research Institute, Madurai. Sir, it's an honor to have you here with us. Over to you, sir.
Thank you very much, Aparna, and thank you, Medtronic, for giving me this opportunity. And a big thanks to NIC for having me in this meeting. I'll share my screen. So the topic assigned to me was bundle branch pacing. So we know the chronic deleterious effect of right ventricular pacing is going to produce both electrical as well as mechanical dysynchrony. It is going to produce a chronic LV dysfunction, recurrent heart failure, atrial arrhythmias, and ultimately increase in mortality. So to overcome this issue, so what people started doing is, instead of pacing the RV myocardium, people started pacing the cardiac conduction system directly. So either the His bundle can be directed, which is a narrow band of fibers in the lower right atrial area, just close to the tricuspid leaflet, or even the left bundle branch can be directly targeted by placing the lead inside the proximal. So what are the tools which are required for doing this conduction system pacing? So it is nothing but doing a routine dual chamber pacemaker, but for two additional gadgets. So one thing is a delivery sheath. There are two sheaths available. One is a non-deflectable sheath, which is known as C315 sheath. The other one is a deflectable sheath, which is yet to be available in India. It is labeled as a C304 sheath. So these sheaths are meant to take the lead towards the target zone. The lead which is most commonly used for doing conduction system pacing is the 3830 Select Secure MRI compatible lead. It's a small 4.1 French lead. It's an open helix lead, so it has to be taken inside the heart only with the sheath. So the lead is having an open helix, so you have to rotate the whole lead per se to deploy the lead inside the septum. To do conduction system pacing, we need to know the fluoroscopic anatomy of the conduction system. In fact, my talk, I'm going to restrict to the left bundle branch pacing. So we should know what exactly the conduction system will look like in a fluoroscopic view, so that we'll be able to deploy the lead properly. So the one important view which we usually do before starting the procedure is RAO 30-degree view. So where in a center where you have an EP equipment, just place a catheter in the His bundle and one catheter in the RV apex. Just draw an imaginary line connecting the distal His bundle to the RV apex. So this imaginary line should connect the distal His bundle to the RV apex. And the area to deploy the lead for left bundle branch pacing is going to be the initial 1.5 centimeter. This is because the cardiac conduction system anatomy will be looking like exactly in this picture in RAO view. So you'll have the distal His bundle here. It branches out into left bundle and right bundle. The right bundle will be in line with this His bundle catheter, and the left bundle will be a little down. So it is easy to target the left bundle here from the right side of the septum. The only thing we have to do is identify the area properly and go deep into the septum so that your lead will be deployed just beneath the LV subendocardium to capture the left bundle branch. Why His bundle branch, left bundle branch pacing? In fact, His bundle will produce a most beautiful looking QRS, and it is considered as the most physiological form of pacing. But despite that, there are a lot of limitations which are inherent for His bundle pacing, which is actually can be demonstrated very well in all published trials. So we are aiming for a narrow target, so where the His bundle is probably 4 plus 2 millimeter in dimension. And once you deploy the lead, there is a chance for lead dislodgement. There is a need for lead revision on long-term follow-up. At least 20% of the patient may need some form of a redo procedure for either rising threshold or a lead dislodgement. Of course, there will be a lot of atrial oversensing and ventricular undersensing, and you may have to program the battery at a higher output that's going to deplete the battery prematurely. Of course, some of the distal conduction system diseases may not be able to correct by the His bundle pacing, but your left bundle is going to correct all these problems. If you are interested, probably you can go to these two reviews which will tell you how to do the procedure both with the EP system and without EP system. Of course, the first step in doing the procedure is going to identify the target site. See, we are entering into the left LV submetacardium from the right side of the septum. So we need to know exactly where we are going to start to deploy the lead. So like in the previous slide which I was mentioning, so you have to go to the RAO view. So draw an imaginary line connecting the distal heat signal to the RV apex, target the initial 1.5 centimeter. So you have to place the lead along with the sheath there, pace there on the right side of the septum to get a W pattern in lead V1. So once you get a W pattern in lead V1 and a positive QRS in lead 2, then start deploying the lead. You have to give turn by turn and monitor the pace QRS morphology as well as the pacing impedance. You can see here. So once I start from here, I've given a couple of turns. So this notch has gradually ascended up. And once I give a couple of more turns, when the lead reaches the mid septum, you can see the QRS has started shrinking. The QRS duration has come down, and the notch from here has migrated to this isoelectric line. When you give additional one more turn, the notch is almost formed an R wave. So once the lead reaches the left bundle area, after giving one more turn, you can see the notch has ultimately formed an R wave. So this R wave in lead V1 is very important to identify that you have reached the left bundle area. So not only this R wave, you'll be able to see a very narrow looking QRS, almost normal appearing QRS, and the ECG will show incomplete right bundle match pattern because you are directly facing the left bundle. Apart from that, you have to demonstrate that the left ventricular activation time is short and constant. So what we'll do is we'll be measuring the interval from the onset of the pacing spike to the peak of R wave, and that should be less than 80 milliseconds. So if you are getting a QRS with the left ventricular activation time, that is from the pacing spike to the peak of R wave, less than 80 milliseconds, that means that you have reached the area. So this is how we usually deploy the lead. From the RAO, for lead deployment, we'll go to LAO and give rapid turns so that the lead will go deep inside the septum. So once you reach the target zone, you can confirm the depth of the lead by giving contrast, just 2 ml of contrast into the sheath. You can see here how deep the lead is in. So almost 13-14 millimeter of the lead is deployed inside the septum. Of course, clinical implications, you can do left bundle branch pacing for any pacing indication, be it a sick-sinus syndrome with an associated AV node disease, or be it a malignant AV block where the patient has a recurrent syncope. You don't have to worry about late iteration threshold. You don't have to worry about late lead dislodgements. So all this can be effectively tackled by left bundle branch pacing because it is going to produce a very stable threshold and it is going to produce a stable lead parameters. Of course, the interest of left bundle branch pacing is not for this Brady indication, but for treatment of heart failure patient. So any patient with an indication for cardiac resynchronization therapy, it is our custom in our lab to start with the conduction system pacing. So we usually go for a left bundle branch pacing, whether it is an ischemic or a non-ischemic cardiomyopathy. Of course, if it is a non-ischemic cardiomyopathy, like in this patient with a dilated cardiomyopathy, normal coronary left bundle branch pacing, all you have to do is take a dual chamber pacemaker, put one lead in left bundle area, put one lead in right atrium, connect it to a dual chamber pulse generator, you'll be able to regenerate a normal appearing QRS. Even in dilated left ventricle, if you feel that the septum is not scarred and it is predominantly a non-ischemic cardiomyopathy, you will be able to narrow down the QRS. The beautiful results of left bundle branch pacing can be seen immediately. This is a post-implantation echo done within 15 days, where you can see the LV contractility, which was very poor, has significantly increased to close to 40-45%. Not only that, you can see even the mitral regurgitation, which was almost like a moderate 3+ eccentric jet, has come down to a very trivial value. This happens actually within a period of 15 days. So this dramatic improvement, this acute hemodynamic improvements, has been documented even in his bundle pacing. But in left bundle pacing, you are going to have a very stable lead with a stable pacing parameter. Not only LBBB, even a right bundle branch block can be corrected. So all you have to do is you have to deploy the lead deep inside to allow the anode also to capture, to mask the RBB delay created by this left bundle branch pacing. So another area where we are effectively working is atrial fibrillation with fast ventricular rate, where your drugs if the drugs are not going to control the rate, you can ablate the AV node and put the lead in the left bundle branch pacing if you feel that the atrial fibrillation is permanent and it is not a paroxysmal one where you can directly tackle the atrial fibrillation. Of course, not all cardiomyopathies can be corrected by left bundle branch pacing. There are certain segment of population where your left bundle pacing is not going to produce a complete correction of LBBB. Like in this case where I could narrow down the QRS to probably to close to 140 milliseconds, but still this QRS is not optimal. So what we did was we put one more lead in coronary sinus and we paced both together, and this has reduced the QRS duration of almost 200 milliseconds. to close to 100 milliseconds. So this left bundle branch is optimized cardiac resynchronization therapy is a current modality for those patients for whom LBB pacing or a hip bundle pacing is not going to correct it completely. So this is what we usually do. We take a CRT PG, put one lead in left bundle, put one lead in coronary sinus, and the RL lead can be placed in the appendage, and you can connect it to a CRT pulse generator. So this left bundle branch optimized cardiac resynchronization therapy can be done with the help of a left bundle lead and a CS lead, left bundle lead and an RV lead, or a left bundle lead, CS lead, and an RV lead. Of course, the procedure is safe even in pediatric population. We have demonstrated the safety of procedure even in elderly populations where the lead can remain safely there without producing much complications. So this, our experience, we have done close to 305 conduction system pacing is predominantly of left bundle pacing. In our center, we have done close to 208 cases of left bundle branch pacing, and we didn't find much complications with left bundle branch pacing. We have published some of our experience in as a single center as an international collaborative study along with Vijayaraman sir. The last year's late-breaking trial was related to this left bundle branch pacing as a replacement for CRT, where we have shown that LVBP is going to give significant advantage in terms of reduction in LV dimension, in terms of improvement in LV function, and reduction in cardiac NYHA functional class. Of course, there are certain segment of population where the LVBP alone is going to be the culprit for producing LV dysfunction. So this category of patients is known as a left bundle branch block induced cardiomyopathy, where you have to just do left bundle branch pacing and use probably a dual chamber pacemaker, and you'll be able to produce 100% improvement in LV ejection fraction. So this particular study, where we included 17 patients and 13 patients underwent left bundle branch pacing, and almost all patients showed a significant reduction in QRS, and almost all patients were a significant hyper-responsive group, where we could show improvement in ejection fraction to more than 50%. But word of caution, remember this is a new procedure. The first procedure was done in 2017 by Dr. Rung in China. So the data available is only limited, and the lead which actually we are using for left bundle branch pacing is actually not meant for a deep septal pacing. It was actually used for a site selective pacing from 2005. There are data which supporting for its use for septal pacing, but this deep septal pacing, again, we have to wait for the data. Of course, potential complications you have to keep in mind. We had some couple of dislodgements which we have to reposition it, and we had a case of transient ST elevation which settled automatically, and there is a chance that the lead may even dislodge into the left ventricle during follow-up. So all these things you have to keep in mind. Of course, lead extraction, the data will come probably in another 4 or 5 years for lead extraction, because as of now, the need for lead extraction is very, very minimal. To conclude, of course, the alternative site of pacing has led to physiological pacing was targeted initially, and now we have a good area to target the conduction system. But the only thing is that the long-term safety data for left bundle branch pacing is yet to be available. Thank you.
Thank you, sir. That was quite an insightful session that we had on conduction system pacing. So up next, we have another novel technology in the field of pacing, which is the leadless pacing. So for that, we have Dr. P.K. Hazra, who is the head of the Department of Cardiology at the AMRI Hospitals, Kolkata. Sir, over to your presentation, please.
Can I share my video?
Yes, sir.
Okay. Give me a moment. Start my video. Okay. So friends, today I'll be talking on another aspect of wireless pacemaker device, that is micro AV. This is basically a kind of dual chamber pacemaker, but it works in AV block, not in sick sinus syndrome. When you have active nice A wave, so it tracks A wave not electrically, but by some algorithm, and it produces the AV synchrony, and it works as VDD pacemaker. Now, why micro AV? Micro AV because it is the smallest pacemaker in the world, and it is just another single chamber micro. And on the top of that, you have this AV synchrony, and you don't need any lead, so it is inside the heart, and there is no scar outside. We started with mass 40 patients, A4 data. So A4 is very significantly tracked by this device, and that's how it produced. And we had to wait many years for this wonder device to come into practice. So we have 90% of reducing and synchronic. We have more data, but from this trial, what we have learned that Marvel 2 algorithm downloaded in existing micro devices, and they enrolled completed study procedures at 12 centers in Europe, United States, and Malaysia and Hong Kong. In Malaysia, Kuala Lumpur is a very big center, and they are pioneer. I got myself trained from Malaysia, and they have very active program on micro devices there. Primary efficacy objectives demonstrated increase AV synchrony. So the AV synchrony was the primary thing they looked for. BDD pacing versus a single chamber VVI pacing in patients with complete heart block. That means you have many P waves, very few V waves, or in sinus rhythm. Primary safety objectives, freedom from pauses, inappropriate tracking, more than 100. So pacemaker-related tachycardia, we also look for. Demonstration of higher LVOT VTI in VDD. So there was hemodynamic study, and we know that pacemaker syndromes are much less frequent with the VDD device and DDD device. The pacemaker-induced cardiomyopathy is also another issue with VVI that can be corrected by left septal, left LVB area, LVB zone, or his it produces. So it cannot replace a patient who has got pacemaker-induced cardiomyopathy, and they are not the candidate for your pacemaker, this kind of pacemaker. Is they're elderly people, they may be on oral anticoagulants, they may be on warfarin, they are frail, fragile, bad skin, and time since implant 13.8 months, female 30, that means 40%, hypertension, paroxysmal AA 19%. Now, if you have AA, that VD, then why VDD synchrony? It's not necessary that paroxysmal AF means they will always remain in atrial fibrillations. Once you correct that six sinus syndrome, AV block, many of them may come back to sinus rhythm. If they are in heart failure, this rhythm may come back. Diabetics, CAD, COPD. Now, this is the nice pictorial of A sensitive and V pacing. So ASVP is nicely demonstrated. Now, when you put micro AV in humans, on the table, I check their Valsalva, their arcs to calf, they can sit up. So these maneuvers can be done on micro AV while they are still on the thread of the micro device. And it's nicely can be demonstrated hemodynamically once you have an arterial line or DPDT in your LV chamber. So you can immediately see the responsiveness or the BP or DPDT is increased once you switch from BVI to VDD mode. Now this A4 sensitivity, like your electrical sensitivity, can be modulated by your programming, so you can make this device accelerometer more sensitive. Primary results, more switch to VDD in patients with intermittent AV block. So it does not mean that it will remain in VDD all the time. Like any other pacemaker, it switches to VDD mode, then it goes to a waiting kind of thing, demand pacemaker kind of thing. So it can be programmed. This is the only pacemaker which can be completely switched off. For a patient like TAVR or any other indication like viral myocarditis, if you don't need any pacing, this pacemaker can be switched off. Primary efficacy objective, this is the algorithm performance versus VVI at rest. Synchrony was significantly greater with VDD pacing. That is quite understandable. Median AV synchrony was 26.8 during BBI pacing, 94.3% during BDD pacing. AV synchrony remained in more than 70% during postural maneuvers. So we can ask them to stand, to run, and you can always recheck their AV synchrony, and you can always adjust their A4 signals. This is kind of phonocardiographic signals, and as I said, it can be modulated. LVOT, nicely seen, sinus rate decrease. So mode switching is possible, and in primary results from the Marble 2 study, no pause observed, no instances of oversensing induced tachycardia, 6 adverse events collected, none related to the investigation algorithm, no adverse event reported due to lack of synchrony. Accelerometer-based atrial sensing with novel automated enhanced algorithm significantly improves AV synchrony in patients with AV block and a single chamber delta pacemaker implanted in the right ventricle. Improvements in AV synchrony led to significantly improvements in stroke volume or VTI. AV synchrony remained more than 70% during postural maneuvers. AV conduction and activity mode switches perform as intended. It can work as a concomitant device with your CCM technology or any other device like subcutaneous ICD. And this is not included in this study, but in real world, this can be done. No adverse event reported due to lack of synchrony. Limitations: acute download study, a Marble 2 algorithm for a short duration, small number of patients. Assessment of the predictors of A4 amplitude was performed in patients already implanted, and chronic ventricular pacing may have altered the electrocardiographic parameters. Validations in larger populations for longer durations in all ethnic populations, all age groups is still required. And we have other studies like that echocardiographic studies, Marble 2 algorithm temporarily downloaded up to 5 years to existing micro devices. And you can see on echo, you can see this TAPC and atrial contraction excursion. You can in the same age group, and you can see it nicely tracks. So here is my patient, and this is real world. This is real time, and you can see it nicely tracks. But the QRS duration little wider than the conventional single chamber pacemaker. You have to keep it in mind. And this is not a replacement for all types of DDD pacemaker. Those who require DDD pacemaker due to cardiomyopathy, it should be like his bundle and LV pacing nowadays. This is the pictorial thing, how it senses the A4. And this is one of my patients. He had initially single chamber pipe micra, and had to be, that time it was not available. Now he is having some LV dysfunction. He opted for micra. So it cannot be, you cannot make out which one is micra AV and which one is simple micra. It looks exactly same size, exactly hooks, and exact duration of life, battery life in these devices. This is another wonder of pacing in 2021. And with that note, I'd like to thank you for your kind attention.
Thank you, sir. We still indeed marvel about the abilities that Micra is capable of. So thank you for that wonderful talk.
Thank you.
Up next, we have our last topic for today's session, which is on the future of implantable device management, which is the BlueSync technology. For that, we have Dr. Praveen Srikumar with us. He is the consultant cardiologist and electrophysiologist at the Aster Medicity, Kochi. Sir, over to your presentation, please.
My slides are visible?
Yes, sir.
Okay. Good afternoon. I think I'll go into another new thing. As Hasra sir had told, he has shown us a new thing of 2021. So I think I'll go into another new thing in the field of patient management. One is the BlueSync technology and the future of implantable device management. This is mainly about patient monitoring. So what is remote monitoring? This is done to effectively manage cardiac device patients, even when they are not able to come to clinic. Most of the patients who are implanted with the implantable cardiac device these days are elderly. The average age of implantable patients have gone up significantly in our country. And remote monitoring allows patients with implanted cardiac device to communicate with physicians using a remote monitor. Especially, it can be done either on a daily basis. Some of the Biotronic devices, they have regular transmissions daily with a regular report. Medtronic also has that, and or you can request information from them as and when is required, or when the patient triggers an event. These are available in all the vendor devices. And older devices were larger devices. They were significantly large. You have to carry them. That was the main problem. And whenever there is an event button, there's an event trigger button where you can transmit the information. They were using they were quite simple to use, and most of the patients, once they get used to it, prefer so. And they use mostly the cellular networks available. And the advantage is that it is global. So it's almost easy to connect anywhere in the world. So it's useful for patients who are not at present in the same place as you are implanting the device. They may move to another country at a later time, and they can use it in any country. The significant advancement in this area is in the improved access to many available networks. And there is an expanding cellular network standard also, and so that you can connect to more cellular carriers. So there's an expanded coverage. There's a new connectivity algorithm where the newer technology like 4G, etc. are being used. You can switch between 2G, 3G, 4G as per the local bandwidth availability. So it's even useful for patients who are quite remotely in places. And there is faster data transmissions. In each year, the speed of data is ever increasing. So basically, they combine there's a small handheld reader device, which can be charged and kept on with a link devices. Then there is a software part of it. There will be an app which pair the reader with a smartphone or a tablet. And so place the reader over your hard device and follow step-by-step instructions as per given in the app. So it's as simple as that. Most of the people with Android phones, they know how to download each app. So any people who know how to handle an app, download an app, will also know these things. So it's as simple as that. Most of the cardiac devices can be connected to CareLink systems. 99.9% of devices are compatible with the CareLink existing network. So including the pacemakers, ICDs, CRTs, and also the Reveal Link devices. And at present, there are almost over 40,000 plus patients implanted with cardiac devices currently active in India. And approximately 1.5 lakh device follow-ups, programming, mode changes, extra performed within a year, and almost 30 to 40 follow-ups per hour. So recommended follow-up for a pacemaker is every 3 to 12 months, ICD 3 to 6 months, ILR every 1 to 6 months, and at the signs of battery depletion every 1 to 3 months. This is a recommendation. So basically what remote monitoring does is, from the patient side, there is a device which transmits cellularly to a central repository, which is accessible to a backend viewers, backend people who can monitor the events and alert the physician over the internet. So this is the same thing. There's a reader. It goes through the BlueSync. The technology is BlueSync, and it's almost like Bluetooth. So it's called as BlueSync. That's all. And it's a separate frequency of communication, it's not the usual communication frequency. So it does not interfere with regular for telephone communication frequency. And the clinician gets notified from the central repository to Medtronic through the vendor. And this will be the I'm unable to play it. Somehow it's not playing. There'll be username and password. The doctor can sign in and access all the information like a regular pacemaker follow-up. And all the data like impedance, everything is easily accessible. Regarding the studies, it has been found that patients with high adherence to remote monitoring have been shown to have 53% greater survival than patients with low adherence to remote monitoring. But these are all 3 or 4 year data. So probably long-term data will give the accurate results. So there are many RCT of meta-analysis also shows that there are many trust echoes and in time, which are in 2014, which have come in 2014, and they all showed that remote monitoring was beneficial. Some of the studies did not show much difference in survival or mortality. These conflicting results can be only assessed over a long term. So this TrueCoin is another meta-analysis which showed that there is benefit in remote monitoring. And once daily, what all these studies have shown in nutshell is that if there is a daily transmission and a daily physician monitoring, then there is definite survival advantage. Intermittent transmission has not been found to have a survival advantage so far. But number of ICD patients are quite less in most of the studies. So we need to have more time to get a data from this. And daily automatic RM system reduces all-cause mortality. That's the only thing which is shown so far in these meta-analysis. So HRS guidelines have come with a class 1 recommendation for RM should be performed for surveillance of lead function and battery conservation. That's the present recommendation. So 2015 HRS guideline. And remote monitoring is useful to reduce incidence of inappropriate ICD shocks. That's as class 1. And RM is useful for an early detection and quantification of atrial fibrillation. And patients with CID component that has been recalled. So such patients, I think RM has a definite role because there is a day-to-day monitoring enabled. And effectiveness RM for thoracic impedance alone has only a class 2A to manage congestive heart failure. This is a good application, but it has a class 2A recommendation because survival advantage is not shown in studies. So it is useful for initiation of RM at the time of CID implantation and enrollment of all and non-enrolled CID patients into RM and continuation of RM for remote monitoring for all CID previously enrolled in RM and conversion of all routine implantable device evaluation office visits to remote monitoring visits. This is slightly easy. What we do in our center is when we have a pacemaker clinic, in the morning, you can allot a particular time to remote monitoring patients, 1 or 2 hours, and monitor those patients. And patients who have an event can be given separate call or separate video call and can be managed. Especially we found it very useful in the COVID situation. And we have many patients. We almost have 85 to 90% follow-up of all due to remote monitoring. I think we have about 60% of the devices, once remote monitoring has come, we are converted to remote monitoring system either through CareLink or presently Azure device as a remote monitoring by itself. So it is easy. So these patients, we have a very good follow-up. And I think it is a niche area where, especially in the pandemic situation, we found it useful in that scenario. And the future of coming to that, of course, the CareLink, Smart App, etc. are there. And there is a relay home communicator which is yet to come. And Smart App is already there. And my CareLink monitors are already there. And Medtronic Link 2, which can be programmed with MCLH, which is expected to be available, and the current devices are upgrading. Already we have an upgraded programmer where we can program through the regular PSA. We can program remotely the patients. We are waiting for our center's internet connectivity to the device, to the programmer. Once that is there, we can use the routine old programmer to connect to patient remotely. You can do that from your laptop. At your home, the physician can program the device with a special permission from Medtronic, if it's a Medtronic device. And the patient, when he comes to a hospital, one person need to connect the programming wand to the patient. That can be done by ICU nurse or who are in the even ED physician. So only that connection is required. Then we can program and access the data directly. So another new thing is a wearable Seek patch. This is a ELR-like external patch which transmits the data, collects data and transmits. And it's a long-term device. It is yet to come. These are all new things which is yet to come. And Azure has already been there, and we have implanted quite a few. Thank you.
Thank you, sir. Thank you for that brief on the digital management of implantable devices. So this brings us to the end of the industrial symposium from Medtronic. A heartfelt thank you to all the speakers who have been there for all the talks and the audience who have been patiently there throughout the session. Have a great weekend and thank you.
Greetings. Thank you for the CSI NSI scientific chairman for this opportunity. The task given today was how to choose and use hardware in anomalous coronaries.
Sorry to interrupt you, sir. My apology. I just want to restart because the cloud recording.
Recording in progress.
Yeah, that was the backup recorder. So, yeah, you can start again, sir.
Greetings, and firstly, thanks to the CSI NSI scientific chair for this opportunity. And the task given today was to talk about how to choose and use hardware in anomalous coronaries. Firstly, the anomalous aortic origin of coronary artery is found in around 0.6 to 1.5% of all coronary angiograms. And when you come across this, it is really challenging to selectively engage the coronaries and also to follow it with intervention. So in the next 10 minutes, we will review the hardware, that is catheters, wires, and other adjunctive selection and techniques for selectively engaging for each anomalous coronary arteries origin and interventions. Commonly found ones are absent left main trunk, that means separate origin of the LAD ostium and the circumflex ostium. And the second one is the anomalous right coronary artery from a variety of locations within the left sinus of Valsalva. And the third one is the anomalous RCA from right cusp, superior as well as towards the left cusp. The third one is the anomalous left circumflex from the right cusp. And the next one is the posterior origin of the left main in the left cusp itself or in the non-coronary cusp. And then anomalous left main stem from the right cusp. Now, conceptually, the anomalous origin of the coronary from the opposite sinus can take any of these 5 courses. One is the retrocardiac, this one. And the second one is retroaortic, that is behind aorta. And the third one is pre-aortic, that is between aorta and pulmonary artery. And the fourth one is intraseptal, that is running inside the muscle, intramural one. And the fifth one is pre-pulmonary. So any of this course, the aberrant vessel can take. And depending on that, the risk is involved in terms of ischemia and sudden death. So let's look at the absent left trunk first. So when you have this separate origins as shown in this CT, usually a smaller curve like Judkins 3.5 will cannulate the LAD. And then if you upsize by 0.5, you'll be able to cannulate the circumflex. Most of the time, just pulling back and then counterclockwise rotation may cannulate it. Otherwise, you can upsize it by 0.5 size, and we should be able to cannulate the separate origin of the circumflex. The anomalous right coronary artery from the left sinus. This and the next one are the most difficult ones in terms of cannulating selectively as well as intervening. Now, this is recently published. You can reference this in terms of a sort of algorithmic approach on how you can cannulate these coronaries. If the elective patients, you can do a CT and identify the origin. In the acute patients, you can do 2 orthogonal views, a PA or a PA caudal and a lateral view. And you'll be able to identify whether the aberrant right is coming close to the left main stem or below it or above the ST junction in the aorta Greetings. Thank you for the CSI NIC scientific chairman for this opportunity. The task given today was how to choose and use hardware in anomalous coronaries.
Sorry to interrupt you, sir. My apology. I just want to restart because the cloud recording.
Recording in progress.
Yeah, that was the backup recorder. So, yeah, you can start again, sir.
Greetings, and firstly, thanks to the CSI NIC scientific chair for this opportunity. And the task given today was to come across this.
So, yeah, you can start again, sir.
To come across this, it is really challenging to selectively engage the coronaries and also to follow it with intervention. So in the next 10 minutes, we will review the hardware, that is catheters, wires, and other adjunctive selection and techniques for selectively engaging for each anomalous coronary arteries origin and interventions. The commonly found ones are absent left main trunk, that means separate origin of the LAD ostium and the circumflex ostium. And the second one is the anomalous right coronary artery from a variety of locations within the left sinus of Valsalva. And the third one is the anomalous RCA from right cusp, superior as well as towards the left cusp. The third one is the anomalous left circumflex from the right cusp. And the next one is the posterior origin of the left main in the left cusp itself or in the non-coronary cusp. And then anomalous left main stem from the right cusp. Now, conceptually, the anomalous origin of the coronary from the opposite sinus can take any of these 5 courses. One is the retrocardiac, this one. And the second one is retroaortic, that is behind aorta. And the third one is pre-aortic, that is between aorta and pulmonary artery. And the fourth one is intraseptal, that is running inside the muscle, intramural one. And the fifth one is pre-pulmonary. So any of this course, the aberrant vessel can take. And depending on that, the risk is involved in terms of ischemia and sudden death. So let's look at the absent left trunk first. So when you have this separate origins as shown in this CT, usually a smaller curve like Judkins 3.5 will cannulate the LAD. And then if you upsize by 0.5, you'll be able to cannulate the circumflex. Most of the time, just pulling back and then counterclockwise rotation may cannulate it. Otherwise, you can upsize it by 0.5 size, and we should be able to cannulate the separate origin of the circumflex. The anomalous right coronary artery from the left sinus. This and the next one are the most difficult ones in terms of cannulating selectively as well as intervening. Now, this is recently published. You can reference this in terms of a sort of algorithmic approach on how you can cannulate these coronaries. If they're elective patients, you can do a CT and identify the origin. In the acute patients, you can do 2 orthogonal views, a PA or a PA caudal and a lateral view. And you'll be able to identify whether the aberrant right is coming close to the left main stem or below it or above the ST junction in the aorta or in the right sinus itself, but towards the left and superior and the normal origin. So depending on that, then you can decide on the catheter you're going to use. Otherwise, you'll end up using 5-6 catheters and still difficult to cannulate. So as mentioned here, if it is coming just nearer to the left main, you might be able to use an Amplatz or a layer catheter. If it's coming below, again, you might be able to use an Amplatz or a backup catheter like a EBU or a CLS. If it's coming above, like in the C position, you can either use a larger Judkins like JL456 or, as mentioned here, Amplatz can be used. This is the most difficult one, the E, that is the superior and towards the left from the right sinus itself. Here you will need a 3-dimensional catheter like a 3D-RC or a Sherpa NX balanced catheter. So this is the first example, the RCA coming from the left sinus, close to the left main. And here the layer catheter is used, which is about 45 and 90 degrees angle, as you can see in 2 different views, the 3-dimensional appearance and an acute bend towards for cannulating the aberrant origin. The other thing is, IVUS was done, which shows a slit-like origin of the aberrant vessel, which is indicative of ischemia. So, LEA catheter used, wire is there, and IVUS is done over that with good support. And that is the live image of that LEA catheter cannulating selectively the aberrant vessel, the wire, and then IVUS run showing clearly a systolic constriction of the ostium with oval shape causing ischemia. This one is slightly away from the left main and a little bit more superior. A right ACOS catheter, that is aberrant coronary artery origin from the opposite sinus, right, is used for this. Again, this is a three-dimensional with a slightly longer primary curve, selectively able to cannulate that with wire support, able to intervene this right coronary artery. And that's the angiographic image, showing it's almost nearer the ostium of that aberrant vessel, and with wire, we're able to cannulate it. So the next one is the aberrant RCA from the right cusp itself, but coming superior and towards the left cusp. This is the most difficult one to cannulate. So once you identified it in CT scan or with your two orthogonal views, the first patient here shown is an AL with a wire and with a guide extension, here guide liner to cannulate it. So that's one way of doing it. You can have a guide, floating wire, and then guide extension, getting closer to it and cannulating. Here AR1 is used. Here again AR is used. This is a vertical origin, even multi-purpose might have worked. And this is above the sinotubular junction in the aorta itself. And in this case, Judkins right is used. Again, Judkins right is used. Here AL3 is used because of the larger root. So you will be able to decide based on the two orthogonal views. And if it's still difficult, you can float a wire and then you can have a guide extension closer to the ostium to take good pictures as well as intervene. Now this is again another one from the right superior closer to the left sinus. Here the three-dimensional catheter is used, that is the Sherpa NX balance catheter. You can see the three-dimensional, there's a primary curve, secondary curve, and then the tertiary one is almost 90 degrees, which selectively cannulates this apparent vessel. And that is the angiographic picture, and then there is a wire for support for intervention. About the left circumflex coming from the right sinus, most of the time you will be able to cannulate with your Judkins or a multipurpose, like shown in this picture. Sometimes you might go deep into the right, and when you pull back slightly and rotate anti-clockwise, you will be able to cannulate. So this is an AR, which is selectively cannulating the circumflex coming from the right sinus. And as I said earlier on, most of the times you might miss it. If it is deeply cannulated, you may not see the origin of the aberrant vessel, and you have to predict from the left system if the left main is long and if there is not much vessel coming towards the circumflex territory, then you have to have a prediction. And then once you've done the right, you just pull back. Here in this case, a wire was used to push the catheter out, and the second wire is used to cannulate the aberrant vessel, and then selective image is taken. So this is a wire supported technique. The posterior origin of the left main from the left sinus, that is below. Unlike coming here, it's coming posterior and below. Here you can still use a backup catheter and then push it with a wire to open it, and you'll be able to cannulate it, as shown in this angiographic picture. So it is selectively cannulated the LAD, and then with your wire, you're extending the primary curve, and you are able to cannulate the circumflex. Now, coming from the non-coronary cusp, like in this one, if the left main is coming from the non-coronary, you will be able to cannulate with a multipurpose or a Judkins. Sometimes you may need a flotation wire or a guide extension. In this case, it was selectively cannulated with the Judkins right. The total left main coming from the right cusp, it might take three different courses. The first one here shown is anterior to the pulmonary artery. You can see the bend. The second one is posterior to the pulmonary artery. And the third one is between aorta and pulmonary artery, which looks almost straight. So in the RAO caudal view, you'll be able to see all these three appearances, and you'll be able to have a prediction whether it's going anterior, posterior, or in between. Sometimes if you are in doubt, if you are doing a right heart catheter at the same time, you can leave the swan gowns or the right heart catheter. The RA view is not showing that, but when you go to the lateral view, it is very clear that the left main is curving around the pulmonary artery and then taking the course. Here it is shown clearly in the CT scan, origin, curling around that and then taking the course. And we'll see that in this live picture now. So it is taking the origin, course, and then curling around. So you can use that as a marker as well. And this is interarterial course, which almost looks straight. And in the CT, it confirms it is running in the muscle. And the JR4 is cannulated. Now this interarterial course, it is dividing in the septal level and the LAD is descending down. So these are the dangerous ones in terms of the sudden death and ischemia. And this is the picture representation of the 3D dimension of the Sherpa index balanced catheter. The other techniques that can be used is multiple wire support. So here, obviously, the Judkins is used, which was not able to cannulate. 3D RCA was used, and then 2 wires are used. Still, there was not support. So third wire was used, and PCI was completed. So that was in the same vessel, 3 wires, 1, 2, and 3. Here, 2 wires are used, one in the RCA for support, and then the other one in the vessel that has to be treated, the aberrant vessel, and the PCA was completed. The other technique is long wire and exchange technique. Sometimes the diagnostics will cannulate it closer to the vessel. Once you get it, then you exchange over a long coronary guide wire to the catheter of choice to get the full support before you do intervention, ballooning and stenting. It's the same here, diagnostic catheter, wired, JL catheter, and then exchange for extra backup catheter to complete the intervention. Deformed guiding catheter technique. Here you can use with steam heating or without. Here it is just simply hand sort of right angle creation of the Judkins catheter into 3-dimensional shape. And following that, the PCI was completed and the lesion was stented. Sometimes it may not retain the shape you are making. Then you can use steam to create the shape, and then you immediately immerse it in the room temperature saline or cold saline. Then the catheter will retain the shape, and then you can use it to cannulate selectively and complete your PCI. Floatation wire technique, usually it needs 2 kind of operators. You can keep the catheter closer to the origin, and the second operator can float the wire. Once the wire is floated into the vessel, then you can get it closer, or you can use a guide extension, and then you can complete the PCI. This is another one. Amplats, guide, balloon support, taken nearer, and then stent, and then completed. So this is balloon anchoring. This is another balloon assisted catheter engagement. So the Judkins is taken to the anomalous right, wire is placed, and then a distal balloon is placed. With a distal balloon, it is changed, and closer to the origin it is taken in, and then PCI is completed. You can use microcatheters or catheter extensions or mother-in-child catheter approach. As I shown here and published, severely dilated aorta, catheter was not reaching, so guide extension heart rail was used and wire was used. And following that, we were able to cannulate the coronary, which is a completely distorted aorta and more anterior and higher above. The same technique can be used for the right coming from anterior as well. And sometimes you can use a mother-daughter, granddaughter technique. That means 2 guide extensions, an 8, inside that 6, inside that 5, to reach out to the very sort of superior and higher origin aberrant vessels. In this case, it is coming from the posterior non-coronary sinus. It is cannulated with a right Judkins or multipurpose, and then a guide extension and a microcatheter was used to cannulate it and successfully complete the PCI of this occluded mid-right, as shown here. So one slide about where you need to intervene for these aberrant vessels. You have identified the aberrant vessels. So if there is ischemic symptoms, or if you have shown ischemia, or if you have shown IVS, a slit-like opening, then that particular artery might need intervention. And depending on the anatomy and area involved, you can either go for surgical intervention or PCI, and you might need a sort of additional guide extension support if you are using PCI techniques. So in conclusion, the aberrant or anomalous origin of the coronaries is challenging, even though it is rare when it happens. In elective patients, you can do a CT, identify exactly the origin, and then before the procedure, have a plan of action of catheters that is going to be used. Acute cases, you can take two orthogonal views, and as I mentioned, have an algorithmic approach of catheters that you're going to use, and techniques like wire, multiple wires, guide extension, microcatheter techniques. Radial access might sometimes help for the right coronary arising from the right sinus towards the left, higher and superior. So your hardware, your technique, and operator experience is important to complete such procedures successfully. Thank you.
We have spent a lot of time on the first lecture because of glitches. Is there any question or comment? We can take one. Any comments, or if there are one? Yeah.
Actually, this kind of patients are definitely challenging. He has presented well. Just in two situations, we may face too much of problem. If these patients come with an acute coronary syndrome, particularly STEMI, particularly in odd hours, that is another one problem. And second thing, if the patient is having anomalous origin along with there is a CTO, that will be a challenging thing. Any highlight from Dr. Anantaraman regarding how to tackle CTOs in this situation? If the origin is anomalous and there is a CTO, what kind of support will you prefer?
Absolutely. It's a fantastic question, sir. Thank you. And I think the acute patients, when they come in, especially if you're going to primary, as I said, if you have a biplane lab, then you take two orthogonal views. You can identify which catheter a single plane lab, you take two orthogonal views, and again you can identify whether it's below the left main, above the left main, or where it's coming from, and then decide, as I showed in the algorithmic view. Now the CTOs is a different animal altogether. I think most of the CTOs we do it in the elective setting. So in that cases, I tend to do a CT to identify the course and everything. And most of these cases, you will end up using microcatheter dissection re-entry techniques and two operators, where you have to use a good guide catheter support. Sometimes you have to go for a, that again helps in terms of the support. And the guide extensions, they are fantastic in those CTOs. Again, guide extension can be taken up to the occlusion point, then wires for a set of dissection re-entry, and then kind of pre-cross. So those are some of the things which you can use in the CTOs.
Okay, thank you. I think we can go to the next presentation, Dr. Bhandari.
Yeah, I think sure. So we can have Dr. Pratap Kumar to give us the talk on CTO, how to start and when to stop. Dr. Pratap.
CTO PCI, how to start and when to stop is the topic today. When you have a selection of a patient, you should understand that you should have a dual angiography, CTO tools and imaging, CTO crossing strategies, and when to stop. How do you select a patient for a CTO PCI? There are data. Treating CTO after STEMI does not improve LV function. CTO PCI stumbles for the stable CAD patients with the chronic total occlusions. But there is one important data in 2017, EuroPCR produced better quality of life for patients with CTO PCI compared with the optimal medical therapy. So the patients with an extensive ischemic burden and no residual ischemia after CTO PCI had lower rate of all-cause death and acute non-fatal MI. So the point is, in 2017, a CTO PCI for refractory symptoms remained highly appropriate for regardless of the risk assessment. CTO PCI did not lead to an improvement in survival or in MACE, but It resulted less angina and a fewer target lesion revascularization compared to optimal medical therapy. So when you go to the primary indication of CTO PCR is an ischemic symptom improvement. In an asymptomatic patient, I should think that you should have a high threshold for doing a CTO PCR. Why do I attempt for an open CTO? One, it is improving the quality of life. Second, an improved tolerance for future ischemic events. These are the two important points. Whenever you do a CTO, you should actually have a dual coronary angiogram. The most powerful technique for the technical success and reducing complication to understand the CTO complexity, and it improves a procedural safety. When you go to the angiogram, a dual injection is done. You may be seeing an ambiguous proximal cap, a poor distal target, and appropriate intervention collaterals. If it is there, you should go for a retrograde intervention. Otherwise, you should go for an antegrade intervention. Antegrade can be two methods, antegrade wiring and antegrade dissection re-entry. In the retrograde also, you have a retrograde dissection re-entry and retrograde puncture. In antegrade dissection re-entry, you have two things. One, a control, one is a stingray using, other one is a wire-based strategy. So in angiographic plan, what are the plans to be done? We have four things to be looked into the angiogram. One, you should have a proximal cap and the lesion, and third is the distal vessel and the collaterals. In the proximal cap, you will look for the tapered cap or a blunt cap or an ambiguous cap. If it is a tapered cap, it's a proximal cap localization is by dual injection. You can actually use a selective contrast injection to the microcatheter near the proximal cap, or you can use an intravascular ultrasound, and people may use a CCTA co-registration. Basically, you should understand that the penetration wires are used, actually blunt proximal cap in heavy calcified at proximal cap and presence of a side branch at a bridging collaterals at the proximal cap. In ambiguous proximal cap, the two things that are important, it should be an image guided. It can be CT guided or IVUS guided. In a tapered cap, you can use an antegrade wire escalation is the most successful thing. And actually we tell that a low or medium tip load wire with a polymer jacket is useful is a loose tissue tracking. In a blunt cap, it usually associated with the side branch at the cap, and anterior wire escalation is challenging and penetration wires are needed in blunt cap. In the lesion length, course and composition, you have to be overestimated with antegrade only by injections. Dual injection of the pre-procedural CCT is the correct assessment of the length. More than 20 millimeter CTO length, tortuosity and calcification, ADR is more likely to be required. In the distal vessel, what are the things we are looking for? In ideal for a CTO PCR, a larger caliber vessel is important because then it's free from major side branch that is good for our CTO intervention. In a post-CABG patient, distal CTO caps are more calcified and resistant to guide wire penetration. Distal cap is more or near to the bifurcation of a significant side branch. It's one of the toughest things in CTO where ADR may close the side branch. In a collateral circulation, for determining the feasibility of retrograde approach, collaterals are important. You may take a AP or RAO with a cranial angulation with the septal collaterals, but you should understand that a caudal projection is important for entry purpose. A predominantly collateral may change over the time before the procedure or during the course of the PCI, shifting collaterals. So always important that you should carefully study the previous angiogram for multiple potential collateral pathways. Size, tortuosity, bifurcation, angle of entry and exit to the collaterals, and distance from the collateral exit to the distal cap are the important thing in collaterals. When is coronary CT angiogram is required? Number one is actually to identify the simultaneous angiogram shows proximal cap, retrograde collaterals, and length of the occlusion. The further imaging is to delineate the anatomy in CT angiogram or CT or MRI. CT angiogram actually, the calcification more than 50% of the vessel actually predicts the failure. One is actually calcification more than 50%, bending more than 45 degrees, multiple occlusion, shrinkage are the indicators. And CTO, there are lot of the score called CT vector score, and very difficult is more than 3, and likelihood of success within 30 minutes is 20% only. And CTO tools we have to discuss. We have sheath, guide catheters, Y connectors, guide catheter extensions. You have microcatheters, guide wires, dissection re-entry equipment, snares, uncrossable and undilatable lesion equipment, and complication management equipments. We should always see to that in a retrograde seating intervention, maintain the ACT for more than 300 to 350 seconds. In antegrade, you can keep 250 to 300. A covered stents and coils should be available to treat larger vessels and distal vessel perforation. How do you minimize the radiation dose? You can use a rate fluoroscopy, low frame in fluoroscopy. You can have a fluorostore can be used instead of a cine. You have a collimation to be adjusted and minimize the distance of the image receptor from the patient and intermittently change the position of the image receptor during the procedure are important to reduce the radiation dose. CTO crossing strategy. You have an initial crossing strategy. The antegrade is preferred over retrograde because high risk of complication with retrograde approach and need for the anticoagulation preparation even when the retrograde approach is eventually required. All are complementary. Antegrade wiring, antegrade dissection re-entry, and retrograde approach, all are complementary. When you just see an Asia-Pacific algorithm is actually totally, you should understand that a careful analysis of angiogram, proximal cap ambiguity, you have to go for IVUS guided, and actually poor quality distal vessel, you have to go for intervention collateral present retrograde approach, and otherwise you go for an antegrade wire-based approach. Antegrade wiring, a tapered or the proximal cap or with a visible channel, you can use a polymer jacket wire. At the blunt cap, you have to use for a forced polymer jacketed guide with intermediate penetration or a composite core guide wire. A highly resistant, you have to use a high penetration stiff wires. Stiffer wires actually ranging from XTR to Confianza Pro in between Gaia first, Gaia second, Gaia third actually takes the lead nowadays. Microcatheters actually can be two types. In the antegrade approach, you have a pushable microcatheter, rotatable microcatheter. Pushables are fine cross and MCath, which is available for fine cross in India. Rotatable microcatheter is Corsair and Turnpike Spiral. In a retrograde approach, you can use a Corsair and Turnpike actually rotatable microcatheters. Otherwise, in epicardial collateral, preferably to use a Caravel or sometimes Turnpike. Antegrade approach, we can use a filter X3 or a 5-3 filter X3R. Then you can go to Gaia second or Confianza 2. If the course of the occluded vessel is unknown, you can take a pilot wire. Retrograde crossing, I usually use a Zion, and you can actually go to SUO3 as well as sometimes X3R. And externalization always done by RG3 wires. Change of the crossing strategy. Flexibility is important in success, safety, and efficiency of the CTO PCI. Avoid getting stuck in a single strategy. This is very important. Only 50 to 60% of the patients can have a success if you use only one strategy. So indication for a different purpose, actually, the primary approach is bifurcation of the distal vessel and difficult to engage the CTO vessel, a flush aorta occlusion, diffusing disease vessel. These are the primary retrograde approaches required. Retrograde wire escalation, you know that short occlusion, actually, we can use less tapered distal cap, you can use a wire escalation. Otherwise, you have to do the reverse cart or confluent balloon technique used to be used. And marker wire for antegrade wiring. You can have an antegrade wire, then you can pass the retrograde wire using a antegrade wire, marker wire technique. Before starting retrograde, two things to be important. Assess the risk of ischemia. That is actually lesion at the donor vessel proximal to the collateral vessel is important. We have to correct that, then only you can go for the retrograde approach. And a dominant collateral, especially a single collateral, the actually risk of ischemia is very high if you use a single large collateral. Donor vessel, keep a guide wire in place as a safety measure, always when you do an angioplasty on a patient with retrograde approach. Be clear about the collateral anatomy. You have a selective injection of the contrast into the collateral. You can have a selective injection that is called tip injection or a balloon occlude to make the collateral to see very clear if there is an interventional collaterals are not clearly seen. Selecting the collateral, larger or non-tortuous collateral to be collected. When unfavorable or non-interventional collaterals provide dominant blood flow to the CTO. You can actually, there are three things actually, tortuosity, tamponade risk, wiring difficulty, able to dilate. These are the points. Most important thing is epicardial collaterals are difficult, especially able to dilatation is not possible. Otherwise, you should understand that the central collaterals can dilate. Preferred collaterals, actually central collaterals are very good, especially shorter route to recipient vessel, less tortuous, less chance of tamponade, can be dilated with the small balloons. IMA grafts, when only no other options left, only you have to take this one. Intracoronary imaging is very useful to understand, especially IVUS, to resolve the proximal cast ambiguity. confirming the distal true lumen wire position and facilitate the re-entry into the true lumen after subintimal tracking. IVUS guided proximal puncture, actually this is the technique to be used. IVUS in the PCI, retrograde wire crossing and reverse cartilage is very important IVUS. IVUS guided before stenting and after stenting to understand the length, morphology and lapping storm before stenting, after expansion, apposition and geographic limits can be identified. So in conclusion, actually IVUS is a very important tool for understanding. Assess the probability of success by failure and success. Actually, you should understand these things. Complication, lower success, more complication versus other complex PCI in CTO. So you should understand that all registry, the success rate is ranging from initially 50%, now it is ranging up to 90%. Now my success rate is only 87%. Overall technical success is 89% in various studies. To balance the possibility, you should understand the complication. Complication and success rate to be identified as a balance with operator experience, skill, and selection of the case are important. You should understand that angiogram success, actually different studies showing these things. Very important. Death, urgent cabbage, stroke, tamponade are the most common things. How to select system? Use scoring system, likelihood of success and complication, better case selections. JCTO score is actually more widely used. If the person is not experienced, better JCTO score more than 2 not to be tried. This is very, very important. So more than 3 is a success only 70%, even in the best hands of the world. Other scoring systems are also available in the world. More accurate in antegrade. These scores are similar predictive capacity for technical success, more accurate in antegrade, not in retrograde. And you should understand that operator skill is very important. You should actually start with antegrade wire escalation stage 1. Second is actually you can do the ADR. Third is actually retrograde, and lastly with the epicardial collaterals. Reasons to stop a CTA PCI: occurrence of a complication, number 1. Number 2, high radiation dose, more than 5 centigrade is very, very important to stop the contrast procedure. Number 3, large contrast volume. You should always calculate eGFR into 0.3, 0.7. If your estimated creatinine clearance is into 3.7, if it is more, then you have to stop it. And lastly, exhaustion of crossing options or the patient or the physician fatigue is to stop the reason for CTO PCR. Thank you very much.
Thank you, Dr. Pratap, for a wonderful presentation. I hope the slides would have been slightly better. But anyway,
okay, sir. Actually, what I could do is that actually it's a recorded one. I was ready to present otherwise, so it's okay, sir.
Yeah. So anyway, it was a wonderful talk, and I think any comments or questions from the coordinators, moderate, and the expert panel, please.
I think most of the points are well discussed. We should move forward for the next presentation because
we are behind time. So I think we should invite Dr. Anil Dhal, for his talk on optimal stenting technique for complex lesions. 12 minutes, Dr. Dhal.
Yes, so it's thank you, Dhiman, and thank you, CSI NIC, for this opportunity. Of course, my friend Dhiman does give very complex topics to be covered in 10 or 12 minutes. Hats off to both the previous speakers for having done a marvelous job, despite the fact that sometimes the acoustics and sometimes the visuals didn't really match up. But I guess we are all learning, and things will only improve. So he gave me a topic saying optimal stenting techniques for complex lesions. I mean, I think that's all of interventional cardiology. So I just couldn't think of what the hell am I supposed to do. The principles of angioplasty remain undisputedly to try and obtain a scaffold from a normal segment to a normal segment, which means less than 50% plaque burden to less than 50% plaque burden. But we start by identifying the morphology of the plaque and to see whether there is any calcium which requires modification, whether there is any thrombus, which requires special treatment or special pharmacology, we have to identify distal proximal landing zones, targeting the normal segment, and then we go ahead and perform some measurements. Measurements can be angiographic, can be by imaging techniques. We need to identify what is the diameter of the stent we will use. And very clearly, because of the fractal nature of the coronary flow, we will size the vessel by the stent by the distal vessel. Now, if we are using imaging, we have to see whether the EEL can be identified to allow the vessel diameter measurement, yes or no. And if you can, then you come down to the rounded the EEL diameter to the nearest stent size. And if you cannot, then you take a mean luminal diameter, and then you determine the stent length by measuring the distance from the distal to the proximal. And post-stenting, you would do a non-compliant balloon sizing determined based on the proximal reference vessel measurement. So now we are going to talk more about the proximal vessel size once we are post-dilating, and we should try not to over-dilate a vessel for fear of rupture. Now, again, in an image-guided implant, we see that they should be angiographic success, and you should have a post-dilatation based on pre-PCI sizing, intravascular imaging sizing. We can follow it up with a post-PCI intravascular imaging. We should check whether our target MSA criteria have been achieved. The target MSA should be both checked in proximal and distal segments, which is closest to the relative reference segment. Optimal should be more than 90%, and acceptable is more than 80%. And then again, we should do a post-dilatation and look for any reference segments which may have any major dissections requiring the necessity of an additional stent. And we look for residual lesions, for example, in a geographical miss, which again may require additional stents, or we look for any other reason for additional PCI, and an operator-determined optimization followed by a final intravascular imaging. So, however, this is only when I am making it imaging and angiographically based. But the results of the defined PCI trial, which according to me in the last 3 years has been one of the most important trials which has come in interventional cardiology, showed us that physiologically 1/4 of the patients leave the cath lab with post-PCI residual ischemia, which even if the operator determined or thought he did his best job, he thought it was angiographically successful. There are many causes about this. It could be diffuse disease, which is not angiographically apparent. It could be geographical miss. It could be inadequate lesion coverage. You have not gone healthy to healthy. It could be stent underexpansion and serial stenosis. So the IFR used a blinded IFR pullback, the defined PCI trial, and realized that 81% of these were focal stenosis, 18% were because of diffuse stenosis, 2/3 of these stenosis were proximal or distal to the stent, 1/3 were within the stent, and it gave us an opportunity to improve our results. And if you realize that just by using a physiology-guided post-PCI intervention, we could reduce the residual ischemia from 24% to 5%, which gave us another 79% benefit. And this then went on and improved our results. Now, really, intracoronary imaging and physiology are like glasses for modern interventional cardiologists who do not like blind decisions. And we should have some defined criteria for stent optimization. There's a beautiful review in Eurointervention. These are the European guidelines, which actually came 2 sets of reviews. And this is one is by Lawrence Raber and the other is by Tom Johnson, which actually showed this very beautiful cartoon, which means that we find out how much we have dilated our vessel, and what is the relative stent expansion, what is the stent area we have achieved. So if we have a stent area of more than 5.5 in non-left main, and more than 8 in a left main lesion, we apparently have done a reasonably good job as long as we have a relative stent expansion of more than 80%. There should be no malapposition of more than 0.4 millimeter in distance and 1 millimeter in length. There should be no protrusion of tissue, and this could be a cheese grater phenomena or a tissue prolapse. There should be no dissection, especially proximal or distal, which is anywhere more than 60 degrees, and the flap should be limited only to intima, which should be less than 2 millimeters in length. These should not have such a major intramural hematoma that the moment you pull out the wire, the vessel closes. And this is a very clear graphic which we can put in our day-to-day practice. And for different sizes of stents, we can then make out what are the appropriate size of MSA that we would like. However, we are here to discuss complex PCI, and complex PCI can be a huge topic. It can cover CTOs, bifurcation, trifurcation. It can cover vein grafts. It can cover small vessels. It can cover left main. So bifurcation, we should try and keep our bifurcation principles simple. A KISS principle, which is keep it simple and safe. Obviously, we should try and wire both branches, limit the number of stents, and again, aim for well-apposed and well-expanded stents with limited overlaps. You can choose your technique. Depending on the setting, you should choose either a T-tap or a Culo and DK crush. I know that currently we are all inclined to use a lot of DK crush, which can be given in all comers, and also in some particular, if you have equal size of vessels, we can use a Culo. However, if the separation is more than 90 degrees, we still would use a tap or a T technique. In all these techniques, we would have to do a proximal optimization, which is required because we are placing the stent according to the distal reference diameter, but to optimize the proximal main vessel and to also assist to recross, and also to decrease the number of cells covering the side branch orifice and guide and facilitate the re-entry of the wire into the side branch, we do a pot. But there are many confusions about which balloon, compliant or non-compliant, semi-compliant or non-compliant. We used to use extensively non-compliant, but now there are more and more recommendations that we should be using semi-compliant balloons, and that may be a more favorable way to go. And also we should definitely, many people cannot place this in a cartoon, it should be very clear that it will be difficult to do it in real life, in a 3-dimension. So we must make sure that the stent is long enough to allow for proximal optimization, and we should actually have the proximal optimization balloon, which is ideally something like this, which does not cross the side branch, wherein you could then be creating a carina shift. It should also not be too proximal, by which you would be getting proximal stent dissections, and definitely not too distal. So all this is something which we must factor. In a side branch, there are studies using drug-eluting balloons, which may be feasible, may minimize metals. There are some labs which are using a lot of drug-eluting balloon. Unfortunately, in our country, a drug-eluting balloon, it costs about 2.5 times that of a drug-eluting stent. Well, we used to say we should KISS, and apart from the obvious answer, the idea is to recreate the carina, prevent a carinal shift, and so we must be careful about using the wire crossing appropriate to the technique that we have planned to ensure that we have less major oval distortion in the vessel. Now, despite the fact that clinical data may not support routine kissing balloon inflation, now with ultra-thin stents, we know that with short balloon overlaps, kissing inflation has decreased the target vessel revascularization. There is a risk of aggressive kissing because you can create a proximal bottleneck, and you can create a proximal edge malapposition, and you can deform a stent. But one has to be careful and use simple rules and understand how we have to size the vessel by Finney's law in anybody in whom we have to use this. There was an advocation of a pot side pot report strategy, which meant that we thought it was making it simple, but it is probably less simple than theorized. And pot side report allows you to probably use a drug-eluting balloon in the side branch and then continue to perform 2 pots. But the final pot is more important to ensure that the proximal stent is more cylindrical than otherwise. So the pot side report, again, could be image guided for even better results. When it comes to the left main, we understand that the left main anatomy, the identification of the ostium, 10% trifurcations, potential for guide wires to go behind, and a very low chance of accepting mistakes means that we should have a low threshold for using imaging optimization. Kang's rule of 5, 6, 7, 8 are very popular, but this is the bare minimum. We can also use OCT to actually check where we are exactly, whether we are using distal wiring in T-tap and QLO or non-distal wiring in, say, DK crush or any crush technique. IVUS optimization, the distal vessel with the distal reference segment, ensure adequate apposition, ensure adequate expansion, and to avoid stent deformation. I will just show you a few cases of left main trifurcation. I'm cutting out all the theory because the shear stress of stents is very important, and we must respect port, proximal, optimal main vessel optimization, and maybe a final kissing balloon. Inner trifurcation and a left main trifurcation, there will be challenges with trissing. So here are some cases, a very simple case of a trifurcation with a kind of disease in all the vessels. Very simple 8 French guide. We must respect our axis, wire all the vessels, predilate all the vessels, and go ahead and perform your first stent, exchange your wires, recross. Make sure that if you are using a tap technique or a T technique, then you are using a distal crossing, and this is a pre-tris. And here we go ahead and do a double tap and finish with a good result, and we confirm the same on imaging again that this is a good result. So this is another case. Similarly, severe triple vessel with severe involvement of all 3 vessels. We create kissing inflation after stenting of the left main towards LAD. After kissing inflation, we actually check the physiology, find it to be significant, and then again a double tap here with the trissing and IVUS optimization. But sometimes things don't go well. Here's a case which went bad. Here's a patient who presented with an inferior MI. His right coronary was fixed, and he had a peculiar lesion in the circumflex, the ostium of the ramus, and somewhere in the LAD. So next day, the LAD was fixed, and the operator, it's my team only, I have vicarious responsibility. So he pre-dilated the ramus and then decided to stent it from the ostium. But when he was trying to do the circumflex, he could not deliver a 2O balloon, and then he sounded an alarm. We rewired it and tried to do some image optimization. Unfortunately, the IVUS on that day was not working, and with great difficulty we could deliver this stent. So we first decided to do a kissing inflation of circ and ramus, and then we went ahead and performed a direct stent of the distal, and then came back and actually we were trying to do a precise placement but converted it into a crush. But at the result, as of the very nice dog, that boxer dog that Pratap had shown, there was so much of fatigue, and after this, that people did not bother to go ahead and perform a kissing balloon at this time, but the angiographic result appeared satisfactory. Unfortunately, this patient defaulted on his DAPT. He was getting it from some panel and did not take it for 5 days, came back with a stent thrombosis, all 3 vessels gone. All hell was raised. We did not know what to do. We could not see the ramus. Went ahead and blindly wired the ramus, wired the LAD, wired the circumflex, sequential pre-dilatation, opened the struts. Now we know that we had stents in both the ramus and the circumflex. but now the LED was also compromised. So we actually ended up doing a tap to the LED because the left main already had a stent. But we could not do a tracing, and this time we were very reluctant to come out either without an imaging or without delivering. So we did not know what to do. So what we did was we took a second guide, and with the second guide we managed to do a tracing, and where it became very easy, and we had a good result. And with this good angiographic result, we further confirmed it on imaging and actually finished this case, and he's had a follow-up of a reasonable length of time. I picked up this courtesy Dr. Kunal Mahajan from Shimla. I saw this on Twitter 2 days ago, and he actually posted that sometimes it can be a challenge in trying to do a pure ostial stent placement. You may think about doing a crossover. I end up doing a crossover most of the time because we don't have flash balloon, floating guide wires, Zabo, stent pullback, simultaneous IVUS, or almost always leads to a kind of a question in our minds, especially if you're not doing imaging in all cases, and we may have to convert to a two-stent technique. So he posted a very nice case. So you can actually have a hexaflocation like this, which I'm leaving as food for thought for people. So if you are doing a left main trifurcation, we should be very careful not only about all branches, but also about mechanical circulatory support, DAPT, and antithrombotic diligence, and try to finish with tracing, and because it can be challenging, and we should not read any bad results. So thank you very much for your kind attention. If there are any questions, I would like to take them.
I don't know, we are actually 7 minutes ahead, overshot your, we gave you 12 plus 4, 16 minutes.
So that's all right.
6. So I think we'll leave the questions because we
thank you, sir. No problem.
Still have 2 talks to go ahead with, and we are. So can we have Dr. Saibal give us his talk on common cath lab mistakes and how to avoid them? Until the time he joins, he puts his slide. If there's any question for Dr. Dhal, I'm sure he will be happy to answer. So do we have Dr. Saibal?
Dr. Dhal, can you...
Dr. Dhal has to exit. You have to stop screen sharing, please. Dr. Dhal, please stop your screen share.
Okay, 1 second. I have already stopped.
Good afternoon. At the outset, I would like to thank the organizing committee of NIC for giving me this opportunity to give a lecture on common mistakes in the cath lab, how to avoid them. Now, as we all know, to err is human and we all commit mistakes. But at the same time, we should remember that cath lab work is a teamwork, and to avoid errors, a trained team is required. Now, whenever a patient walks into the cath lab or we are planning for a procedure, the first thing that should be seen is that whether the specific procedure that we want to do has been explained to the patient and it has been notified in the consent form. Along with that, the risks and the benefits of the procedure should also be explained to the patient, and we must also check whether this has been documented. And the third most important thing that needs to be documented is the known reported complications, and this should also be explained to the patient in details. And if possible, sometimes we can help the patients by showing visual aid of what exactly we are trying to do. Now, there are 3 areas where we can make mistakes. This can be either patient-related or related to the drugs which we need to administer, or procedure-related. And briefly, I'm going to highlight some of these areas. Now, whenever you are taking a patient to the cath lab, you have to take a vascular access and you have to give an antithrombotic drug. So you must assess the baseline bleeding risk of the patient. This will help you to select the access site and also to tailor the anticoagulant regime. Now, there has been number of methods to assess the bleeding risk, and the most recent one is the Academic Research Consortium recommendation, in which different factors, clinical factors, we can consider to assess the bleeding risk, like the age of the patient, whether he has renal disease, liver disease, whether the patient has anemia, thrombocytopenia, whether he has any history of spontaneous bleeding, past history of ischemic or hemorrhagic stroke, or the patient is on oral anticoagulants, and so on and so forth. And based on this, there have been major and minor criteria set. And based on applying this criteria, we can re-stratify a patient as at high bleeding risk or low bleeding risk. So once we have ascertained the bleeding risk of the patient, the next important thing we should always look or check is the renal profile of the patient. And for this, we need to know the urea, creatinine, and calculate the eGFR. This will help us to calculate the amount of dye which we can use in this patient by different formulae. And also, if the patient has a baseline renal disease with eGFR of less than 60 ml per minute, we have to give prophylactic hydration. And we can follow various regimes, normally with isotonic saline, which we can start in a standard dose and then give a maintenance dose during the procedure and continue for 4 hours after the procedure. Next, another important thing which we should always look into is whether the patient had undergone any angiography or procedure previously and he has any contrast allergy, or if the patient even has an allergic diastasis. If it is so, we should always try to give the patient pre-medications like H1, H2 blockers, hydrocortisone, and use Visipec, which is an isoosmolar non-ionic contrast agent, which causes the least amount of anaphylactoid reaction. Then all after this, we have to choose the vascular access. Preferable is the radial access, which we always try to choose so as to avoid the vascular complications, but there may be many instances where we have to go for the femoral access. So if we have to go for the femoral access, how can we make it as safe as the radial access and avoid all the vascular complications of like hematoma, pseudoaneurysm, retroperitoneal hematoma? The first thing which we need to do is to see the access site, and the ideal site is the common femoral artery in the mid of the femoral head. This should be your fluoroscopic landmark. You should avoid coming below the lower border of the femoral neck where the artery divides into profunda and the superficial femoral artery, or going above the upper border of the neck, above the inguinal ligament, where you can puncture the external iliac artery or injure the inferior gastric artery, which later on can lead to retroperitoneal hematoma. So fluoroscopic guidance should be used to do the femoral puncture. And another important point is that if we apply the micropuncture technique, whereby we do the puncture with the help of a micropuncture needle, along with which you have a 4-French sheath, and do a check angiogram to see if you have punctured at the appropriate point. If your puncture is higher or lower, then what you can do, keeping this as a marker, you can again repuncture with another micropuncture set and do and recheck. And once it is there, you can take out this sheath and apply some local pressure to obtain hemostasis. This is how you can avoid all the vascular complications while you are taking a femoral approach. Now, in radial access, we all know the key is to avoid spasm. So you can give mild sedation to the patient, adequate local anesthesia, avoid repeated punctures, and try to do the puncture in a single go. Once you have punctured, give that cocktail of vasodilators and anticoagulants. Then when you are negotiating with your wire, it should be always done on fluoroscopy. And also all the guide manipulation also should be done on fluoroscopy. And unlike in the femoral route, whenever you are withdrawing the catheters, it should be always on wear and you should not pull it out, as you may induce a spasm. And if there is any resistance while passing the wire, you must always try to look whether you are have faced some anatomical challenges like a radial loop, or higher up there is resistance or a loop in the tortuosity in the subclavian artery. In these cases, you have to apply appropriate techniques to overcome these hindrances posed by the loops, but never push through your catheter, which might cause a dissection and later a complication. Next important thing is whenever you are going to do the procedure, the most important thing is the unfractionated heparin, which we give prophylactically to prevent thrombus formation. And after we have calculated the dose which is required, you must confirm that sister is giving the appropriate dose, because sometimes there are different vials and there might be confusion. Next, coming to the hardware, new hardware is always preferred, but if you are using sometimes old hardware, you must always check the integrity of the hardware outside for bends and kinks, and you must be ready to face some complications as this old hardware may not follow your commands. Like in this case where we're doing a root angiogram to profile an RSOV, after the RO view, when we took the LAO view, see what happened. The pigtail catheter broke and it is in the aortic root while the shaft has migrated into the LV. So next, it migrated into the descending thoracic aorta and we had to snare it out. Next, again, while doing a coronary angiogram, after doing the angiogram, we saw that the tip of the catheter is lying within the RCA. So then we had to pass a wire and then a balloon had to be inflated and we had to snare this catheter, this broken piece out, and you see there was a normal angiogram. So these are the problems. Next basic thing we should remember that without seeing the catheter tip pressure, we should never inject. Either there may be damping or there may be ventriculization, and you must ascertain what the cause is, but never push dye. And if dye was pushed, here you see the catheter is not coaxial, it was touching the roof, which must have caused damping. And as the injection was made, there was dissection in the left main with sticking of dye, and an emergency bailout angioplasty of the left main had to be done, where you have to put a stent from left main to LAD. Now, again, if you don't see the damping, and you may also inject air, which at times can become also fatal. So another important thing when we are doing angioplasty, sometimes after doing primary angioplasties, here the artery was opened up and there is significant residual stenosis, but as much calcification was not appreciated, the stent was deployed. But you see that part of the portion of the stent where no balloon dilatation was done is under expanded. And so instant dilatation was done with a high pressure balloon. And what happened, you see, there was a perforation. So now, after the stent, as you had not prepared the lesion, now you have to either do a prolonged balloon inflation or put in a stent graft. The lesson is adequate lesion preparation is a must before stent deployment. And another important thing, while we are doing primary angioplasties, sometimes we use high penetration power wires or polymer jacketed wires. And I feel once the role of this job of the wire is done, that wire should be routinely taken out and rest of the procedure completed with the help of an floppy tip wire. But if you sometimes continue with these wires, there is always the risk of distal perforation. And before taking out, you should take a check shot to see whether there is any distal wire perforation. As in this case, there was a distal perforation created by the wire tip. So if you do not detect this, 2 or 3 hours later, patient may come back with cardiac tamponade, where you have to then deal with the tamponade and also seal the perforation. So to summarize, in the cath lab, the work is mostly mental and no need to exert physical force. Control the catheter, don't let it control you. Never advance catheters or wires without fluoro. Never push against resistance. If there is pain while manipulation, it indicates a problem and do not ignore it. Obtain always back bleed before injecting, and this will help you to avoid air embolism. Never take anything for granted. Availability of all the material for managing common complications should be available with the techniques you are aware of. And whenever you face a complication, always work as a team, communicate with others, and never leave the cath lab without addressing all issues emerging during the procedure. Sometimes mistakes can help you to also discover new methods. As Dr. Sones in 1958, while doing an aortogram, their catheter migrated accidentally into the right coronary artery, and he could see that the dye injected led to beautiful visualization of the right coronary artery, and that ushered in the error of coronary angiography. So we should not cry foul when some genuine error happens in the cath lab, as sometimes we may also innovate from these mistakes, which can help us in future. Thank you.
Actually, I'm Dr. Ghosh speaking.
Please, Dr.
We
Ghosh.
should know that dye allergy is a common phenomena. I don't know that each and every labs follow it routinely, whether it can be recommended to test the dye allergy test before starting the procedure. Sometimes we have seen patients who die in anaphylactic shock.
Good afternoon, everyone, and a big thank you to the CSI NIC.
Done. Do you have any comments or help guidelines, please?
Routine recommendation. Am I audible?
Yes.
Okay. So there is no routine recommendation, but you should definitely take the history. And if there is a history of dye reaction, or more importantly, leaving aside dye, if your patient has some allergic diastasis, like he is an asthmatic patient, there also you should suspect that they are at increased risk of dye reaction. And if you are doing an elective procedure, the recommendation is you can give oral prednisolone, either oral prednisolone 3 doses, or easier regime is to give around 40 to 60 milligram at night and then repeat the same dose in the morning, and give 50 milligram of diphenhydramine hydrochloride orally before the procedure. And you can also give H1 and H2 blockers. That is the recommendation. And if it is developed acutely in the cath lab, or
whether it should be recommending that dye should be tested each and every patient.
No. There is no recommendation that you have to test. If you have a history and if a patient even had a dye reaction, you can avoid. It doesn't mean if you had, you should know the type of dye which had caused the reaction. And the least reactogenic has been this Vesipec. So if you have to, even if there was a dye reaction, you can do a procedure. And before the procedure, the pre-medications recommended either orally or IV, you can also give Avil, diphenhydramine hydrochloride, hydrocortisone, H1 and H2 blocker, and use Vesipec. And be prepared with epinephrine. If the dye reaction occurs, then you should be able to treat it. But there is no recommendation for routine testing for dye reactions.
Okay, thank you.
So let's go to the last talk, and that is on OCT, IVUS, FFR, which to use, by Dr. Ajit Menon.
Good afternoon, everyone, and a big thank you to the CSI NIC faculty and the organizing committee for giving me this opportunity to be here with you guys, and it's a big privilege. My talk today is on the use of FFR, IVUS, and OCT, and which do you use and when do you use them. Well, what we do know is that today angioplasty has become more precision guided, and that basically means in terms of functional testing to know what lesions to treat, and intracoronary imaging as to how to strategize and optimize an angioplasty. Let's take the functional testing to begin with, and there are basically questions as to what lesions do we treat. We do know that the coronary angiogram detects only 5% of the entire total coronary tree, and the entirety of the coronary tree depends upon the integrity of not only the larger vessels, but also the mesh of smaller vessels and the microcirculation on which the entire myocardium is so dependent. Well, and all those add to the physiology of the circulation, and that's where the fractional flow reserve, which is basically a lesion-specific physiological index determining the hemodynamic severity of intracoronary lesions, comes in. We do know that FFR is measured at maximum hyperemia, and the definition of FFR is basically the maximum achievable blood flow in a stenotic vessel, which is divided by the maximum blood flow in the same artery without stenosis. We do also realize that the utility of the FFR is basically dependent upon multiple factors, and we have the FFR is dependent on the perfusion area. It is dependent upon the extent of scar tissue or a presence of normal myocardium, and also the presence of absence of collaterals in the presence of a normal myocardium and a critically stenosed vessel. The recommendation to use FFR as far as the ESC guidelines is a class 1 recommendation today, and it's recommended for those for ischemia-related lesions where objective evidence of vessel-related ischemia is not available. There are various intracoronary physiology studies which have been done in the past, and basically physiology studies on coronary artery disease, which have shown that starting from the COURAGE onto the DIFFER, onto the FAME, and then onto the FAME-2 trials, basically the undercurrent has been that patients who have functionally non-significant lesions can do well with medical management, whereas those which have proven functionally complex or functionally significant cystinosis, they do well with interventions of some sort. We also know that from the recent data that the 5-year follow-up of the FAME trial showed that there were significantly lower MACE rates in FFR-guided angioplasty as compared to angio-alone PCI. And the issue in terms, and the benefits in terms of the use of IFR, which has been found to be equivalent to FFR, and thereby extrapolating that evidence to the RFR in terms of the IFR performance. And they're shown to be mutually beneficial in those patients with multivessel disease. There's also the use of FFR-guided complete revascularization versus only the infarct-related artery in ACS patients has been a point of debate and for a long time, and now has some clarity on what lesions to treat versus what not to treat. Just a couple of examples that we see here. This is a gentleman who presented with an acute coronary syndrome, had a critically stenosed occluded obtuse marginum, but also had a visibly significant LAD lesion. Of course, we treated the OM lesion and subsequently did an RFR and FFR on the LAD, which surprisingly, the RFR came as 0.86, with a pullback showing a jump at 2 areas, one in the mid-LAD and one in the proximal LAD. Two jumps here. But the FFR that was done with 140 mics of adenosine for over 4 minutes actually, showed that the FFR was 0.82, and the decision was to leave the LAD on medical management at this point of time. Compare that with a gentleman who had undergone an angioplasty to a dominant circumflex, had the stent was occluded, came in with classical symptoms of exertional angina. LAD angiographically had borderline disease. The RCA is a small non-dominant vessel. We decided to do an RFR on the LAD to decide whether we need to treat that, and the RFR surprisingly came as 0.73. The RFR on the circumflex also was 0.88. Decided to treat both the lesions and gave the options of treatment to the patient. Another gentleman who came with the lateral wall MI, RCA, and LAD lesions, both of which turned out to be significantly normal as far as the RFR is concerned, treated with only the circumflex, and followed up the patient medically, doing well. So in terms of the studies that we know that RFR is 94% accurate versus FFR. In coming to the question of intracoronary imaging, how do you strategize and optimize PCI using intracoronary imaging? We do know that the advent of IVUS and OCT has helped us with respect to the resolution of the coronary vessels. Intracoronary imaging definitely has improved the quantitative grading and of the vessel quality and the plaque distribution, as also the extent of calcium distribution, and with OCT, the calcium thickness, and also the distribution, localization, and the volume of calcium that is there. We do know that in the absence of intravascular imaging, you can end up with certain issues related to stent under expansion, longer procedures, malapposition of stents, and thereby leading to increased complications, increased MACE events after the procedure. That angiography alone will not pick up calcium is well known, and IVUS and OCT together have almost a significantly similar rate of pickup of calcium, depending upon the experience of the operator. Most of the outcome studies and the outcome data shown in randomized trials has been with intravascular ultrasound. And we do know that most of these have shown that the use of intravascular ultrasound significantly leads to better MACE events, lesser complications, and better acute results in these patients. We also have studies which show that compared with standard coronary angiography, the use of intravascular imaging techniques during PCI reduces the risk of cardiovascular death and major adverse cardiovascular events. And this has been significantly well shown in this graph, in the graph here, where it shows that compared to IVUS or compared to angiography alone, these imaging modalities definitely have a better result. There are certain studies with the use of OCT in terms of outcome data, the Illumin 1, Illumin 3, the CLI OPCI-1. All of these show that when you use OCT to guide an angioplasty, you end up with a better stent expansion. You end up with a better decision making in angioplasty. And also, these patients do end up with lower MACE and than patients with non-OCT or non-IVUS guided interventions. The Optico trial in India was also showed that there was a significant amount of decision making with change with the use of OCT. The Pan-London registry, PCI registry, a registry of angiography alone versus angiography plus optical coherence tomography, also included IVUS guided PCI patients, showed that the use of IVUS guiding or the use of OCT was definitely associated with improved MACE rate and improved long-term survival. If you look at the images with IVUS and OCT, I think there's little much to choose today, depending upon the expertise of the operator, whether you choose a patient, whether you choose to use an IVUS or an OCT. Though I feel that in terms of stent edge dissections, in terms of the extent of calcium, the thickness of calcium on the calcium arc, and also in certain situations like stent malapposition, OCT has an edge over IVUS. Though we know that the use of IVUS has definitely improved in the prediction of stent expansion, and there are certain IVUS guided scores of calcium depending upon the length of the calcium, presence or absence of a calcific nodule, the vessel diameter, and the reverberation arc, a 4-point system which can be used to use adjunctive devices when the calcium score is more than 2. In terms of certain situations like an osteal lesion and CTO lesions, IVUS definitely has an edge over OCT. And the use of IVUS in CTO lesions cannot be underrated because it does help in wire crossing and in the antegrade wire escalation strategies. It also helps in tracking subintimally and getting the wire back into the true lumen, which is not possible with an OCT. The use of imaging and OCTs can be helpful in changing the strategy due to an unexpected clot morphology, unexpected change in landing zone or stent diameters, detecting complications like dissections, stent deformations, tissue prolapse. And of course, in OCT, you're finding out the struts hanging across the side branch ostium using the 3D view, which definitely is helpful in predicting long-term results. And none of these above incidences of 100% can be seen on an angiography. Just to give you a couple of examples, this is a Army major who came with acute coronary syndrome. There was a man, he came in 1 year late. The angiogram done first showed a recanalized LED. Came in later again with a recanalized segment and escalation of angina. This was the OCT which showed a recanalized vessel. It helped us in basically determining the character of the vessel and the length of the stent, and we ended up with a good result on the end result. And this is another lady who had a previous stent deployment in the proximal LED, came with exertion with classical rest angina. OCT showed an osteoproximal LED lesion. The stent was in the proximal LED, and just about a year prior to this, undergone an extensive rotablator and cutting balloon angioplasty to the proximal LED. And OCT showed a significant chunk of calcium in the osteoproximal LED, and this made us decide our treatment choice to go in for an IVL, for an IVL in this case, because of the thickness of the calcium and the extent of calcium extending onto the stented segment. Basically, the thickness is almost 1.04 centimeters, a 3-12 mm shockwave balloon, and you can see the extent of cracks in the osteoproximal LED with the almost worryingly large chunk of the stent. So, and that basically helped us to optimize the PCI in this patient. So, in terms of the physiology and borderline diseases, multivessel ambiguous disease, non-culprit vessel in STEMI, large bifurcations, ambiguous aorto-osteal lesions use physiology. In terms of left main PCI, aorto-osteal PCI, bifurcation PCI, calcified lesions, CTO, CKD, ISR, and thrombotic lesions use either OCT or IVUS. And only in aorto-osteal lesions, IVUS would be a definitely better, better investigative tool. Thank you very much, and I hope I was within the time. And I once again thank the organizers of the CSI NIC for this wonderful opportunity. Thank you.
We can take one or two questions before.
While IVUS and OCT are giving information on structural aspect, and another FFR gives the functional aspect. Whether both should be added together for each patient, or they would be supplementary to each other?
I think.
What is your recommendation?
No, I mean, I think you don't need to add both to a patient. It depends. It depends upon the nature of the disease. So I think, like I already said, the decision to treat or not to treat in an ambiguous lesion would be physiological. The decision to optimize the treatment and how to do it and how to get an optimal result would be based on an IVUS imaging or on OCT imaging. So I think that we have a thin line there in terms of, I mean, there are some people who say that the nature of the plaque also decides the treatment. I don't think we have too many data on that purely based on OCT, whether we should or an IVUS, whether we should stent a non-critical lesion just because we see a vulnerable plaque at that point. So I think in terms of decision making to treat or not to treat, physiology, how to treat, how to optimize, how to get a good result is the role of imaging.
Yes, thank you.
Thank you. With this, we can close this session and hand it over to the organizers. We would like to thank the speakers and the expert panel for making this a success, this session a success. Thank you.
Thank you. Thank you. Thank you very much.
Thank you, sir. So after such a wonderful session, now let's move on to the next session. The next session will be a bootcamp non-coronary. May I request the chairpersons for the session, Dr. Ashok Dhar, Dr. P.K. Sahu, Dr. N.N. Khanna, Dr. Shishu Shankar Misra, and the expert panelists for the session, Dr. Mahendra Prasad Tripathi, Dr. Ajay Kumar Sinha, Dr. Arvind Kumar, Dr. B.H. Nattesh, Dr. S. Ramakrishnan, Dr. Siddharth Mani, Dr. Pankaj Singh, Dr. Sibu Matthew to be on the screen. And the session will be moderated by Dr. Nakul Sinha. Dr. Nakul Sinha, sir, over to you, sir. Dr. Nakul Sinha, sir.
Hi, am I audible now? Am I audible?
Dr. Nakul Sinha, sir, are you there, sir?
Yes,
you are audible, sir.
Yeah, okay, fine. So,
Dr. Sinha, sir, are you there, sir? Dr. Nakul Sinha, sir?
right, I'm there, I can see you. Are you able to see me and hear me? Are you able to see and hear me? Are you able to see and hear me?
So audible, sir.
Am I audible?
Audible, sir.
Okay. Okay, fine. So, are we going ahead? Hello?
Yes, sir. Yes, sir.
Okay. So who else are there in this session? I can see Dr. Natesh and Dr. Sibu Matthew. Anyone else who is there in this session? Am I audible?
So audible, sir.
Okay, fine. So, I mean, besides Dr. Natesh and Dr. Matthew, is there anybody else from the panelists and the chairpersons? The first talk is by Dr. P.C. Gupta. Is he available? No? Hello? Dr. Natesh, you can unmute yourself. And
yes, sir.
Dr. Matthew also, you can unmute yourself. So I just wanted to know, is there anybody else besides you two people in the chairpersons or the panelists? No? We had Dr. Ashok Dhar, Dr. Sahu, Dr. Khanna is here. Right. So the first talk is supposed to be by Dr. P.C. Gupta. So is he available?
Yes, I am available and I have sent a recording of the talk.
Hello.
Organizers.
So we are playing the same.
Yeah.
Okay, please go ahead.
Good afternoon, everyone. I would like to thank NIC for giving this opportunity. Today, we are going to discuss who are all the patients for intervention or patients for the bypass and a critical limb ischemia. There is no proper clear-cut guidelines to say who are fit for endovascular, who are fit for bypass. If you're going for a management, I'll just brief about what is CLI. This is nothing but a severe compromise of a blood circulation to the tissues, resulting in a basal metabolic needs failure. And definition-wise, presence of chronic ischemic rest pain plus ankle pressure less than 50 and toe pressure less than 30. Presence of foot ulcer or gangrene plus ankle pressure less than 70 and toe pressure less than 50 and TCPO is less than 30 mm of Hg. And coming to the Rutherford's and Fontaine classification, the stage 4 and 5 and 6 comes under critical limb ischemia in Rutherford's classification, and stage 3 and 4 in Fontaine's classification come under critical limb ischemia. And how you plan up the treatment in a critical limb ischemia. This is the global guidelines have been formed last year from European Vascular and Society of Vascular Surgery, and from the World Federation of Vascular Surgery. Even our Indian authors also have been involved in this, how to plan for a critical limb ischemia patient. Once the patient comes to us, we stage the severity of the limb by Wi-Fi classification, which we're going to discuss later. Once the stage is low stage, then we'll just give a wound care and surveillance and look for any deterioration. If the patient is for intermediate and high risk, then those are the candidates for the revascularization procedure. And what are the strategies for evidence-based revascularization? Effective revascularization is the cornerstone of limb salvage in critical limb ischemia. Although multiple techniques are available, there are limited high-quality data to support evidence-based revascularization CLI patients. First comes patient risk estimation, limb staging, and anatomical pattern of a disease for further revascularization. Patient risk estimation, before going for estimation, what are the goals of the treatment? One is healing of the pain, healing of the wound, preservation of the functional limb, and finally the limb salvage comes. And peri-procedural mortality less than 5%, and estimated 2 years plus survival is more than 50% of the candidates for the revascularization. The residual foot function should always considered in the limb salvage procedure. In case of severe impairment, primary amputation may be considered. However, also in these cases, it is usually to evaluate the chance of revascularization, more distal amputation, achieving the healing of amputation stump and improves the next rehabilitation to the patient. And comes to planning of the patient. Critical limb ischemia patient presents with broad spectrum of diseases severity, includes ischemia, infection, and wound condition. Staging of the limb is centrally to evidence-based revascularization, and the use of SVS threatened limb classification is recommended nowadays. Even we are planning for any intervention or any revascularization on the patient, we would like to do Wi-Fi classification so that we can well manage. And this is the only system that fully integrated wound severity ischemia and infection to stage critical limb ischemia. How you stage a Wi-Fi classification? One is wound, that will staging from 0 to 3, and it comes to ischemia depending on the TCP-O2s and depending on the foot infection from stage 0 to 3. This is how the Wi-Fi correlates with the limb salvage, amputation risk, and wound healing, and can identify patients who are likely to get benefit from the revascularization. Rather than doing all patients revascularization, if you stage the patient as per the Wi-Fi, you can clearly say that who are the patients who will get benefit from the revascularization. If you see here, the anatomical complexity of the disease and the Wi-Fi staging of 4 stages, and the patients, those who got a high benefit from the revascularization is those who got a high ischemia levels of severity of the ischemia as stage 3, and the Wi-Fi limb severity of stage 4 and 3 and 2 with the high ischemia of the patients who get benefit from the revascularization. Then coming to the global limb anatomic staging system. This is mainly important to see which patients want what to be done, whether the intervention or open surgery, who will get benefited from the anatomical staging. GLASS provides a basis for the clinical practice and supports future research in PLI, critical limb ischemia, and GLASS staging facilitates the development of specific evidence-based revascularization guidelines in CLI. When it comes to how to manage a treatment, once the patients with CLI candidates for revascularization obtain high quality of angiography imaging, which is very important. What we prefer is a distal subtraction angiogram and define the target artery pathway. And we are doing any planning for any intervention, we need to give an inline flow to the foot. And we have to plan as per the target artery pathway from almost from the groin to the foot, and grade the femoropopliteal segments, whether which grading they comes as per the GLASS scale, or grade the infrapopliteal segments and look for overall GLASS staging, and so that the revascularization strategy by integrating patient risk, limb severity, and anatomy according to the plan concept. And in order to choose the best revascularization technique, it is mandatory to have an adequate knowledge of vascular tree and to evaluate the distal runoff as per the distal subtraction angiogram. Regardless of revascularization approach, goal of the restoring straight inline flow to is especially important in setting up a tissue loss. Pulsatile blood flow optimize the local environment for the wound healing. When it comes to inflow disease as per the glass grading, stenosis of the common and external iliac artery, chronic total occlusion of either common or external iliac artery, stenosis of the infrarenal artery, any combination of this comes to stage 1. And you come to chronic total occlusion of the aorta, chronic total occlusion of the common external iliac artery, and severe disease comes to stage 2. When it comes to A modifiers, no significant CFA disease, B comes to significant CFA disease. This is how the glass anatomical staging of the femoropopliteal segments, and this is how in the infrapopliteal segments. There are different types of grades, grade 1 and 2 and 3 for the femoropopliteal, and grade 1, 2, 3 and for the infrapopliteal disease. Previously, you used to have a task classification. Now, it's better if you grade the anatomical pattern by glass grading. When it comes to inframalleolar or pedal descriptors, there are P0, P1, P2, where the target artery crosses ankle into the foot is P0, and target artery crosses ankle into the foot absent pedal arch is P1, and no target artery crossing the ankle into the foot is P2. And assessment of global anatomical staging system is very important. You can see here the glass stages from 1 to 3, depending on the staging of the femoropopliteal 1 to 4 or infrapopliteal 0 to 4. These are the very important where you stage the glass 1, 2, 3, so that the technical complexity and revascularization is depending on this. And finally, after staging with the glass and the limb severity scoring system, you come to a conclusion which patients fits to an open surgery, which patients fits to an endovascular. This is how we can plan up instead of going for doing inappropriate revascularization procedure. If you score the patient with either the glass staging or limb severity, where if you have a limb severity score of 3 and 4 with a anatomical complexity staging glass staging 3, open surgery is the best. This is clearly said that the guidelines says open bypass is better in stage 3 and the limb severity Wi-Fi stage 3 and 4. And when it comes to endovascular, the Wi-Fi staging with the patients 2, 3 and 4 with a glass staging 2, patients fit well with the endovascular. And in between there are indeterminate where you can do either with the endovascular or a open surgery. And stage 1, if it comes to glass, low complexity disease and failure in target is less than 10% and branch patency is more than 70%. And this is how the table shows. Technical failure in stage 1 is less than 10% and more than 1 year patency. And when it comes to stage 2 patients, classification, less than 20% is technical failure and 50 to 70% of branch patency. And when it comes to stage 3 of glass staging, and more than 20% is technical failure and less than 50% of limb branch patency. And first line strategy, debate on the first line strategy between open and endovascular revascularization. The bypass versus angioplasty in severe ischemic limb, that is what you all know is Bessel trial, remains the only multi-center randomized control trial to have a direct comparison. And inflow and outflow disease, the decision to perform staged or multi-level revascularization is outflow is femoropopliteal, infrapopliteal, and inframalleolar disease is an individual on the basis of severity of the limb threat. And most of the patterns of aortoiliac disease can be managed well successfully with endovascular, and very extensive disease can be managed after failure of endovascular with the open bypass surgery. And this is how the task D lesion can be treated with the intervention in aortoiliac inflow disease as per the glass staging. And when it comes to the impact of inframalleolar disease on the success of proximal revascularization, whether open or endovascular is very important. Pedal loop technique has been described to achieve a complete arch reconstruction in the presence of inframalleolar disease. And don't in CLI. This is very important. What are the things we are not supposed to do in CLI patients? First, ineffective revascularization can lead to poor symptom relief, limited durability, wound healing, and inadequate clearance of the infection. And the outcomes of bypass in patients, those who are underwent failed endovascular intervention, are significantly inferior. This is the reason why we shouldn't attempt in the patient those who are not fit for endovascular. Even though if the failed endovascular intervention, if the patient wants to proceed for the bypass, then those patients will do inferior when compared to primary bypass. And you may damage the target vessels by doing intervention, and you may leave behind damaged vessels for the bypass. This is the reason why if the patient has got a bad anatomy and the bad calcified vessels, those are not fit for endovascular, better straight away go with the bypass rather than trying to treat with the endovascular intervention that may cause damage to the target vessels for the bypass. And patency rates of endovascular intervention are poor in setting of diffuse tibial disease and popliteal and trifurcation occlusions and heavy calcified vessels. Endovascular outcomes for advanced tissue loss are inferior with high early stage of major amputations. Patients with CKD have a high rates of limb loss across all sort of interventions. And patients suitable for bypass. Obstruction of common femoral artery and its bifurcation usually suitable for surgical approach rather than trying to treat with endovascular. Still, you got a better stents across the joints, but still bypass may give a good result when compared to interventions. And in case of long occlusion of femoropopliteal and infrapopliteal vessels, bypass is usually more effective and ensures long patency, as we all see. And however, treatment of endovascular approach in centers of highly experienced hands, still we can try to peripheral interventions. Thank you.
Shamida, it was a very sort of comprehensive and extensive talk nonetheless. And you showed us so many levels of classification and scoring systems. For the paucity of time, we'll move on to the next talk by Dr. Naren Khanna. Dr. Naren, can you unmute yourself? Yes. Dr. Khanna? Yes, please. So please go ahead with your basics of endovascular therapy.
Is it visible, sir?
Yeah, your slide is visible. Please go ahead.
Okay. Thank you very much. I'm going to be speaking on basics of endovascular interventions, offering a ray of light in peripheral vascular disease and endovascular and vascular disease. Whenever we are talking of endovascular, we don't limit ourselves to the lower limb. We sort of encompass every disease, vascular disease from head to toe, from artery to vein, except coronary artery disease. And most of us are, as interventional cardiologists, are actually getting into these situations because these are all comers. If you just look at the statistics, among patients who have coronary artery disease, 14% would have carotid disease, 9% would have peripheral vascular will have renal disease, and 18% would have peripheral vascular disease. Just to give you an example, this is a patient who came with unstable angina, had hypertension and angio, had a bilateral renal artery stenosis, had a proximal LAD stenosis which was tight, and also had claudication and tight aortoiliac disease. And this was a patient done about more than a decade ago, and also had a this was not very difficult. Those days we used to have cut downs, and this is a simple cut down. And we could actually, this was the table outlay at that point of time. Now it is miniaturized. And it was simple to treat them with the coronary stent, bilateral renal stent, bilateral iliac stent, and also treat the aorta in the same sitting. So this is how we have progressed in the vascular interventions. Being an interventional cardiologist, we have to combine skills of interventional cardiology, learn from interventional radiologists and vascular surgeons, and transform ourselves to vascular interventionalists and be something like a robo-doc where we can actually, we are a mix of all three, and we are with the basic ethos of an interventional cardiologist. And that is how we will be able to tackle most of the vascular disorders in the entire body. Now, just time treating peripheral vascular interventions. Now, the timing actually depends the time you have in terms of the viability of the limb. If you have no time, it is better to send them for surgery. And if you have time, it is better to treat them by endovascular techniques. I'm not going to go through details because that has been covered. This slide was seen earlier also. There is an array of technology which has grown from balloons to lasers, to cutting balloons, atherectomies, and stem cell therapy, and debulking therapies, re-entry therapies. So I'm going to be skipping this, but this is how the technology has grown. It is just to show you that most of the technologies which when this for acute limb ischemia, we can do that percutaneously by, this is a percutaneous embolectomy. We can also do by intra-arterial thrombolysis or by special thrombectomy devices which can actually treat these acute ischemic limbs immediately with a better success than surgery alone. Now, coming on to the critical limb ischemia, which the previous speaker has talked in detail. What is very important when we have critical limb ischemia, we have to understand this actually presents as an ischemia to the limb, but it also gives you a clear indication that this patient has a multiple vascular problem and a diffuse atherosclerosis. If you look at this is the data at of 6 months outcome from 19 studies. If you look at the 6 months outcome, 20% would be dead, not from vascular critical limb ischemia, but from other vascular emergencies. 35% would be alive with amputation, and only 45% would be alive without amputation. So CLI becomes very important in treating these limbs, but also it gives you a clear indication and chance to look for atherosclerosis in other parts of the body. And that is where one should be looking at and treating all together to save the patients and to decrease the morbidity and mortality. What are the basic principles of peripheral vascular interventions? One, if you have an above inguinal, suprainguinal disease, you should have a stenosis more than 70%, gradient more than 30 millimeter of mercury, and there should be a good outflow. And if it is not there, you need to make sure that the outflow is restored. One has to also understand if you have to choose between profunda and superficial femoral artery. Profunda is like the left main or the more important LAD of coronary circulation. It has to be preserved. The SFA can still be compromised, but profunda is the vessel which is most important for lower limb ischemia or perfusion. If you cannot revascularize extensively lower downstream, you have to make sure that the proximal lesions are adequately dilated and revascularized so that there is a good pressure head for the collaterals to flow in. And one must avoid stenting over the joints or below the lower 1/3 of SFA, especially if there is a poor runoff. One has to understand for the limb viability, one leg artery, one leg perfusion in one straight line flow from top to a foot artery, at least in one artery, is good enough. But one must try to revascularize as much as possible. And you have to also understand that the drug-eluting technologies are coming up in the lower limb intervention, especially the BTK intervention, and they have a future role. And give you some examples here. I would be fast. This is a complete chronic total occlusion of the superficial femoral artery treated by PTA and stenting. Similar sort of lesions can also be treated if it is calcified and the wire cannot go luminally. You can go subintimal, and this can be treated with subintimal angioplasty and stenting, and they have equivalent results. For subintimal angioplasty, we have many a times we can do without re-entry devices, but we have dedicated re-entry devices which we use. Or we can have front-looking lasers which can all which can also recanalize and channelize these atheromas, chronic total occlusions, and we will be able to do angioplasties. For below knee lesions, we follow the same principles of equipments as we use in coronaries. It's the same size of balloon, same wire, same size of stents, and many times what we have an advantage to use pedal access or infrapopliteal direct arterial access to actually do the revascularization. We also have an alternative of stem pediatric care, but limbs do heal, and it is very promising, and we have seen it in our own group in the last 10 years. Now, let me just run through the next 5 minutes through exotic vascular interventions, what all we do as interventional cardiologists as basic endovascular intervention. These are different patients of varicose vein, which can be treated very with endovenous laser therapy, also by radiofrequency ablation or by non-thermal therapies, where we actually ablate the veins, the great saphenous vein and the perforated and the short saphenous vein. This is our case series of one of the largest in the world of 8,000 cases, and where we have treated mostly GSV, but also SSV perforators, and we have also used at very few patients, almost negligible, had DVT, and that to a very mild DVT. Pain, mild pain is the most common side effect, and it resolves with simple analgesics. Very few patients have swelling, and no patient had pulmonary embolism. Ecchymosis is also rare. This is our occlusion rate at 1 year, which is almost close to 94%, which is much better than surgery. Now, the robotics have also entered the endovascular arena, and these are, we can do most robotic with the endovenous, an endovascular robot, which we are not going to acquire, but we have it in our other centers. Many of the lesions, especially the carotid and above the inguinal ligament, can be treated by a radial artery approach. Even the upper SFAs in ordinary height patient can be treated with regular route, and the patients can be discharged on the same day, as most of these are tests now. Now, looking at another set of disease which is very common in Indian population in vascular domain is the Takayasu arthritis. We have all seen this involving every artery right from head to toe, right from head to the lower limb. And this is one of our patients where you had an innominate stenosis, you had a common carotid stenosis, you had aortic aneurysm, also coronary artery disease. So stenting of arch vessels and stent graft for aorta, and also, this patient had descending thoracic aortic stenosis, which was treated by Angioplasty. This is another total arch reconstruction in Takayasu arthritis. I'm not going to go through details, but it is common, and all of us are doing this. This is a very interesting 19-year-old patient, which was done by us almost like 15, 20 years back. And this patient had Takayasu arthritis involving the left main, and this patient had a bypass for that with a Lima graft and a venous graft, and following that, the patient had angina. And post-angina, when we did an angio again, we realized that there was a subclavian artery stenosis, which was treated by a stent, and we also did left main stenting. This probably would have been the first Indian case of left main stenting almost 20 years back. Treating aorta and Takayasu arthritis has very good results. This is our patients of results of our patients. Personal series in Takayasu arthritis of 461 patients with 630 lesions. A follow-up of 3 years. I'm not going to go through details as this has been published, but overall the endovascular techniques work very well and much better than the surgical techniques. Second syndromes is acute aortic syndromes, which encompass aortic dissection, rupture of aorta, thoracic aorta is like a transection, penetrating ulcers, intramural hematoma, and traumatic injuries. For acute transaction of aorta, there is a class 1 indication for doing an aortic endovascular graft. The test we actually, it's quite debatable. For acute aortic dissection, the most important principles are that we close the entry point, we depressurize the false lumen, we try to increase the flow in the true lumen, and we aid the remodeling of the aorta. It has been debated that in acute dissections or chronic dissections, when to treat, whether to stent or not to stent. But what is not debated is if you have indication of malperfusion to the gut or the lower limb, you need to treat them not by endovascular graft, which you may do to close the entry. Is communicating the true and false lumen, and this is done by in situ fenestration and balloon dilatation. So that was for the mesenteric vessels. This is for the vessels. There has been a lot of debate.
We are very short of time. Can you try and wind it up, because we are
Yes,
already
sir.
30 minutes late?
Yes, sir, sure. So there has been a lot of trials to address an issue whether the chronic dissection should be treated by stent graft or just be managed by optimal medical therapy. And we have seen that in both situations, that the endovascular approach along with the optimal by the surgeon. The surgeon actually takes out the aneurysm and puts a surgical PTFE. We do that by endovascular means. And what happens over a period of time, the aneurysm actually shrinks over this. And that is how it has evolved the treatment from long surgical scars to no scars and a totally percutaneous treatment as of now. We have also improved our techniques by using vascular staples and treating ascending aortic aneurysms with branch grafts, with chimney techniques, with hybrid techniques, and also with a new principle of multi-layer, which is non-covered stent, which actually depressurizes and centralizes the flow. And we have been using it to cover the ascending aortic aneurysms, arch and ascending aortic aneurysm. The beauty of this is that it preserves the side branches. There is no need for a side branch hybrid or a chimney procedure. And what has now come in real practice is the endovascular Bental, where we put a aortic stent graft, where we put aortic stent graft, and we also have EVO, which is and this is also possible with a non-covered stent or a multi-layer foam later. And we are also going into the genetic interventions, and we can actually turn off the genes for aortic aneurysm enlargement, and we can, doing that, we can actually prevent a rupture of the aortic aneurysm. So I'm going to be stopping here. We'll stop for the paucity of time. If there is any question to answer now, if there is a paucity of time, thank you very much.
Well, thank you, Naren. It was really a very, very extensive lecture. I wish there could have been more time, but we are very hard pressed for it. So I'll request the next person, Dr. Vimal Someshwar. I believe he's going to give his talk on imaging for the peripheral interventions. So Dr. Vimal Someshwar, please.
Thank you, organizers, for this invitation. Today I'll be talking on role of imaging while you plan for a peripheral arterial interventions. As you know, imaging plays a very important part in actually making diagnosis and planning the treatment in cases of peripheral arterial disease. There are certain procedures that we do, especially before starting the actual imaging modalities. Clinically, obviously, the history is very important. If there is any pain or discoloration, if you have ulcer or gangrene, that would mean that there is a peripheral arterial disease, especially in patients who are diabetic and have are smokers also. Now, in these patients, clinically, one should examine for the pulsations. And if you find that the pulsations in the dorsalis, pedis, posterior tibial, popliteal, and femoral are poor, then that's one case where you should be looking up to doing various investigations. Now, in the diabetic group of patients, there are various special investigations that have to be done before you actually do imaging. Now, these are what we call as foot profile examination. And in these three examinations are included. You have the ABI measurements, where what we do is we measure the ankle and brachial blood pressure, as you can see on this photograph. So you take the pressure in the ankle region as well as the brachial region. We know that the brachial pressure is invariably higher than the ankle pressure. So if the ankle and brachial index is taken, or if you divide ankle by brachial pressure, if it is anything equal to 1 or up to 0.9 is normal. But if you see it is 0.7, that means the ankle pressures have gone down. There is a significant stenosis. And if it is 0.5, then there is definitely a gangrene setting in, or ulceration will set in these patients. The other two tests, biothesiometry and pedopotograms, are basically to assess in diabetic patient where there is an associated neuropathy. So the vasculopathy and neuropathy can be assessed by the special foot profiling that is done in these patients. Once you do your foot profiling, that's a time that you now think of vascular imaging. And the whole aim of vascular imaging is to assess the disease segment as well as the distal runoff. It's very important to look at the distal runoff because you want to improve the distal flow to allow the claudication to go away or ulcer to heal, or if there is a gangrene, if there is an amputation, the amputation stump should heal. Now, the investigations that are done after clinical investigation is color Doppler investigation. You have the CT angiography now, the MR angiography, and obviously the digital subtraction angiography that is to be done in these patients. Now, the Doppler ultrasound, as you know, you can visualize the plaque very well. It tells you the morphology, whether the plaque is soft, whether there is calcification or hard plaque, there is ulceration, that will tell you the morphology of the plaque. You also assess the stenosis or the quantification, how tight the stenosis is. And anything more than 70%, we would say it is a significant stenosis. The spectral waveforms are another advantage in an ultrasound examination, which will tell you, and I'll tell you in the next slide, what does this spectral waveform looks like and how you got to evaluate it. The ultrasound also helps you to give you the hemodynamics. That means how much is the collateral flow, how is the distal runoff. These are very important to assess. The important thing about ultrasound is there is no contrast required. And in these patients who are diabetic and often associated with early CKD, you don't want to inject contrast in them or keep the contrast load as low as possible. The problem with ultrasound is that it is purely operator dependent, and there is a chance of missing out lesions, especially in the iliac region, or if there are tandem lesions down the line, you may not get proper assessment of these tandem lesions. Iliac vessels, you don't see it very well because often the patient are obese, or if there is gas in the abdomen, you may not see it very well. This is the spectral waveform that I was telling you about. Now, the advantage of ultrasound is you can get a color Doppler image. You can also get the sound and this spectral waveform, which will tell you whether the stenosis is significant or no. In a normal artery, you would get a triphasic wave. You'll get an upward curve, and a sharp downward curve, and a short, small curve above. This is a triphasic normal waveform. If you have a stenosis, you will get broadening of the spectral flow. As you can see over here, the spectrum has widened now. And if there is a tight stenosis, if you color Doppler it below the level of the stenosis, you will get a post-stenotic turbulence, which is seen as multiple short waves all along in the arterial waveform. Now, this particular spectral waveform is very important. If there is a tight stenosis and if there is a collateral flow, you can imagine the flow distally is diminished. At the same time, the spectrum is monophasic. There is no three waves. It's just a single upward surge. And the wave is diminished. And this will give you that there is a tight stenosis there. CT and MR angiography are the most important non-invasive modalities that are being performed nowadays. Highly specific, and it can tell you the length of the disease, the tight stenosis, the collateral flow, and distal runoff. However, what is the problem with CT and MRI is that sometimes if there is a calcification at the site of the stenosis, you may not be in a position to evaluate. And I will tell you, I'll show you in an example there. Again, the three major disadvantage of a CT is if there is calcification, there is a problem. If there is CKD, again, the contrast load is very large. You can have to give about 100 to 120 ml. And obviously, radiation is quite significant when you're doing a CT angiography. Between CT and MR, my first choice is a CT angiography. MR, I just keep it for patients where there is a lot of calcification, one can do an MR. Now, how do you read your CT is very important, and a couple of slides will show you that. The first two images that you are seeing is what we call as a reconstructed MIP image. And in that, you have to first look at the plain MIP image and isolate or find out where there is calcification along the expected course of the aorta, the lower limb arteries. And then you start looking at the contrast image. Now, this gives you a complete idea. Important is that you should do the CT scan right from the level of the diaphragm all the way up to the level of the foot, because foot is your target and you should see all the digital branches there. Now, if you see this angiography, you now realize that there is an occlusion of the mid SFA on the left side. More than that, it is difficult to evaluate on this study. Even look at the bifurcation, you feel that the iliac branches are very good, but there is a lot of calcification there, and therefore it is important that in these areas you should do what is known as a cross-sectional or an axial imaging and isolate these segments very well. As you can see that the aorta is looking very well out here. The iliac, the superior and inferior mesenterics are very well seen. The celiac is well seen. The renals are well seen. Now you can see a lot of calcification here, but the luminal diameter is still okay. As you come towards the bifurcation, you will start seeing. If you remember, the MIP image had shown that the right iliac artery was normal. But when I see this, you can realize it. Compare it with the left iliac artery, there is narrowing of the common iliac artery. And that is because in the first image, the overlapping calcium was masking the image and you would not get a clear idea. So cross-sectional imaging at the level of the calcification is very important. As we go down, the external iliac artery that you are seeing here are good. The common femoral artery is good, but there is a big plaque on the right side. And if you come down, now you can see that the SFA is comparatively narrowed. This is the profunda femoral artery in cross section, and this is the SFA. And SFA is narrowed bilaterally. And that tells you that there is a narrowing in the SFA. Distally, we know that the femoral artery, here it is, the spot images, as you can see that the common iliac artery on the left side, and this is on the right side, overlapping calcium was masking the image and you are not getting clear image. And when you go down, the femoral arteries are also narrowed. So you can now see that not only the MIP image that you got to see, but the cross section has to be evaluated, especially if there is an associated calcification. Coming to DSA, as you know, is a gold standard investigation. It is invasive. And hence, as of today, we invariably do it prior to planning an intervention. So if you have decided that this patient has an ulcer or a gangrene and needs intervention in the form of angioplasty stenting, then we do a DSA prior to doing an intervention and follow it up with an intervention. Important thing to realize, on a DSA, the contrast required is much less than the CT angiography. As I said, in a CT angiography where you require about 100 to 120 ml, on a DSA within 60 to 70 ml, not only a diagnostic is finished, but we can also finish off the angioplasty and stenting. So not only diagnostic, but therapeutic is possible with a DSA in a low contrast, especially in patients who have diabetes and CKD, we need to do that. The DSA also gives a good flow dynamics, gives you a collateral flow and a reformation distally, and helps to plan the treatment completely. And if there are multiple tandem lesions, all can be evaluated and can be treated very well. What is my approach as far as imaging is concerned in peripheral vascular?
We can start the discussion.
So you can start the discussion.
Thank you.
Thank
you. But is Dr. Someshwar there present for the discussion? I doubt so, because I believe this was a recorded talk.
Hello.
Hello.
Dr. Gupta here. Is my talk on or is it cancelled?
Your talk was tried to be played. It didn't play. I believe it was a recorded one. So the technical team had a problem. If you have the talk live, you can please go ahead quickly.
No, I can make the presentation if you think there is time.
If you can do it within 10 minutes, I think you can go ahead.
10 minutes is rather.
Hello.
Anyway,
I'm Dr. D.P. Smith. We are running
So we are
late.
starting the presentation.
Can you stick to time, please?
So we are starting the presentation.
Please.
Dr. Gupta.
Good evening, everyone. And at the outset, thanks to CSI for the opportunity to make this presentation. I will talk about peripheral toolkit and how we get started with peripheral interventions. So most important thing is to have the correct patient details. What are we intervening for? The correct history. We should have a definite procedure planned. The comorbidities, any medication, especially some of our patients may be on full anticoagulation, and we may need to take care of that before we plan any intervention. Safety in terms of patient monitoring, radiation protection. We need to plan the access well so that we are able to execute whatever we've set out to or plan to. The site, always use an ultrasound, and that is the current standard of care. The type of sheath that we plan to use, and at the end of procedure, check the distal circulation and see if you need any closure device. And this really would summarize my talk. So when it comes to radiation safety, you don't feel a thing when you're in the cath lab. It only happens later on. Use a wraparound apron, not just a front covering apron. Use a thyroid collar, use goggles, use cap. So radiation protection, you can never have enough of it. Avoid getting radiation on the hands. Use a dosimeter so that it can be checked frequently. Keep detector close to the patient to reduce scattering. Use collimation so that the radiation dose is less. Use a movable skirt below the table and a screen in front of your chest. And you can use a rad pad to reduce scatter. It's important to have the right attitude. So while I'll talk about hardware, the software in the interventionist mind is extremely important. Attitude is really the key. We need to have concern for safety, for self, for staff, and for patient. Material use should be optimal, not extravagant or stingy. And if you are struggling, call for help. Ego can be your biggest enemy. These are some of the things that I will talk about. And then there are, of course, other thrombectomy devices, atherectomy devices, crossing, which I will not be talking about. Now, sheath provides access to the vessel to approach the target. It avoids trauma to the vessel and prevents bleeding and hematoma while the procedure is going on. These sheets are color-coded based on size, and we have short, long, braided, crossover, micro sheets, steerable tip, and it's important that we don't pull the wire out of the sheet because the wire can get cut. And make sure that it goes at the correct angle so that you don't push the sheet into the posterior wall of the artery. This is the color coding. These are some of the parts, and I'm sure when you're starting interventions, you will be comfortable knowing parts of the sheet. And this is the working length, and we should be aware of this. Lengths of sheath range from 5 to 100 centimeters. 10 centimeters is the one that is used for standard vascular access. A crossover sheath is 45. If we are going from brachial to viscerals or to iliacs, use a 70 centimeter sheath. From femorals to carotids, use a 90 centimeter sheath. Use appropriate length. Don't go in for a excessively longer sheath because you would need then longer balloons and longer devices to reach the target. This is a crossover sheath, and here you can see the catheters come across. Guide wires, we have the access guide wire, which is a standard J-tip short wire, which we use for placement of the sheath. And then we have wires with the maneuverable or steerable tips, and these can be floppy, often hydrophilic. And these are used to subselect the vessels to get into the orifice. And then we have the rail wires, which are stiff. And these provide a platform for exchange of catheters and balloons. And we typically use a J-tip or a floppy tip to avoid injury, where the wire ends in the vessel. And these can be stiff with a steel core or flexible with a nitinol core. For example, a sort of stiff thermo wire. Size is measured in inches. 035 is the standard which is used for most peripheral interventions. 018 or 014 is used for carotid, renals, and below the knee. And 038 for larger sheaths and for aortic endografts. So what is the length of wire that you need in a given situation? Take the length from the insertion to the target, plus length of the catheter or device system, that may be the stent system, plus another 15 centimeters, so that you have something to play with. The lengths are available from 120 to 360 centimeters. There are specific wires and hydrophilic wires to non-hydrophilic wires, and some of the ones which we use are glide wires, which is the standard thermo wire that we use in the Roadrunners or V18 for below knee lesions, and the Lunderquist wire, which we use for aortic endografts. Catheters, again, basically three types of catheters. The flush catheter, this is what we call the pigtail catheter, which has multiple side holes. There is no recoil, tip is usually rounded to avoid entry into a branch, and it keeps the shaft in the center. Then we have selective catheters, which could be guide catheter or diagnostic. A guide catheter typically has a thinner wall, a much larger internal lumen, and it has rotational stiffness to seek the vessel orifice, and should be flexible enough to advance into the vessel. And it has a slightly more reinforced construction. And then we have microcatheters, 2 to 3 French, which fit into these standard guide catheters, at times even into the diagnostic catheters. These are parts of the catheter, and I think it's important to understand what the tip length is, because if we have too long a tip, maneuverability becomes a problem, and we need to understand what is the primary curve. This is the angle of the target vessel to its parent artery. Then the secondary curve, for example, we in the aorta, we can have a wider secondary curve, and the tertiary curve, which is the normal curvature of the parent vessel. And catheters lengths range from 100 to 110. This is the standard, but we do have long catheters available for use from transradial going down into the femorals or the tibials. And choosing a catheter. For example, an angled catheter, when the angle of axis branch from the aortic branch is low, or a curved catheter, for example, a Cobra 2 for a celiac artery, when the angle is 60 to 120, or a recurved catheter, like a Simmons catheter, when the angle of axis from the aorta is great, and you may not be able to get down a standard curved catheter inside. And these are some of the other catheters. My favorite catheter personally is the JR4, which I can use to access most vessels. And for cardiologists, this is the catheter you would be using for the RCA. Then the micro and support catheters. In periphery, we use them typically for tibials or at times for coiling and embolization of either tumors or vascular malformations. The catheters available that we use are ProGrade, and then support catheters for tibials are CXI and the Rubicon catheters. Balloons can be either non-compliant, which are high pressure and made of polyester or nylon, and this balloon expands to a specific diameter. And these balloons are extremely useful in, let's say, when we are dilating stenosed vein, doing a fistuloplasty, or when we are doing a central vein angioplasty in dialysis patients. Semi-compliant, made of polyurethane and used where mid to high pressures are needed. They are easier to deliver. And then we have the compliant balloons, which we use for occlusion, or the occlusion catheters in the aorta, or for dilatation of a aortic stent graft. And then, of course, we have cutting balloons for tough lesions or fibrotic lesions, drug-coated balloons, and intravascular lithotripsy balloons. So these are some examples. Balloon inflation, this is a non-compliant, this is a compliant balloon, and then cutting balloon, which has blades here, and we always use an indiflator to go to a specified pressure. So each balloon has a specified pressure that we should dilate it to. And then we have different types of balloons over the wire and the monorail system. I think monorail system is the one which is used by most cardiologists for the coronaries, and it's a rapid exchange system. Moving on to stents, we have self-expanding stents which are flexible and have longer lengths. And this is sort of my preferred stent in most peripheral locations. Balloon-mounted stents, when you want to place something at the orifice of an artery or the origin of artery, for example, the renal artery or the subclavian artery, these can be placed more precisely and have good radial strength. Covered stents may offer good patency, but they cover the collaterals, and that is a major disadvantage. But these can be used in calcified aortoiliac lesions. Covered stents, another important point I would like to highlight is they should be part of an emergency kit. When you're dealing with the iliacs or the femorals, do keep a few covered stents in your armamentarium. And this emergency kit should consist of not only the stent, a stiff wire, and also the appropriate size sheath and occlusion balloon. This appropriate size sheath may quite often go on to 9 French or 11 French, which may not always be available in the cath lab. There is a self-expanding stent made of nitinol, and these are very flexible. And most stents have now a user-friendly delivery system, either with a gun or a thumb wheel, so you can deploy the stent slowly. And this is a balloon-mounted stent. And these are stent grafts which are sort of covered with fabric. Snares are, again, an essential tool in the hands of any interventionist. You may be using them to snare a guide wire when you access the lesion from another site and the intervention is from another. For example, you access the femoral artery antegrade, but you're not able to cross, and you access the tibial to get the guide wire up, and then you can snare the wire. Or typically is also used for aortic endografts to access the contragate. These can also be used for IVC filter retrieval or retrieval of broken catheters or wires or foreign bodies. Closure devices, we typically use manual compression, and the formula is 3 minutes per French sheath size that you use. So if it's a 6 French sheath, you're going to be pressing for about 18 to 20 minutes, and the APTT should be less than 170. Then there are passive closure devices. These are hemostatic pads. Then compression devices, which we use for the femostop or the radial devices, which I'm sure cardiologists are very familiar with. And then active vascular devices like ProGlide and the AngioSeal. The advantages these offer are rapid hemostasis without interrupting anticoagulation. Patients can be mobilized early, especially when it's a femoral access. They reduce bleeding, the risk of pseudoaneurysm and AV fistula. Very convenient to use in obese, and complications include limb ischemia, infection, and which might at times lead to pseudoaneurysm. So these are some of the devices. Here you can see a femostop device where you inflate the balloon after placing it along with a belt. And then the Perclose device, which is a suture-based device. And if you're using it for anything which is any sheath which is larger than 8 French, we use 2 or 3 depending on the sheath size, and these have to be then pre-closed, which means they have to be placed before you go in with the larger device. To summarize, a proper assessment of the patient, your plan, the lesion, extremely good planning, take care of radiation safety, check the hardware. Do you have everything available in the cath lab? Because at times you might think that it might be available, but it may be missing on that day. Always use ultrasound for access, have the right attitude, and please do not be scared to call another interventionist, another colleague to help you out if you are in trouble. Thank you so much for your attention.
Thank you, Dr. Gupta. I think it was a very nice summary and an overview, all combined. And I think just one-line messages that know what you have at hand and how to use it, because both things are important. You need to have the full inventory, and you should understand how the usage is to be done. So thank you very much for the nice session. I understand we are still late by around 20-25 minutes. So I'll probably hand over to the organizers for the next session. Thank you very much.
Thank you.
You respected.
Subhashish, you start the next session, please.
Yes, sir.
All the foreign speakers are waiting.
Yes, sir. Thank you, respected chairpersons and speakers of the previous session. Our next session deals with coronary imaging. Chairing this session will be Dr. D.P. Sinha, Dr. Achut Sarkar, Dr. Shuman Bhandari, and Dr. R.K. Jain. Moderating this session will be Dr. Devdatta Bhattacharya. Expert panelists include Dr. Ronnie Matthew, Dr. Pranab Kumar Biswas, Dr. Ranjan Kumar Sharma, Dr. Mahesh Kumar Chaudhary, Dr. Rakesh Gupta, Dr. Darshan Jhala, Dr. Shubhra Banerjee, and Dr. Ashit Dash.
Yeah, we are running late by approximately 30 minutes. So without wasting any more time, our first speaker is Dr. Gary Minch. I would ask Dr. Gary Minch, who doesn't need any introduction, start his deliberation on coronary imaging for bifurcation and treatment of vulnerable plaques. Dr. Gary Minch, please. Dr. Gary Minch. Dr. Minch.
Yes, sorry, one technical difficulty. Some reason it won't share my screen. May I suggest that you go to the next lecture and I can figure out why I can't share my screen?
I think Dr. Gary Minch is having some technical problem with his presentation. So Dr. Akiko Mahira, can you speak?
I'm trying to explain the stent optimization, OCT or IVAS. This is the tissue characteristics of the coronary artery evaluated by IVAS and OCT. And actually the appearance is very similar. We can recognize normal artery, and lipidic plaque, we can see the clear attenuation by IVAS as well as by OCT. In terms of the calcified plaque, very sensitive by both IVAS and OCT. How can we decide optimal stent and balloon sizing using the OCT or IVAS? We look into the media. By OCT, we can recognize low intensity band. Outer layer of the media is external elastic lamina showing red line, and we can measure EEL diameter showing as yellow arrow, which is larger compared to the lumen diameter. We can do similar by IVAS, and we can recognize media showing the black band. And we go to the outer layer of the black band that's indicating the external elastic laminar, and then we can measure the EEL diameter showing as yellow, and which is quite similar by both OCT and IVAS. However, what is the difference in the lesion? This is the same case at the lesion site, and we can recognize EEL diameter by IVAS, but OCT cannot, because OCT is so sensitive for the attenuation, and many times at the lesion we cannot measure the EEL diameter. After the stenting, both modality can see very clearly in terms of the stent expansion. Let's do the case. This is a very diffuse LED lesion, and one may expect we don't see the normal segment in such very diffuse disease. And we thought so, therefore we performed the IVAS. From the distal to the proximal, you can recognize very diffuse disease. However, IVAS can measure the EL diameter, and the very distal segment, we measure the EL diameter, which is 3O. Therefore, I recommend round down closest quarter size of the stent, which is 2.75. How can we do the stent or OCT? How can we do the stent or balloon sizing by OCT? And because of we look into the normal segment, we go to the distal reference. And first, we go to the distal reference and we look for the media, and we measure the EL and EL diameter. And if we could measure the EL diameter, we recommend round down closest nearest stent size, and that's how it looks like we decide the stent or balloon sizing. However, about 15 or 20% of the time, even the distal reference, we couldn't see the EL diameter. In such, we go to the lumen diameter. However, the lumen diameter is underestimated compared to the vessel diameter. Therefore, when we measure the lumen diameter, we go to round up to the nearest stent size, and we're choosing the stent and balloon size by OCT. How about this case? Most of the people recognize left-hand side is more clear, severe calcium compared to the right. But when we look into the OCT, we recognize quite different impression. And left calcium is actually very thin, although this is big calcium. And this type of the thin calcium is really easy to making the fracture. Therefore, OCT is probably more beneficial because we can recognize thickness of the calcium, but IVAS cannot detect thickness of the calcium. And the right-hand side, actually quite thick calcium, this is more difficult compared to the left-hand side. And because of the OCT can recognize everything, we develop the calcium score using the OCT. We measure the angle, thickness, and length. And all of this is important. And what is most important is thickness of the calcium. And the calcium score include angle and thickness and length. And if the score is 4, the calcium stent is poor expansion compared to the low score. How about this case? Looks like diffuse disease in the LED, and perform the OCT. Go to the distal reference, we can measure the normal segment and EL diameter measure 3.24. Round down closest nearest quarter size, and we choose a 3O stent. Additionally, this case, we can see the calcium everywhere, and we thought we have to calculate the calcium score. And based on the OCT appearance, we measure the thickness and length, and also the arc, and none of them require the high score. And then we thought this is not necessary for the atherectomy. We go ahead the balloon and stent. And this is how it looks like after the stent. In such long stent, we recommend to analyze the stent area by comparing the distal half and compared to the distal reference, and proximal half, smallest area compared to the proximal segment. We can do the calcium score based on the IVAS. We learn from the OCT, and then we analyze, start with the angiographic calcium. Because if there is no calcium angio, we know that's more likely thin calcium. So first we start from the angio. And if we don't have the calcium angio, we are okay. But if yes, we calculate the calcium score by IVAS. Components of the IVAS calcium score include the length of the calcium more than 270 and circumferential calcium. Circumferential calcium is quite important because if you have some place which you don't have the calcium, that's more likely good chance to making a good dissection. And the calcified nodule is a marker of the big chunk of the calcium behind. And finally, we include the vessel diameter in the calcium score because IVAS can detect the vessel diameter in the severe calcium segment. And if we start small vessel size, that's indicating less capacity of the good expansion. Therefore, including all together, if more than equal to 2, we consider the atherectomy. We develop the calcium score based on the test cohort and we validate. If score is high, we see the poor stent expansion. Even high, if we do the atherectomy, we have the good stent expansion. If there is no angiographic calcium, even the high score, we can see the good stent expansion. It's quite helpful. What is the goal of the stent expansion? Based on the many different people using the different stent, indicating quite similar answer. Meaning we need at least 5.5 square millimeter as a minimum amount of the stent expansion in the non-left main epicardial artery. But what is important is not only the minimum amount, but also if you have the larger and larger stent area, your specificity curve, meaning more likely not having the outcome, poor outcome, is less and less. Therefore, what is important is required it is at least minimum stent area and larger is better. What about other complication? What is important is edge dissection and malapportion and tissue protrusion. This is a case which having those findings in the same case. And we can recognize these findings similarly, but probably easier by OCT. This is a summary. What is important of those findings based on the IVUS and OCT? And everybody is quite having the same idea, and minimum stent area is the most important by IVUS or OCT. But in terms of the malapportion and the tissue protrusion, as long as the stent area is good enough, that's not indicating the poor outcome. And what is important is either edge residual disease or edge dissection. And many of study indicating that's associated the poor outcome. We evaluate the edge dissection in the ADAPT-TS, including more than 2,000 patients. And what is important is residual lumen area, which is less than 5 square millimeter, or residual flap angle is more than 60 degrees, or length is longer than 3 millimeter. And we can recognize those findings clearly by OCT. This is intimal dissection, a medial dissection, or intramural hematoma. However, there is a specific scenario IVUS can be better. This is a stent from the circumflex to the left main. After the stenting, even though we put only one stent, we recognize there is a multiple layer of the stent at the ostium of the left main. And this is so-called stent deformation by pushing the guide at the ostium stent. And stent deformation is it's not infrequent, because we found 6.5% of the stent deformation in the Excel trial. The patient having the stent deformation is actually poor outcome, even adjusting the minimum stent area. Recognition and additional treatment is important. How about this case? If this is an osteal lesion, and we recognize that's very focal calcified lesion. And after the stenting, we actually surprised because stent was implanted not in the lesion, actually distal segment. And the recognition of the location is important and the expansion is important. This is really necessary to confirm by IVUS. CTO is also important. After the antegrade wire dissection re-entry technique, we can see the wire position. And what is very important is your wire in the true lumen. And I recognize this could be the true lumen, but I recognize there is some tissue and go to the very distal portion. This is actually true lumen. This is actually subintimal space. And the recognition of the wire in the true lumen is the most important. And finally, because of the after the CTO wiring, still the antegrade flow is not good enough. Therefore, recognition where the landing or what is the vessel size is quite difficult by angio, and we should do by IVUS. And finally, this is a case patient having the renal insufficiency, and many times we have to do low or zero contrast PCI. And this is an angio and making the difference, and we could do the wiring stenting based on without contrast. And in such scenario, IVUS is quite important. We can measure what's the vessel size without angio, and we can recognize stent expansion, and we can recognize edge dissection. In terms of the in-stent restenosis, if the patient coming back early, that's more likely under expansion. Coming back late, that's more likely neoedema aplasia or neoatherosclerosis. Therefore, before starting, what is most important is to understand the mechanism of the stent failure. In such, probably
we'll take the next topic as we are short on time. Dr. Gary Mintz, you can go ahead with your talk.
Yes, I'm just sharing my screen now. Can you see my screen?
Yes, we can.
And you can hear me. Good.
Absolutely.
So I'm going to talk about coronary imaging for identification and treatment of vulnerable plaques. The story begins more than 30 years ago with a publication by Jim Miller, who observed that a potential stress trigger could be harmless one day, yet lead to a cardiac event sometime later, and this resulted in the concept of a vulnerable plaque. Well, fast forward more than a decade to the first real natural history study, Prospect, in which IVUS and VH IVUS was performed in all three coronary arteries in patients presenting with an acute coronary syndrome. At that time, VH IVUS was the only technique that allowed intravascular imaging to assess plaque composition. But the findings of Prospect were quite striking. These were pre-specified, a plaque burden more than 70%, a thin cap fibroathroма by virtual histology IVUS, and a lumen area less than 4 square millimeters. And if you had all three, you had a 10-fold increase rate of events at 3 years of follow-up. Well, VH IVUS has been supplanted by NIRS IVUS or OCT. And we'll first talk about the seminal NIRS IVUS studies. The first, which was the LRP study by Ron Waxman. Eventually, there were 1,271 patients who were followed for 2 years. Again, the pre-specified endpoints were a maximal LCBI of 4 millimeters. That is the largest lipid core burden index within any 4 millimeter long segment, a plaque burden more than 70%, and a lumen area less than 4 square millimeters, similar to Prospect 1, but with LCBI replacing VH TICFA. And in terms of outcomes, comparing patients and segments with an LCBI more or less than 400, you can see a doubling in the patient level events and a quadrupling in the lesion level events. Well, the next NIRS IVUS study was Prospect 2, also a 3-vessel study. And we're going to talk about Prospect Absorb later. But again, this was a natural history study. The pre-specified endpoints were a plaque burden more than 70% and a lumen area less than 4 based upon Prospect 1, as well as a max LCBI of the upper quartile, which turned out to be 325. So let's first look at plaque burden. If you look at patient-level events or lesion-level events, comparing lesions with a plaque burden more than 70% or less than 70%, you can see a 3 to 4-fold higher rate of patient-level events and a 10 to 12-fold higher rate of lesion-level events. In terms of max LCBI more than 325, roughly a doubling of patient-level events and maybe a 9-fold increase rate of lesion-level events. But then when you compare those two, plaque burden more than 70% and LCBI more than 325 versus any other combination, It's really only the combination, having both a high plaque burden and a large amount of lipid, that is associated with events at follow-up. Even though LRP used a cutoff of 400 and Prospect 2 used a cutoff of 325, here I compared those two studies using the exact same cutoff above and below 400, and you can see a remarkable similarity between the events, whether they are on a patient level or a lesion level. But I particularly like this analysis from Prospect 2, which is a continuous measure of plaque burden and a continuous measure of max LCBI. And you can see above 70% and above 400, an exponential increase in the predictive probability of an event. So this indicates to us that it's not just a dichotomous cutoff, but that there are super vulnerable plaques that have a much higher rate of events. And we should try to identify not only, let's just say, an average cutoff, but also the lesions that are even more likely to cause trouble. Let's now shift to OCT. The seminal study is the CLIMA study, which was OCT in 1,000 patients with LAD disease. There were 4 pre-specified OCT endpoints: a lumen area less than 3.5, a fibrous cap thickness less than 75, a lipid arc more than 180, and the presence of macrophages. And if you had all 4 OCT criteria in the same plaque, there was an event rate that was 7.5 times as high. And on this slide, I sort of plotted all the various combinations of those 4 criteria, as well as the prevalence. But you can see the Kaplan-Meier curves, how strikingly different it is when a patient had all 4 of these high-risk events in an LAD lesion. There was a secondary analysis from CLIMA that I liked very much, looking at calcified nodules. There are 2 types of calcified nodules, those with and without disruption. And if you have a calcified nodule that disrupts the fibrous cap, and you can see here the disruption of the fibrous cap, the event rate is much higher than if the calcified nodule is stable and quiescent. Then we come to COMBINE. COMBINE has yet to be published. It's impressed in the European Heart Journal. It was presented at TCT in 2020. COMBINE was a very interesting registry. It looked specifically at diabetic patients, specifically at intermediate lesions with an FFR more than 0.8, in an attempt to answer the question: if the FFR is above the ischemic threshold, are those lesions still vulnerable? And this was done, obviously, in a high-risk patient population that is a patient population of diabetics. And you can see that of about 400 patients, about 100 had a thin cap fibroatheroma by OCT, and about 300 did not have a thin cap fibroatheroma by OCT. And the event rate, when you had a thin cap fibroatheroma by OCT in an FFR negative lesion, the event rate is more than 4 times higher, indicating that FFR is not quite as fail-safe as we like to think. There are lesions and there are patients with FFR negative lesions that are high risk of events. What about treatment? Well, Prospect 2 had an embedded randomized trial of about 100 patients who had criteria for a high-risk lesion and were randomized to medical therapy alone versus absorbed BVS plus medical therapy. And I recognize that the absorbed BVS is no longer available, and we'll address that very briefly, with routine follow-up at about 2 years, with a primary endpoint being the IVUS minimum lumen area at 2 years of follow-up. Remember, these were, again, lesions and patients selected based upon the NIRS IVUS findings. And if you look at whether across the entire lesion or at the original MLA site, lesions treated with BVS plus medical therapy had a larger lumen area at follow-up compared to lesions treated with medical therapy alone. Now, as I said, this were 100 patients in each group, way underpowered for clinical endpoints, but you can see that there is no signal that this approach of an absorbed BVS plus medical therapy was associated with safety concerns at 2 years of follow-up. And in fact, when you look at primary clinical efficacy endpoint, although underpowered for statistical purposes, the event rate in the absorbed plus medical therapy group was half that in the medical therapy alone group. This is a clinical example. The patient was enrolled in Prospect 2. He had 2 intermediate lesions, one in the circumflex, one in the mid-right coronary. Both were negative in terms of FFR. The circumflex was not treated. The right coronary artery had a pretty nice result with implantation of the absorbed BVS. You can see here the large lipid core burden index of about 460. Well, the patient came back prematurely with events, and you can see that the circumflex lesion has progressed to total occlusion with an increased maximum LCBI. The patient was then followed to the endpoint at 25 months. And the right coronary artery remains intact and benign. So this is an example of a patient who had 2 lesions, one, if you will, acting as a control, and the control lesion progressed to total occlusion with an event, while the treated lesion was stable. Well, as I said, that's a relatively small study, 100 patients in each group. There is a large study being done in Seoul, Korea at Asan Medical Center. It's called the PREVENT trial. It initially started randomizing patients to optimal medical therapy versus BVS plus optimal medical therapy, similar to Prospect Absorb. Obviously, BVS disappeared while the study was being done. So this has been revised to either a BRS or an everolimus-eluting stent plus medical therapy versus medical therapy. We do not have the results yet, but we're eagerly awaiting these results to see whether they support the data of Prospect Absorb. So to summarize, it's been at least 32 years of baby steps from Jim Muller's first description to Prospect Absorb, with a few intermediate steps. Quite frankly, a really, really long process, but I think we can conclude that we can recognize vulnerable plaques reliably, and we're on the cusp of actually treating them. Thank you for your attention.
Yeah, I have a question for Dr. Mintz. Are questions allowed right now, or are they to be done in the end? Are we running short of time? Can we ask questions?
If time is actually there at the end of the whole session, then you will discuss. Otherwise, go to the next speaker.
Okay. Okay. If we are running short of time, we'll go to the next speaker.
Good evening, and it's a great honor and privilege to be presenting 2 of the hottest topics now, FFR-CT and CT myocardial perfusion imaging. The task I've been given is to discuss whether these are foes or friends. Let's see what the data shows. I have no conflicts of interest. Let's start with what is FFR-CT and CTP. Some of you are doing this, but it might help to just revise the background before we discuss the advantages and disadvantages. As you know, the FFR-CT is detecting epicardial coronary artery stenosis along the length of the vessel, whereas CTP is evaluating the entire vessel, including microcirculation. This gives each technique some niche advantages as well as disadvantages, and we will highlight some of that as we see the data. So what exactly is a FFR-CT and a CTP study?
Here is an example of a patient with an LAD lesion here. You can see some calcification on a CT scan. This is kind of moderate lesion, and often the question is, does this gentleman need to go for an angiogram or should we do another non-invasive test? The same patient also had an OM lesion, and we have two options. Instead of doing an angio, what you can do is do what's called CT-FFR, which is a mathematical way of using the boundary conditions of the vessel from the CT angiogram and mathematically calculate flow and flow reserve along the vessel. And as you can see, these numbers tell you that the flow reserve in this area is 0.85, the RCA looks good, and 0.91 here. The same thing in a different view. And then the angiogram confirmed that lesion. But CTP takes it a step further. Not only it tells us FFR information, but it also tells you myocardial blood flow. And here is a colorized map telling us there are no areas of myocardial perfusion defect in this patient. How about another patient? Here is another person with a tight LAD lesion and a CTO in the right coronary artery territory. And the angiogram confirmed that. The FFR CT showed exactly where you would expect ischemia to happen. And here it shows CTO. And then not surprisingly, the CT perfusion imaging shows you a defect in the LAD territory as well as the inferior wall defect. And then not surprisingly, the invasive FFR in the LAD confirmed that it was indeed a significant lesion. So you can easily see the strength of each of these techniques, but it gets even better and we can go into greater details. Here is an example. This is now looking at CTP with absolute myocardial blood flow quantitation across the whole heart, not just a snapshot of a defect which is ischemia positive or negative, but you can actually quantitate myocardial blood flow and relate it to myocardial function. And then you end up with a one-stop shop. The CTP also has developed even further, and you can see the advantages of knowing myocardial blood flow in terms of ml per unit of tissue. Here is a normal CT angiogram, and you can see normal CT perfusion. Whereas in this patient, the CT angiogram looks normal, but you can see extensive subendocardial ischemia, which is consistent with microvascular disease. This is something FFR CT cannot diagnose. In fact, some of the errors of FFR CT can happen with microvascular disease. And that is where CTP has excellent strength. It becomes even more interesting. Here is an example of a CT scan with instant restenosis and a vessel lesion in the D1. The regular static CTP study wasn't very clear, but when you do dynamic CTP study and do myocardial blood flow mapping, you can see exactly in the LAD D1 territory, you have an ischemic defect, and that matches with some gadolinium enhancement. Research in this area is progressing rapidly and it's getting even more comprehensive. So not only can we find the stenosis, but also we can find myocardial blood flow, and we can find infarcted and scarred areas. And if you combine that with CT delayed enhancement, it adds to the whole thing. And here is an example that if you have obstructive CAD and you have an ischemic perfusion defect on CTP, and you add scar burden based on CT late gadolinium enhancement, you get more prognostic information. So essentially, we are creating a one-stop shop looking at the vessel right from the beginning to the end. It gets even better on the CT side, FFR side too. You can actually use what's called a virtual planner to tell you how you will perform after doing an intervention. And here is a long lesion in the LAD before plasty, and here is the result after plasty, and here is the result before plasty. And if you mathematically abolish the stenosis and try to find out what the FFR would be, the CT FFR suggests that if you intervene on this lesion, you are likely to get a good result. And you can see the same thing here. This is the kind of a pull through in different lengths of the artery, and you can see the FFR CT pre matched with the blue line invasive FFR pre and post, they seem to be matching, suggesting there's a lot of benefit in doing these things. Now, what are the strengths and weaknesses of each other? And that's important to understand before we say they are friends or enemies. So as we said, FFRCT is very specific for the lesion, whereas CT perfusion is specific for the vascular bed. And hence, it is the only technique which can detect microvascular disease. It's not as good for planning intervention, but FFRCT can help you plan interventions. It's affected by scan quality a little more. CTP is affected, but not as much. And in some studies, about 30% of the scans are unreadable for FFRCT, especially if there is heavy calcification. One place where FFRCT scores is you don't need an extra scan. Just from a routine scan, you can extract this information, unlike CTP, where you have to do an extra scan in addition, and that's a slightly complex thing to do. And that makes it a little more tricky and adds a fair amount of radiation, which you don't have in FFRCT. And then, of course, you don't need to do a stress perfusion of the kind that we do with CT perfusion. The accuracy, surprisingly, are comparable. There is slightly higher specificity with CT perfusion. But one thing to remember is FFRCT is not as accurate around the area where we have the most difficulty. That is an invasive FFR of 0.8 plus minus 5. That area is where we have a lot of uncertainty, and surprisingly, FFRCT is slightly weaker in diagnosing that. It's very good in diagnosing extremes at both ends. So, is FFRCT and CTP friend or foe? First, let's compare it to invasive FFR. So invasive FFR is the gold standard for both of these techniques, FFRCT and CTP. And that's why it's not going to replace invasive FFR anytime soon, especially since there's no outcome data, unlike that for invasive FFR. But it will affect cath lab volumes. Cath lab volumes are likely to go down, but the patients who come to the lab are going to get higher rates of intervention because now you have diagnosed the exact group where intervention is going to make a benefit. And then especially for FFRCT, it might help you predict success of intervention. So this is likely to, in the next 5 to 10 years, as the uptake of FFRCT and CT perfusion slightly slower than FFRCT, if the uptake increases, it will change practice patterns in the cath lab. Here is an example from the Syntax study. Adding FFRCT in 7% of patients changed the treatment recommendation. In about 12% of patients, it changed the vessel that was going to be done. And then it changed the number of people with significant 3-vessel disease too. So it has an important role here. Unfortunately, we don't have the same kind of data for CTP yet, but it will come. What about comparing FFRCT and CTP to CTA? It's very clear now, both are better than CTA, and they really increase the specificity of CTA, which has been an Achilles heel for regular CT angiography. Here is an example of a meta-analysis showing what happens. The orange line is CTA, and if you see, if you add CTA and FFRCT, you're going to increase the accuracy further, and same way if you add CTP to CTA, you increase the accuracy further and you reduce the false negative significantly. How about comparing FFRCT to CTP? As I said, the performance is comparable. One advantage is FFRCT can also be done from the CT scan, which was being used to do CTP at a second stage. And so you could presumably have all three done in the same test. That becomes a little more cumbersome for the lab, but eventually as we get very fast at doing these things, that would be a good thing. And here is a study from Pontone's group in Italy showing that CTA plus FFRCT and CTA plus CTP are equivalent whether you look at it at a vessel level or at a patient level. So essentially, they are comparable and they are better than CT angiogram. But it brings us to a philosophical question. The uptake of FFRCT is slightly greater than uptake of CT perfusion, but both are not used as commonly as we thought it would One reason is the FFR CT, you have to send it to the vendor. There's a delay in that by the time the report comes back, and there is an extra expense. And so some labs have hesitated to do that. And CTP is slightly complex protocol. It has more radiation involved. Even if these two issues are solved, medicine is moving forward. There are other areas, medical therapy is improving. And you have to ponder on this question, what does ischemia mean if you look at it in the post-ischemia trial? As you remember, the ischemia study showed detecting ischemia and intervening upon that was more beneficial than just managing those patients conservatively. And then the question comes up, if you can exclude left main or three-vessel disease, how does it matter if there is a moderate amount of ischemia? And remember, both of these tests are testing ischemia. So this is something I want you to think about and take home, and there'll be a lot of debate in this area. So that was a quick whirlwind tour of CT-FFR and CT perfusion and how it's going to influence practice. Thank you. And so the answer would be, they are neither friend nor foe, but they can live together happily in selected patients. Greatly appreciate the opportunity. Happy to take questions.
Yeah, move on to the next talk.
Yeah, I think we should finish it, and then if we have 10 minutes of discussion, that would be good.
Okay. Dr. Ramindranath Chakraborty.
Yeah, yes. Yeah. I'm not able to get in the desktop. I should go to the desktop. I'm just not able to get in the desktop.
Can't you share your screen?
Yes, I'm trying to share my screen, but it should come to the desktop, which is not.
There is a green button. Click on the green button.
I've seen that. I'm clicking on that, but it's not taking me to the desktop. It should take me to the desktop.
Just done it. Okay.
So thank you. Straight away coming to the talk on the coronary computed tomography as first step in cardiology. And we all know that this particular data from CAD randomized trial, and very important information came from this trial saying that CCTA may hypothetically act as an effective gatekeeper to the catheterization laboratory in the diagnosis of stable patients with current indications for invasive coronary angiogram. This strategy will result in non-invasive outpatient-based triage of 2/3 of individuals without actionable coronary artery disease, obviating unnecessary invasive examination, and of course, a follow-up is needed. We do have advantages of CCTA, for example, having higher speed, less motion artifacts, a reduced bolus dose, the newer technology, and with high resolution, you can have better visualization of more coronary segments, improved visualization of calcified vessel lumen, improved visualization of stents and bypasses. And with a lot of data, we know that today the specificity could be as high as 97%, and sensitivity could be 88% with a positive predictive value of 97%. We also know today that coronary artery anomalies can probably best picked up by CCTA, which earlier required invasive coronary angiogram. But today with CCTA, it's extremely helpful not only to find out the anomaly of the coronary artery, it also helps us to know the course along which these anomalous coronary arteries travel to get into the heart muscle, which is extremely important for intervention cardiologists. There are studies to compare to prove that for the anomalous coronary artery detection, CCTA is a unique tool and is very helpful. This is an example. For example, this is one such example where you can see a three-dimensional image showing an anomalous left circumflex artery arising from right coronary sinus and coursing between the aorta and the left atrium, which is extremely important for us to know and could not have been picked up by routine invasive coronary angiogram. So the CCTA has application very useful in asymptomatic high-risk patients prior to major non-cardiac surgery, patients with atypical chest pain who are refractory chest pain with doubtful of coronary origin, non-conclusive stress test of doubtful Treadman analysis. It could be a substitution of conventional coronary angiography prior to PCI in high-risk patient aortic disease, because in addition to coronary artery, it gives us other information about the aorta, calcification, the tortuosity of the arteries. These are extremely helpful, which at times may not be picked up by invasive studies. It can also be an adjuvant to coronary angiography, like as we can understand the plaque characterization, complicated coronary catheterization, and more so in total coronary occlusion is very helpful. But there are contraindications. For example, there could be absolute contraindication, like a very fast rate or even very slow rate, very slow rate. There could be relative contraindication of chronic kidney disease, allergy, atrial fibrillation, multiple ectopics, high calcium scoring more than 1,000 Atherton, and inability to hold breath in certain individuals like COPD and advanced lung disease, and uncooperative patients or patients with some kind of phobia. The CCTA, in addition to coronary artery, also gives us information about the cardiac anatomy, for example, the atrium, ventricle. It also talks to us about aortic valve, whether bicuspid or tricuspid. It also gives us some information about papillary muscle, chordate, mitral valve, tricuspid valve, and also you could get some information about right ventricle, the outward tract, the pulmonary artery is very helpful, and left ventricle. And finally, of course, the coronary artery, its course, ramification, branches, and further course is extremely helpful. As I told you earlier, for coronary artery anomaly, many patients present with atypical chest pain, and CCTA is extremely helpful in this group of patients. For example, this is a case where there's complete absence of left main, which is very difficult to understand, but CCTA has picked up very nicely that hardly any left main, just a kind of a dot at the left coronary cusp. Similarly, right coronary artery rising from left sinus is left coronary cusp is extremely helpful. You can see not only the course and also the course between the pulmonary artery anteriorly and aorta posterior. Similarly, another one, you can see this, another view, you can see in various planes, you can see such anomalies. Left coronary, left circumflex artery again can also be picked up very nicely by CCTA. Myocardial bridge. Sometimes atypical chest pain and comes and goes. ECG, some kind of doubtful STT changes. CCTA is extremely helpful to show that there could be a myocardial bridge, which can be the cause of this diagnosis. We can also pick up pathologies, as I said, atherosclerotic plaques, aneurysm like this is the classical example of right coronary artery aneurysm at its proximal and mid-segment, coronary artery fistula, dissection, as you can see there, vasculitis, even connectivity disorder. Coronary artery fistula, you can see there is an example where circumflex fistula has been nicely picked up by this CCTA. The question of diagnostic accuracy by CCTA, it's been going on for years together because we are not quite sure whether the accuracy of diagnosis would be as good as the invasive study, because still today, the invasive coronary angiogram is gold standard. But the accuracy trial has shown that sensitivity could be as high as more than 95% to 99%, and specificity could be more than 65 to 85%. The EVINC trial has shown highest diagnostic accuracy. For instant restenosis, CCT initially had some limitations due to blooming artifacts of the stent. But the new generation of stents with newer metals and newer alloys, the accuracy has improved and is again a good technique for BVS, for example. CABG graft evaluation from 2 meta-analyses has shown the accuracies could be as high as 98%. Coming to the prognostic implications from CCTA, confirmed study is an observational study, has shown nearly more than 2.5-fold higher mortality in patients with lesions more than 70% in any arteries over a period of 3 years follow-up. Plaque characteristic by CCTA has shown correlation with acute ischemic event in 5 years' time, especially with low attenuated plaque, which can be nicely picked up by CCTA and often is missed by invasive coronary angiogram. Figure-out study has shown volume of ischemic myocardium, which is correlated well with atherosclerotic plaque burden by CCTA. And in this situation, probably the FFR-CT or CT-FFR can also be of some help to understand the myocardial perfusion situation in ischemic heart disease. Role of CCTA from prognostic point of view in acute coronary syndrome, there are 2 trials, CATCH trial and BACON trial. It indicated some prognostic guidance, but there are a lot of data which remain to be further substantiated by more information. As I told you, soft plaque, this is an example of soft plaque where you can see it can be easily picked up. Severe stenosis can also be picked up. Non-calcified plaque in the origin left main, very nicely shown, you can see here in this particular picture. And severe stenosis of left main, which often can be missed, particularly if it is somewhere there, and it at times can be risky to do an invasive study in this group of patients. Chronic total occlusion, CCTA, could be a very important step, especially when the occlusion, it can tell us about the occlusion length, the calcification, the stump morphology, and whether the stump can be tapered or not. This is such example, an occluded diagonal stump can be picked up by CCTA. Another example where totally occluded right coronary artery angiographically showed a distance, length, and I'm sure that you can find a passage through which the wear can be negotiated. Thrombus, again, which apparently angiographically may look like total occlusion, but CCT has shown there's a thrombus. Finally, patent stent. Initially, there was some problem, but the newer generation stent, it's very helpful image technology to pick up the image. And the significance of instant restenosis in proximal right coronary arteries, again, has shown in this view, you can see that significant instant restenosis in right coronary artery. Stent in mid-RCA, again, there is just beyond the stent, there is critical narrowing, can be nicely picked up by CCTA. Graft imaging, for graft imaging, again, a very useful tool of CCTA. This is an example of 76-year gentleman with atypical chest pain after CABG, but nicely shown the grafts are patent, very, very useful information. Sometimes you can see this is a situation that's picked up by Dr. Kushnar's data from her textbook, that graft is actually adhered with the sternum and CCTA as nicely picked up. Sometimes a very sort of atypical chest pain, minor plaque, angiographically is normal, but these are the group of patients where there could be higher event. Therefore, the CCTA is extremely helpful in asymptomatic individual with a strong family history of coronary heart disease, with hyperlipidemia. These group of patients, that has been shown by studies that if you actually commence them with statin right at the beginning, especially the high risk individual, even they are asymptomatic with high lipid score and very strong family history, then the event can be actually postponed by picking up such images. And so therefore, it's very helpful in this group of patients. It also picks up the calcium in the aortic root, aortic valve, and others. But it has limitations, especially with fast heart rate, high calcium score, in presence of multiple stents, in presence of heavy contrast, chronic kidney disease, and even today in small vessels and collaterals, difficult to pick up. It's difficult to pick up in obese individual and with high radiation. And CCT-HFR has already been spoken by Dr. Chandrasekhar. So to conclude, I must say that CCT is helpful even from the calcium scoring point of view. If you find calcium score is 0, but at the same time there is a high risk individual having a strong family history and other parameters like high lipid and minor plaque without any calcium can be actually treated medically, and some events can be postponed at a later stage. So to conclude, the CCTA scanners are robust new scanners capable of performing routine scans as well as CTA and cardiac studies without technical problem. It's easy to perform, almost without complication, enabling screening patient refer for coronary catheterization. In atypical chest pain, high-risk categories, ACS categories in some individual, in CTOs, grafts, and for some patient post-PCI chest pain is very useful. Main indication of CCT of the heart are coronary arteries, but additional information like structure of heart, calcium, they all, the tortuous anatomies can be picked up. They allow faster scanning with routine thin slice and isotropic spatial orientation, spatial resolution with reduced radiation dose. More technology is coming up. Radiation is bringing down. With prospective ECG gating, radiation can be minimized. I'm sure with the newer technology, it could be furthermore really a first step for invasive cardiologists. Thank you very much for your attention.
Thank you, Dr. Chakraborty. I think we can have a few questions. Is Dr. Akiko Mehra still here?
Yes.
Still with us?
Yes.
Yes, Dr. Mehra. So some quick questions for you. 60-year-old lady, diabetic lady with diffuse coronary artery disease posted for an LAD angioplasty, OCT or IVUS?
IVUS.
Someone with a CTO in a diabetic patient, OCT or IVUS?
IVUS.
Someone with a distal left main stem with 2 stents, OCT or IVUS?
Both. Either.
Instant restenosis, OCT or IVUS?
OCT.
What about acute coronary syndrome? So this, I want to ask the question. So someone has come in who has a very patent artery post an acute coronary syndrome. So in that case, you would use OCT or IVUS?
OCT.
Okay, and now someone has come who has got a occluded artery. This is acute, and you have just recanalized it, and there is just flow in that artery. Would you use OCT or HD IVUS?
IVUS. OCT cannot see if the TIMI flow too, or just after recanalization.
Okay, and finally, calcium. If you have a calcific lesion and you want to assess whether it should have this patient should have IVL or not, would you say that imaging is mandatory, because we see a lot of patients who are not having intravascular imaging and going for IVL based on the calcific lesion on angiography?
I think so.
Okay, thank you very much. Any other questions for Dr. Mehra? Because otherwise we'll move on to Dr. Gary Mintz.
Devdatta, can you ask same questions to Dr. Mintz as well?
Yes, Dr. Mintz, are you with us?
Yes, I am here.
Okay, so Bin Chakraborty requested that I ask you the same questions that I asked Dr. Mehra, though your talk was different. So for diffuse disease, would you use IVUS or OCT?
I think there are limitations to both. I think it's whichever one you're most comfortable with.
Okay, for calcific lesions?
Same answer. They both give you good diagnostic information. It's whatever one you're most comfortable with.
For CTO, it is IVUS, I think. Okay. For distal LMCA with 2 stents?
I would favor, you're talking about placing 2 stents, not instant restenosis. The data favors IVUS. There's no OCT data.
Okay. For instant restenosis, it is OCT. Yes. And for ACS, there are 2 questions that we ask. That one in where the vessel is flowing. So if someone has come post thrombolysis and you find a 90% stenosis, and you do imaging, so then in that case,
OCT.
and someone who has come whose vessel is occluded and you have just recanalized it and you want to have a look.
IVUS, you won't see anything with OCT.
Yeah. Much. And Dr. Mintz, I would like you to answer the question on...
Let me just, you're asking us to pick one or the other. That's really not totally fair, because even though, for example, with in-stent restenosis, I favor OCT, if you don't have OCT, IVUS will still give you a lot of information.
Sure.
So it's not dichotomous. 90% of the time, you can probably pick either one and get more information than the angiogram alone. Sorry.
Absolutely, sir. In fact, in your paper, you have already written that that is the wrong question sometimes to ask whether it is this or that. The right question is intravascular imaging over angiography. Yeah. And if you don't have OCT, you should go for IVUS because it still gives you a lot of information. But just to make it interesting, we asked you these questions. And the talk that you gave on vulnerable plaque. So and you showed that very interesting case where the circumflex lesion had progressed and the RCA had been stented and it had not. My question to you is that if you find a plaque which is in a lesser important vessel, like that circumflex artery, which has not a large area of supply, and there is a vulnerable plaque there according to the lipid core burden index, would it be prudent to stent it, or as we now know that there are more aggressive lipid-lowering drugs like PCSK9 inhibitors, and we have data on intravascular imaging that they actually cause plaque regression. So what's your impression based on trials about what should be the correct approach?
Well, the problem is we have one randomized trial of less than 200 patients. And to base clinical practice on such little data is not correct. It is a hint that may be the result or the way we should be treating these patients in the future. But unless we have the right trial that is asking the right question, for example, PCSK9 versus a stent, you just can't make that a blanket conclusion based upon 200 patients. The problem is, as Chandrasekhar mentioned, this is a rapidly moving field. And so the studies that we start today that give an answer in 5 years can be eclipsed by better medical therapy or better stents or something else entirely.
Yeah, so let me just put it in another fashion. So if this was...
session, please.
Oh,
just
okay.
Quick comments, one or two comments, and then finish.
Okay. Anyone else would like to ask questions to the speakers?
No question. Just comment.
I think we should conclude. I wouldn't like to pass any comment. I had more questions, but let it be there. Dr. Mintz might want to pass a comment, or Dr. Mehra, and then we can conclude.
Yes.
No, as I said, and you mentioned it, the question should always be, what gives you more information than the angiogram alone? And when we're talking about treating patients in the cath lab with PCI, some form of intravascular imaging eclipses everything that you see with angiography. And we have data in so many studies of so many different kinds. And so any busy interventionalist needs to be familiar with intravascular imaging. And if they only are familiar with one, that's fine. If their practice is large enough, they should be familiar with multiple techniques.
Thank you very much. Very well said. Thank you. I think, Dr. Rinaldo, we can conclude here.
Yeah.
Thanks to all the speakers, and it was a wonderful session. And thanks for the participation of everybody.
Thank you, respected chairpersons and speakers of this previous session for this enlightening session. Our next session deals with the hot favorite, TAVR. Chairing this session will be Dr. Ramesh Daggubati, Dr. A. Srinivas Kumar, Dr. P.K. Hazra, and Dr. Ravikant Patil. Moderating this session will be Dr. Sanjay Mehrotra. Expert panelists include Dr. Sengotu Belu, Dr. C. Raghu, Dr. John Jose, Dr. A. Javid, Dr. Shunib Banerjee, Dr. Manik Chopra, Dr. Sharad Chandra, Dr. Dilip Kumar, and Dr. Amit Chaurash.
Yeah, good evening, friends. Is Dr. Ramesh there, logged in already? Yeah, good evening, friends. As we move on to... Sir?
Yeah, hey, Dr. Srinivas Kumar, I'm here. Please go ahead and start. Yeah.
Yeah, good evening, everybody. As we all know that we are becoming more and more interested in TAVR procedures, and more number of patients are being undertaken for this procedure. And we also see a lot of younger patients also being taken up. I think we need to balance ourselves and try to do what is best for the patients, and which are the subtypes in which TAVR has advantages over SAVR in the other way. And then some of the problems which we encounter when we are doing such patients procedures, and when the young patients come for the procedure again regarding the repeat coronary access, and some of the problems we face with this TAVR like heart blocks and paravalvular leak. These are some of the interesting things which will be discussed in this session. And we think we can have lectures from our colleagues, and then we can have discussion at the end. I think before we go on to the lectures, Ramesh, a few comments from you.
Oh, I think fantastic session so far. We are looking forward for the talks. And as you know, at the TVT data now is showing that even low-risk patients having with the second generation Ultra or Evolute Pro are still having a higher chance of pacemaker rates, about 10 to 15%. So I think we need to make sure that we are choosing the right population rather than the valve itself. So as we approach for low risk, please be careful about how we deploy the devices, and we are learning. The volume of the center did not matter, but the operator volume, individual volume, did make a difference in outcomes for these patients. Look forward for all the talks. Thank you, Dr. Srinivas Kumar.
Hello, Dr. Srinivas Kumar. How are you?
Yeah, fine, sir. Good evening.
So I think we should get going, Dr. Srinivas Kumar. Is that okay?
Yeah.
So we have the panel, we have the chairpersons on board, I suppose. So as we see, I was instructed by the organizers that we should try to keep in time, although I think we are a bit late. So the first lecture is by Professor Lars Sondergaard from Copenhagen, Denmark, who is going to talk about the challenges for TAVR and non-partner cohort, which is a very interesting topic. As we all know that we have a reasonable, good understanding about the high risk, the moderate risk, and the low risk patients, and how the TAVR has fared. And we all, as you said, Dr. Srinivas Kumar, that we have these concerns about what is going to be the usage of TAVR, what are the limitations, and how we will challenge this issue, especially in a small annulus. I am actually quite worried about a small annulus bicuspid aortic valve. How do we treat? So we invite Dr. Sondergaard to take the first lecture, which is the challenges for TAVR in non-partner cohort. Dr. Sondergaard?
So thank you for the invitation to talk about patients undergoing transcatheter aortic valve replacement who were not represented in the partner trial. So we saw these two low-risk trials presented in 2019, the partner TREAT study, including patients at low surgical risk, randomized between TAVR with the SAPIEN platform and surgical aortic valve replacement. So the primary endpoint was a composite all-cause mortality, stroke, and rehospitalization at 1 year. And TAVR showed that it was superior to surgical aortic valve replacement. At the same time, the Evolute low risk using the CoreValve Evolute platform randomized patients again between TAVI and surgery. The primary endpoint was a bit different. It was all-cause mortality and disabling stroke only, and it showed it was non-inferior for doing TAVI compared to surgery at 2 years. But one thing you have to remember, despite of these encouraging results, is that this was highly selected patients. And you can ask yourself, what did low risk mean? Of course, according to the study protocol, it meant that patients need to be at low surgical risk. But you could also argue that these patients were at low risk for suboptimal outcome after TAVI. So patient not suitable for a safe transfemoral access, patient with who did not have a high takeoff of the coronary arteries, who did not have tricuspid aortic valve, and who had severe calcification in the aortic annulus or LVOT calcification. These patients was excluded from the trial, and that was about 1/3 of the patient screened. So you can also say that these two trials do not necessarily represent all comers, patient with severe aortic stenosis at low surgical risk. Some of these patients may be better served with surgical aortic valve replacement. It's also important to understand that these patients were elderly. And we've seen a number of different trials comparing TAVI and surgical aortic valve replacement with an STS score ranging from almost 12% down to less than 2% in the two last trials. But as you see here, the age have not really changed. Mean age has been around 80 years. It came a little bit down with the two low-risk trials to 74 years, but it's not younger patients. It's not patients with longer life expectancy. And instead of talking about patient at low surgical risk, because that can be an elderly patient, we should talk about patient with longer life expectancy. And if you treat these patients, there will be a lot of issues which is not relevant for elderly patients with limited life expectancy, such as what is the impact of new conduction abnormality, access to the coronary arteries, what about patients with bicuspid aortic valve, and what about durability of these bioprosthetic aortic valves. So for conduction abnormality, we know there's a close proximity between the aortic annulus and the conduction system. And if the valve is implanted too deep or it's oversized, there is a risk of new onset left bundle branch block or even third-degree AV block with the need for permanent pacemaker. So that's been a suggestion to move from a classical three-cusp coplanar view, which is often with your C-arm projection in an LAO cranial projection, towards an RAO caudal, what we call a right-left cusp overlap view, which can be determined on CT scan. In this view, you're going to elongate the left ventricular outflow tract and thereby have a better understanding how deep your implant is. And thereby, you can actually implant in a high position, use the rate of new onset conduction abnormality. And also, what about access to the coronary arteries? We can divide all TAVI platforms into three groups: those with a low stent frame and internal leaflet position, and those with a high stent frame with either an intra or supra-anal leaflet position. And particularly for the last one, it can be difficult or sometimes even impossible to access the coronary arteries after a transcatheter heart valve replacement. And the reason is often that we don't have commissural alignment. So when the valve is implanted, it's rotated in a random position in the aortic annulus. And if you have, as you see here on the left-hand side, the leaflet post right in front of the coronary arteries, it will be difficult or even impossible to access the coronary arteries. So what we should aim for is the same as the surgeons are doing, to have commissural alignment. And it's actually not that difficult. If you know the landmark of your stent frame or your leaflet post, this is for the Evolut platform. You see here there's two paddles, which is using to attach it to the delivery system. One is a C paddle, and that's positioned right over a leaflet post. And again, if you're working in this cusp overlap view, right and left cusp is overlapping, you can see that on the far right of your fluoro screen, you're going to have one of the commissures. So the only thing you need to do here is to position one of the leaflet posts here as marked here with the C paddle of the head configuration. If you do that before valve deployment, you're actually going to have patient-specific commissural alignment. So as you cross the aortic valve, you go to this left-right cusp overlap view, check whether you have this configuration. If not, you do a small torque on the delivery system until you get it, and then you deploy the valve, and afterwards you can see that the C paddle is actually on the far right of the screen, meaning that you have patient-specific commissural alignment. And this can be done for all self-expanding technologies. What about patient with bicuspid aortic valve? We know if you're going to move to patient at a younger age, we're going to see more patients coming forward with aortic stenosis based on bicuspid aortic valve. And the anatomy of these valves is very different from tricuspid aortic valves. And remember, despite we have seen all the encouraging results with TAVI compared to surgical aortic valve replacement, all patients with bicuspid aortic valve has been excluded for these trials. So we don't really know how TAVI is performing according to surgery in these patients at a younger age with bicuspid aortic valve. And for the time being, we should not treat them, but send them for surgery. And also, if you treat this patient, elderly patient with bicuspid aortic valve, you will have a risk that the stent frame is not going to be circular, but it's going to be elliptical. And you don't have a circular configuration of your leaflets. It'll also be elliptical. And how is that going to affect the durability of these valves? Is it going to be impaired? And talking about durability, this is, of course, important if you're going to move to younger patients with longer life expectancy. And as for surgical bioprosthetic aortic valve, also for transcatheter aortic valve, this is going to be different from depending on what kind of valve you're using. So there's two main valves used today, this balloon expandable Sapien platform or MyValve, or the self-expanding platform as the Evolut or the Hydra valve, and they're very different. So self-expanding technology offers much better hemodynamic performance compared to balloon expandable. And this is also reflected in the durability. So if you look here on the 8 years data from the Notion trial, you can see that for a patient undergoing TAVI with a self-expanding technology, this time a core valve, the rate of valve failure is at least numerically lower than it is for surgery, 7 compared to 10% failure rate at 8 years. But if you look at balloon expandable valve, Sapien or MyValve, you see at 5 years, there's a much higher rate of valve failure with balloon expandable valve compared to surgery, because these valves do not offer the same hemodynamic performance as self-expanding technology. So again, when extending the indications for TAVI, be critical, not opportunistic about the evidence. Remember that short-term outcomes may not be sufficient to support TAVI in patients with longer life expectancy. And I think that the heart team is even more important now in order to make the best counseling for each individual patient with aortic stenosis about the treatment options. Thank you.
Probably will leave the questions right now for the end. So, and I think I have a question, so it probably would be a good idea to note down your questions, and we will do it at the end of the meeting if there is time. The second lecture is by Dr. Tarun Chakravarti on the access to the coronary artery after TAVR in a valve-in-valve patient. So I will invite Dr. Tarun Chakravarti to give his lecture. Of course, we have some questions, which I would suggest that if our chairpersons and the expert panelists have them, and we can probably have about 10 minutes of discussion so that we can finish the lectures and have these discussions in the end. Dr. Tarun?
Hi there, can you hear me?
Yes, we can hear you very well.
Oh, excellent. Let me share my screen and then I'll get started. Okay, can you see my screen?
Yeah, we can see your screen very well.
Excellent, excellent. Okay, so good evening, everyone. It's late in the evening there. It's a privilege to be on this call and give this talk. Thank you for the kind invite. So and here's my disclosures. So my title is to discuss coronary access, and I think coronary access, it's a spectrum of challenges. Starting from preventing coronary occlusion during TAVR, then moving on to accessing coronary artery acutely during TAVR if there is coronary occlusion, and then of course access coronary artery after TAVR for new coronary lesions or staged PCI or acute coronary syndrome. Now here's a brief summary of factors that influence coronary access issues. And long story short, any coronary that's located behind the skirt of the valve or behind the commissure, or if the patient has very shallow sinuses, very tight sinuses, all those factors will lead to challenging coronary access after TAVR. Here's some data that we published from our center. One of our fellows published this. So we took post-TAVR CTs. These were almost 400 patients who underwent Sapien 3 TAVR, and these patients underwent CT afterwards. And so we looked at the location of the coronary artery and see how it correlates with the coronary access. So any coronary that's located behind the skirt, it'll be hard to get back into after TAVI, and any coronary that's located behind this space will be difficult to get back into. So 15% of patients had left main coronary in this unfavorable location, and 8% of patients had right coronary artery in this unfavorable location. We did the same analysis for evolute valve. These were around 66 patients with evolute who had CT done post TAVR. And coronary access is much more challenging with evolute because the leaflets are supraannular and the skirt and the valve frame is taller. So almost 35%, almost one-third of patients had challenging left main location after TAVI, and up to a quarter of the patients with RCA had RCA location behind the in challenging position. We further extended this analysis to potentials for challenging coronary access when these patients undergo TAVR and TAVR. And again, the issues are the same, but here we assumed if we sequester the commissure with the valve frame, it'll be very hard to get back into the coronary artery. And so if you look at the risk of sinus sequestration, the risk is significantly higher with evolute. It goes to as high as 39 to 45%. With SAPIEN 3, at least the risk of sinus sequestration remains low, even if you do SAPIEN and SAPIEN in future, because the valve frame is short. Now, here's some data from Mount Sinai, a multi-center study that looked at the predicting a commissural alignment. You know, the goal for TAVR valve deployment should be to do a surgery-like deployment, where the commissures are aligned the way surgeons deploy the valve. And so Gilbert Tang, he loaded the SAPIEN 3 valve in multiple orientations and reported that it's impossible to achieve predictable coronary commissural alignment after SAPIEN 3. But with evolute valve, with their HAT technique, where they align the radiopig marker on the outer curvature of aorta, they were able to achieve commissural alignment in a significant number of patients, which would facilitate coronary alignment access in future. And lastly, for valve in valve, this is a very important marker, virtual valve frame to the coronary artery distance, which is basically a measure of how big the sinus is in relation to the transcatheter heart valve. So you deploy a virtual valve in 3Mencio software, and then you measure the distance from this valve to the ostium of the coronary artery. And if the distance is less than 3 millimeter, it's high risk. Distance of 3 to 6 millimeter is considered intermediate, and greater than 6 millimeter is considered low risk. So here's an example of a patient with big sinuses. So the distance from the virtual valve frame to the coronary ostium is 11 millimeters. So the risk of coronary occlusion here is almost negligible. Here's a patient where the distance is 6.7 millimeters. You're getting there, but it's still intermediate risk. You could get away with it. And here's a patient where the distance is 0.5 millimeter. So this is a coronary that may close off after deploying a valve. And even if the coronary does not occlude, this is a coronary that may be very hard to get back into in future to access. Now, this, so, and when it comes to, especially to valve in valve challenges, there's a few valve types that are especially challenging. Mitral flow and trifecta are notorious because these are special valves where the valve leaflets are located outside the valve frame. So when there are no surgical valve struts that are protecting the coronaries from the leaflets. So mitral flow and trifecta carry a very high risk of coronary occlusion. And the third valve type is the stentless valves, again, because there is no frame protecting the coronaries. Besides these, when you do valve in valve, there is more hardware in the sinuses. So of course, the coronary access can be challenging. And of course, when you do valve in valve in future, when these patients live long enough, we'll be doing a third valve in this space, and it'll become even more relevant. So, now I show the good, the bad, and the ugly of coronary access. So I'll show you a case. This is a case we just did 2 days ago. This video should play. So this is a patient who was referred for TAVI. It's hard to see, but he's 68-year-old. No, I'm sorry. This is a case we did last year. This is a 68-year-old who was referred to us for TAVI with an EF of 20%, 3-vessel disease, significant left main stenosis, and his coronary height is okay. His sinuses are big. The concern for coronary occlusion during TAVI or challenging coronary access after TAVI was low. So we decided to perform TAVI. We put a balloon in the coronary. We were ready to deploy the stent, balloon the coronary if there was hemodynamic compromise, but patient tolerated the procedure well, and we brought him back a month later. and we performed a PCI to the left main with Impella. His EF continued to be low. So we performed PCI with Impella with a few drug-eluting stents, and we didn't encounter any issues accessing the coronary. Now, this is a case that we did 2 days ago. 86-year-old he presented with cardiogenic shock to the hospital. He probably developed acute AI of a degenerative valve leaflet that just broke off. This valve was 18 years old, and it's an epic valve, very hard to see fluoroscopically. And, coronary risk is high. The left main coronary height is 7.4. The virtual distance is 2.3 from the TAVI valve frame to the coronary artery. And we were planning to fracture this valve because in the ID for a 23 epic valve is 19 millimeters, so we expected high gradients. So we protected both left and right coronary arteries in this case for preserving coronary access. We deployed the valve, we fractured the valve, and then we took a picture of the coronaries. The RCA remained above the valve frame, so it was no concern. And we did a thorough assessment of the left main. It's behind the valve, but it's above the surgical valve leaflets. We also measured the virtual distance on echo, and the virtual distance from the valve frame to the coronary measured 4 millimeter. So we decided not to stent this. We took the stent out, and patient did okay. Now here's a patient. So mitral flow and trifecta are the two worst valves for coronary occlusion. And here's a patient, 90-year-old, who was referred for valve and valve. Patient had a 21 mitral flow. The coronary height for both RCA and left main was low, 5.5 and 7.4. So we performed TAVI and we protected both left coronary artery and the right coronary artery. The mean gradient post-deployment was high, so we decided to fracture this valve. We went with a true balloon. We performed high pressure dilation, and if you look here, we fractured the valve. This edge straightened. And afterwards, the sinuses were sequestered. So we went ahead and we stented the left main artery and the right coronary artery also with an excellent result. Now, here's a more dramatic case, 71-year-old. She had a mitral flow valve that was placed 3 years prior and then presented with valve failure, drop in EF to 30%. Her access was okay, but her left main height was 6.3. And this is a mitral flow valve, so the risk of coronary occlusion is very high. So we went ahead, we protected both left and right coronary arteries, and then we stented the valve. We deployed the valve. Immediately following valve deployment, she goes into VFib, cardiac standstill. We put it on ECMO right away. But before we put it on ECMO, we brought the stent back and we deployed it. And she was coding. It was hard to, but she continued to code despite stent deployment in the left main. So we went ahead, put it on ECMO. We first stented her RCA. We brought the RCA stent back and stented this. And then we realized that the left main was occluded and we couldn't get back in. So here we actually took an Astarto wire, a peripheral Astarto wire. We drilled a hole because the surgical valve leaflet is in front of the coronary. So we drilled a hole in the coronary with this Astarto wire, advanced this Corsair catheter, wired the left main into the LAD, and then stented it. We got flow. She came off ECMO in the Cath lab. She was sent to the ICU, discharged home 5 days later. Now I'm running out of time, so I'm going to move quickly. Here's a 66-year-old female patient who again had a trifecta valve. And she underwent an evolute valve because we wanted to give her better hemodynamics. But evolute valves are self-expanding and they continue to expand. So 20 minutes later, when she's trying to be extubated, she codes. And then we go back and look, and her coronary is occluded. And we try multiple catheters, multiple wires. Finally, same process. We're able to drill a hole in the surgical valve leaflets and get an Astarto wire down. We exchanged it for a Fielder XT. We stented, but unfortunately, this patient passed away because she had a very long downtime. Here's a case of basilica. Basilica is to slice the surgical valve leaflets that preserves access to coronaries in future. So she had a mitral flow valve and low coronaries again. Left main height was 2.9 millimeter. So we went ahead. We performed a basilica procedure to slice the leaflets, and here you can see the leaflet is split into half because we've cut it with the wire. And following that, we performed valve-in-valve TAVR, and we didn't have to stent the coronary. An excellent result. And this is the last case. So this is a patient, 86-year-old, who underwent TAVI, and we stented the left main. We preserved flow, but this patient came back a year later with chest pain. We couldn't get back into the coronary. We could get non-selective injections. We tried on 2 different occasions, 3 different operators, every possible catheter. We could not get back into the coronary, so we had to send this patient for surgery. So, and I'm going to skip this. So in conclusion, the risk of coronary occlusion during TAVI or access after TAVI, it's an interplay of multiple factors, not one factor alone. Young patients with longer life expectancy who are at risk for coronary occlusion during TAVR, or where there is concern for challenging coronary access after TAVR, they may be suitable for surgical AVR, and then these are the factors that should be taken into account when deciding which therapy is the best therapy for these young patients. Thank you.
Thank you, Dr. Chakrabarty. That was a wonderful lecture, and especially for those operators who have achieved a certain number of TAVR now. We are not far from getting into these kinds of situations, and I'm pretty sure that those who have done large numbers have already, encountered these issues. I think probably we will, because Dr. Chakrabarty is already online, I will request the chairpersons, would they have at least 1 or 2 questions to move forward? Dr. Dugubati, whether he would like to, ask some question or make a comment.
Dr. Sanjay, can I?
Yeah, sure. Go ahead.
Yeah, Dr. Tarun Chakravarty, thanks for a nice lecture. I think what we need to understand where we are going now is, instead of seeing the patient with high risk, low risk for surgery, we should devise a system of identifying the right patient for TAVR. And if patient is suitable for TAVR, do TAVR. If patient is not, then he goes for surgery. It's almost moving to a stage like coronary revascularization. And one of the important aspects, I would say, is coronary heights, apart from many others. I think if it is too close, at least in our scenario, unless you have a very strong indication for against doing surgery, we shouldn't be like both. You showed one cases where you have to stent both right and left. That is stretching too far, I feel. What are your thoughts on that?
You're absolutely right. I think when we are dealing with young patients, I think the 2 biggest issues are coronary access and pacemaker. Yes. So you're absolutely right. If there are surgical options and there is concern for coronary occlusion during TAVR or challenging access to coronary after TAVR, certainly surgery should be the preferred approach. That's our approach also. And the patients I showed you, these are all an average age of 85. So it's a different patient population. But you're absolutely right. For young patients, where the approach should be anatomic approach, especially in younger patients. And if the anatomy is not suitable for TAVR for one reason or the other, surgery would be the preferred approach.
I totally agree.
Can I ask one question?
Yeah, who's that? Hi, Dr. Secretary. How are you? Please go ahead. Please go ahead. Yeah.
No, I just want to ask.
We'll allow one question, then we'll move forward.
Fantastic. Tarun, nice to see you, Tarun. Just want to ask you about TAV and TAV. I think that's one of the really fearsome for coronary occlusion. So I didn't see any of your cases for TAV and TAV. So what is your experience on coronary obstruction and TAV?
For TAVR and TAVR, we have not encountered coronary occlusion so far. I'm sure it'll happen one day. But I think with TAVR and TAVR, the bigger issue is not really coronary occlusion. The bigger issue is access to coronary following TAVR and TAVR. Because once you put a new valve, especially if you put a self-expand, if you're doing if your first valve was self-expanding valve with supraannular leaflets, when you put a second valve inside this, we have turned this sinus into a tube, into a cylinder. And to get back into the coronaries following this TAVR and TAVR would be extremely challenging. With SAPIEN 3, it's a shorter valve frame, so its access to coronaries still remains reasonable. But our experience with TAVR and TAVR has, in terms of coronary occlusion, we have not seen any. But also we haven't seen we are a very high volume center. We've done over 3,000 TAVIs. I would say TAVR and TAVR, maybe we've done 50 total. So the experience, even in a very high volume center, is not as much. But in the next 5 years, we're going to see a lot more because now we are treating low risk patients. They will come back with valve failure. Our previous patient population, the patients would outlive the valve. So, but we have not seen coronary occlusion so far with TAVR and TAVR.
So totally agree, and I feel that as we move forward, we would have issues like which valve to use, what is what is the skirt height, the commissural alignment, and the life expectancy of a patient, how young he is, and these are very important questions. You cannot ignore these questions. With that background, the second most important concern, which I think is the highest concern, is the need for a pacemaker. So we will invite now Dr. John Joes to talk about predicting and managing high-grade AV block after TAVR. So Dr. John Joes.
Hi, I'm Dr. Hajra in place of John. Can I?
Hi, Dr. Hajra. Yeah, sure. Please go ahead. Please, that will be.
Can I share my screen? Can I see?
I can see you. I can see you, but I can't see your slides as yet. Yeah, we got your slides now.
Respected Dr. Mehratra, Sanjay, Sengutu, Ramesh. So my talk is high-grade AV block predictions and management. I'm from Kolkata. Now in 2021, we do not call it left bundle branch block. We call it LB delay. That means left bundle delay or right bundle delay. Because now we know that if you do the ganglionic plexus ablations, these AV blocks, the LVB can be corrected. This pacing can correct the LVB. We can recapture the LVB block and make it look like sinus rhythm. Now, in TAVR, what is most important to understand the membranous septum, the gateway of your conduction system to the membranous system. This membranous septum is divided in two parts, atrial part and the ventricular part. And once we cross this tight gate, then it's a freeway, either on the left bundle branch, right bundle branch, left ventrivesicle, posterior vesicle. And it doesn't mean that once you have a pacemaker already implanted in TAVR patients, like those who have CRTPs, CCM, his bundle, LVB zone pacing in 2021, you can still do harm by pushing the valve too much down, and you can ignore, or you can, the basic purpose of putting this Evolut Pro seal, paravalvular leak, or you can hinge on a pre-existing mitral valve device like mitral clip. You can cause mitral valve inflow obstruction. So perfect landing is very important. And we have now many trials, different types of valve, which varies from 4 to 31%, SAPIEN, Evolut R. But as the technology is improving, there are more and more operators with proctorships, like many of our seniors. They're helping the juniors to learn, to practice, and they're teaching tremendously. And the rate of Indian patients having TAVR and requiring pacemaker is also coming down. So we have Indian pride, and this my valve is almost 0%. So valve is important, the technique is important, the imaging is important. Now the operator volumes and the volume in particular center is also important. In the high volume center, it is as low as 1.9%. But in this beautiful graph, what you can see, if somebody is doing for the first time, if he's not gone through the learning and the proctorship has not done a good training under proctorship, he can land up with low positions and can do harm by having more requirement of this pacemaker. And these are devices which cannot be removed from the body. It's a permanent device and can cause some problem like endocarditis. Pre-existing RBB, everybody knows that the most serious underlying mechanism by which you can develop high-grade AV block. Other things like baseline atrial fibrillations, baseline PR interval, QRS interval, calcifications is very important, volumes, and the distribution pattern is also important to impinge on the membranous septum or conduction system. Now we know this Gaspal overlap view is very important to remove the parallax, and we know that this NCC is the lowest portion. Whatever you try, sometimes there will be mistake, the valve can drive in can dive down into the LVOT, can damage the LVOT, can cause some problem with the conduction system. So we have now CT scan, which can help us to decide which is the best projections for cuspal overlap view. So these dots can be joined by CT scan. This is non-coronary cusp, right and left, one line, and almost I would recommend, and nobody recommends in our proctors, nobody recommends almost zero. But even if we start zero, it will dive down because some valves move up with the deployment. So you have to be very careful with the control of the valve. But in spite of good knowledge of implantation, good technique, you do develop these heart blocks. So what is new in 2021? We know that the membranous septum is most important. And recent study from New York, Langone Health examined the use of minimizing depth according to the membranous septum approach to evolute R. And they have shown that it is very important. RBB, the odds ratio is 3.36. And if you have membranous length less than 5 millimeter, it's very, very high risk for developing because it is a condensed zones. It is like a toll booth and it is a very tight gate. If you crash on that gate, your system, conduction system can get repulsed. And if you have large device, large evolute R or evolute Pro, you can damage the AV conduction system. This is not a rocket science to understand that if a bigger device, that's smaller LVOT can get compromised. So length of the membranous septum versus depth is important. And depending on your implantation's height or the implant depth, you can escape or you can land up with a pacemaker. And there are different registries, different trials that have demonstrated this is very, very important. So what I'm saying here, if you follow this Midas approach, you can reduce to 3%. The suit up was 19%, but I'm sure our legendary teachers and the proctors like Sanjay Mehrotra or Sengetuvalu, they have reduced the number of requirement for pacemaker in India to a very low acceptable level. Now, if I come to the anatomy, you have right side and the left side. This bright area is a membranous node, then his bundle, there is his node, we know is a cloud. It's not a single point or a node like AV node. And then the conduction system passes through this. So it's a very tight and you can have this kind of conduction system abnormality, maybe permanent, maybe temporary, there may be edema, there may be injury. So this can be corrected by waiting, and sometimes this is unfortunate to have a permanent pacemaker. And most of these patients, they do suffer from LV dysfunction, so better to have a dual chamber pacemaker until unless they have atrial fibrillations. So this zone is again important. And you know, right fibrous trigone, left fibrous trigone, and you have to understand the valve beautifully so that every nodes, every depth, you have to understand beautifully to avoid, especially in low risk group of TAVR, because the last TAVR in low risk has been successfully won, but there is a lot of debate in this segment. And the most, as Sanjay has mentioned, that the pacemaker rate is definitely unacceptable in young patients. So what I'm saying here, this anatomy is very important to understand, and there are different varieties of left bundle. Now we know by mapping, and the solution is sometimes a wireless pacemaker which can be switched off. This is the only pacemaker which can be switched off. You may be wondering why what they are doing in my patients. Initially, he had a single chamber micra. Because of LV dysfunction, high-grade AV block, we have to upgrade it. And this micra works wonder. And this is new innovations in the technology of pacing. So it senses the atria, A4, and it maintains the AV synchrony. We also know that routine pacemaker is harmful post-TAVR because they have diastolic dysfunction, some have LV dysfunction, some have an cardiogenic shock. The latest is septal pacing. You have to penetrate the septum. You have to cross the septum to reach other side, and you have to recapture the left bundle branch. So if you have RBV and LV dysfunction, better to go for LV zone pacing, or you have to go for his bundle pacing. To summarize then, RBV at baseline is the strongest risk factor for PPI post-TAVR. AF, long QRS durations, landing zone calcification have also been associated with PPI. New onset LBB post-TAVR has been associated with higher mortality and reduced left ventricular ejection fraction recovery and remodeling. PPI rates vary between institutions, operator, publications for all valve types, simple modification to the procedural technique, implant depth, target may help reduce the risk of PPI post-TAVR. More research is needed to identify patients who may not be dependent or on a new pacemaker after discharge. Thank you very much for your kind attention.
Thank you, Dr. Hajra. First of all, thank you for taking up this lecture in absence of Dr. John Joes, and you've done a wonderful job. I would, of course, invite the chairpersons to, come forward and ask at least 1 or 2 questions. We have advantage of some discussion, which we should do at the end of the talk, because I think Dr. Syed Satish is not there. So maybe we can have at least 2 questions with this talk. If Dr. Dugabetti, Dr. Hajra, of course, he's also part of the chairpersons, or Dr. Patil or Dr. Srinivas Kumar, or anybody from the expert panel, they would like to say something about this.
Satish, I think he's logged in. I see him. I don't know.
I think he's probably not presenting his I was told by the organizer, but I'll speak to him. We'll probably invite him. If he's not there, then we'll go to Ragdish Kapoor. So I have a question here, that the importance of cuspal overlap, which is coming now in, especially when you use the self-expanding valves. And to my understanding, and I've been trying to sort of get hold of this in the last many cases, it's a bit of a process of learning. And I think you need to probably practice it for some time before you start using it very effectively. Anybody like Dr. Sengatvelu, you would like to say something, or Dr. Hajra, would you like to say something about how do you feel about preventing a deep deployment of a valve like a self-expanding evolute?
Sir, I have very limited experience. I would like to hear from Sengatvelu or senior persons like
I have been using, actually, as you said rightly, this is more for a self-expanding valve, the cusp overlap view. But now we have been using it for even balloon expandable valves, and we use final deployment, the RAO views, and we have found, we have to publish this, but we have found the pacemaker rates extremely low with both Sapien and MyValve. And of course, it's more predictable deployment with the balloon expandable valve. Self-expanding valve, yes, it is, but I think with more and more experience, I think it's not an issue. But when we make a very close deployment, there is a risk of either the diving the valve either up or low. That is the only challenge, I think. Maybe Ramesh can add what are the risks of valve going up or going down when we go very sharply deploy these valves, particularly the self-expanding valves.
Dr. Ramesh, is he online?
I think as we all understand from previously we used to keep it little low. Now I think 10% versus 90%, something like that, we come very close. So as you said, you should be careful to avoid ballooning out of this valve, popping out of this valve. That's what you're saying.
Yes, particularly self-expanding is a little more not predictable like a balloon expandable valve, and there is a very high risk of either valve popping out. So I think this technique has to be done more carefully. Otherwise, you run the risk of valve popping out.
Tarun is wanting to answer, Sanjay. Tarun.
I feel, I don't think Dr. Ramesh is there, but I have...
Dr. Tarun Chakravarti is wanting to answer, I think.
Okay, go ahead, Dr. Tarun.
Yeah, so, so we are a Sapien heavy site. But we had Hemal Gada, he's the one who described this cusp overlap technique. So we had Hemal come over to Cedars to proctor us for a few cases for cusp overlap. And I agree, it's when you deploy, you're concerned it might pop out because it's a high deployment, but it's effective. And maybe you are deploying it the same way anyways. The only different technique besides cusp overlap. So Hemal would use the Lunderquist wire, the pre-shaped Lunderquist wire, and he would swear by it that it makes a big difference because it helps you align the valve along the outer curvature of aorta. The other thing that he did differently from us, he would actually rapid pace for the initial part. So we would pace around 100 and 120 for our deployments. He would pace much faster for the initial part, so the valve remains stable. So when we would deploy, it looks very concerning, but with his technique, but you're right, it's a technique that comes with big, large volume experience. But I mean, the numbers speak for it. In Himal, his pacemaker rates with evolute valve are 3 to 4%.
Yeah.
These numbers need to be reproducible in other sites. But his numbers are really excellent with this technique. He's the one who described it, and he is a master. But it works when it works.
And my 2 cents here, Hemolgada, he has done more than 1,000, and Lenda twist, he just pulls it up. I mean, it's not like it is curves inside the apex. It's the mid cavity very carefully. But in spite of his cuspal view, the rate of pacemaker, again, 1.9% in Hemolgada's Texas Institute. So you may imagine anything, but on the table, sometime you'll end up with pacemaker.
Yeah, I totally agree. I think this is a very beautiful discussion.
Can I ask a question, Dr. Sanjay?
Yeah, go ahead. With the last one, maybe we'll move forward.
Yeah. Just wanted to know from the chairpersons and the panelists that whether the amount of the calcium and the position of the calcium also matters for the complete heart blocks associated with the TAVI, and if it is, then what is the?
Yes, answer is yes.
Yeah, I can also answer this that I had a patient yesterday. I did 2 towers yesterday, and one of them had a LVOT calcium. So whenever you have an LVOT calcium, the calcium is tending into the septum, you have a very high incidence of, and obviously even in that patient. So this is a minimum diameter of the annulus was 20. I use a 18 balloon to dilate. And as soon as I pre-dilated, the patient went into complete heart block. And after the deployment of the valve, the patient was in complete heart block, totally no beating at all. He was not conducting. We had to do the pacemaker on table, and the patient required pacemaker. So there are a lot of prerequisites. Of course, older people, deeper deployments, presence of calcium, presence of pre-existing right bundle branch block. They all lead to a higher incidence of complete heart block. And we have to be ready. We have to be cautious about. We have to tell the patients that this is a high possibility of needing a pacemaker. And of course, if we suspect, we educate the patient and go ahead and do the job and try to do a higher deployment. And I also choose my valve. So if I feel that this patient is a higher risk, I will then go with a balloon expandable valve and do a slightly 80-20 deployment. So let's move forward. Anybody wants to say something for this regard?
No, Sanjay, I want to ask you, when do you remove the temporary pace for the benefit of audience? I think if everything is stable, do you remove it on table both for self-expanding and expandable?
I've done about 24 cases in the last 4 months. I've had 1 pacemaker. So I remove immediately. The only patient I don't remove is he has developed a prolonged PR interval and a right bundle branch block. I will watch for the next day. Fortunately, this patient, which I did yesterday, was completely dependent, today has a RBB only. He's come back to sinus rhythm. But you can't take a chance. While the pacemaker was being put in this patient, went into complete standstill and what are going Stokes-Adams. So such patients are very, very, difficult to treat with, but you never know when they will come back and they may not need their pacemaker ever in their lives.
Absolutely, we do the same. But do you differentiate taking out the pacemaker between balloon expandable versus self-expanding valve? Because there are some operators who wait for some time, particularly with self-expanding valves, but we don't do it.
No, I don't wait. I take it out immediately, and then because I don't want to leave any device into the patient as far as possible.
Absolutely, that's what we have been doing, and if everything is fine, remove everything immediately.
And this temporary pacemaker leads also sometimes the perforate.
Absolutely.
And everything went well, and next day a patient landed in trouble because of this tip. Though it was a balloon tipped catheter, but still they could have trouble. So it is better to remove it as soon as possible.
And also, I would recommend that whenever you're putting a temporary pacemaker, even if it's balloon tip, go with the balloon inflated to position it.
Yeah.
A lot of people prefer to do an inflated balloon and then deploy. Let me move forward with this. Next talk is Dr. Sai Satish. Is he there? Mitigating and managing paravalvular leak after TAVR. Is he there? I think he's not there, so we will. Dr. Sai Satish. Okay, let's move more forward. Now I invite Dr. Rajneesh Kapoor to speak about the predictors of hemodynamic structural valve deterioration in TAVR patients. Dr. Rajneesh Kapoor.
Yeah, thank you. And thanks for having me here. It's a privilege. And I'll just share my screen. Give me a few seconds on this. Are my slides visible?
Very much. Go ahead.
Okay, right there. So topic given to me for this session is predictors of hemodynamic structural heart deterioration after TAVR. I think this is very apt and very important in today's arena. Once we are, our volumes are going up, our data is accumulating. I think this is one aspect which is still very important as far as once we choose a valve at what age. So still, our tendency is to choose a TAVR beyond 65 years or at the most more than 60 years of patient rather than a younger patient. So this is the pointer which comes handy once we, select a valve at a younger age or we are compelled to select a TAVR at a younger age because of compelling indications. So this is very important to discuss in this session. So with the background that TAVR we know has done very well or even better than surgery in areas like survival and cerebral stroke, in areas such as paravalvular leaks or pacemaker implantations. Now, pacemaker implantation was a previous issue, but not that frequent issue anymore with TAVR. But yes, in these fields, paravalvular leaks or pacemaker implantation, one can say that surgery definitely has an edge over TAVR. One area where TAVR has consistently shown better results, now this is very important, as compared to surgical AVR, is a forward flow hemodynamics. So we know as compared to surgical AVR, we get larger effective orifice areas with TAVR, lower gradients, and lesser patient prosthesis mismatch. So these are very important terminologies, and now it's used more widely with the TAVR into play. And once we talk of that, we do have to keep talking that which valve has better orifice areas and which valve has lower gradients and lesser ppm. So I'm going to touch upon as I move further. So as we move down the risk scale, I think hemodynamics is increasingly important, rather enormously important, I would say. Let's see how. So getting back to basics, this slide clearly depicts, that once we are talking of aortic valve areas, and this is the thing which we need to achieve. The effective orifice area should be more than 2, because we know from our basics that if it is more than 2, the mean systolic gradient is almost negligible. But as the orifice areas start becoming lesser than 2, see this rectangle, the mean systolic gradients start to escalate, and obviously lesser than 1, the curve rises very sharply. So this is the point, and this graph very clearly tells that for the success of any AVR, it has to be orifice area more than 2. And if it is less than 2, probably it is suboptimal, and we are having gradients, and that's going to lead with enhanced structural valve deterioration. The second graph, second picture also shows the same thing. And this we know, we have seen this picture quite frequently, that this is a surgical AVR versus TAVR and a 2-year follow-up study. And we know that if we talk of aortic valve areas, TAVR is faring much better even at 2 years. So this picture shows at the end of 2 years, 2.2 area versus 1.7 with surgical AVRs. And similarly, so this also reproduces with AV mean gradients. So once the area is more with TAVR, the gradients are lesser with TAVR as compared to SAVR. And once we talk of patient prosthesis mismatch, we also know that this factor again impacts mortality and structural valve degeneration. Once ppm, patients with severe ppm we know it amounts to almost 20% increase in mortality. Similarly, the PPM also leads to almost 40% increase in heart failure and rehospitalizations post valve replacement. So PPM is again a notorious thing, and we need to have this corrected, and we need to have this under control once we're deploying the valves. And this is a valve degeneration, structural valve degeneration risk. Now see, the PPM is independently associated with 2.3-fold increase in risk of structural valve degeneration. Gradient, again, once there's a PPM, there has to be a gradient, and if the gradients are more than 20 millimeter of mercury, they are associated with increased cardiac rehospitalizations in TAVR. So this shows the same story. And now based on this, the biggest question comes that durability of the valve. The long-term durability and threat of this structural valve degeneration, it has gained more momentum, as now we are talking of that at how much age we can actually offer TAVR. So if we are thinking of offering TAVR to more younger population and lower risk population, I think this is an extremely important question which we need to have an answer. The evidence exists that smaller the orifice area and higher the initial mean gradients, more likely or sooner the patient will develop the structural valve degeneration. It would therefore make sense to achieve highest orifice areas and lowest gradients possible, and that is the success of the procedure. This is a very important slide. Now, what actually is a structural valve deterioration? If we need to define. So if the mean gradient is more than 20 millimeter of mercury, that is a moderate degree of structural valve deterioration. And more so, this is more important. Now, if we are following a patient post-valve deployment, the initial gradient, whatever amount of initial gradient the patient had, if the gradients accelerate or gradients go beyond more than 10 millimeter of mercury as compared to the baseline, this also comes under a definition of structural valve deterioration. And similarly, the last point, the moderate or severe intraprosthetic aortic regurgitation, new or worsening from baseline. So these are the things which we need to watch as we follow more and more patients in our data where we are using the TAVRs. Now, does the valve design matter? This is again a very important stuff which we need to discuss, because this will be pretty handy in making us a decision for which valve to use in which patient, and which valve will give better outcomes to that patient. Yes, I think the answer to this question is yes, the valve design also matters. Let's see what the literature says. Now, this study was published in Eurointervention Journal. A total of 691 patients of balloon expandable valve. And it was all aimed at, trying to get the answer of predictors for structural valve deterioration. The primary endpoint of structural valve deterioration was observed in 10.3% patients post-TAVR in balloon expandable valves at the end of 12 months, 1 year. And the predictors were use of 20 millimeter valve, lesser the size of the valve, more the chances of deterioration. Valve-in-valve procedure, obviously again the effective orifice area gets reduced, and the oral anticoagulation, they were independently associated with hemodynamic structural valve deterioration. Now let's see the comparison studies. We do have some studies which have compared the supraannular versus the self-expandable valve, and most important is Notion 8-year, we know, and Notion 8-year has clearly depicted that the core valve, the self-expanding TAVR, behaves much better than the balloon expandable, and the figures were close to 14.1% at the end of 8 years. These are structural valve deterioration figures, 14.1% in self-expanding versus 28.5% in balloon expanding. So quite a difference. And also, please note the graph of deterioration with balloon expanding rises much early as compared to the core valve. Core valve up till 6 years were hardly 5%, 3-4%. But after that, after 6 years, the percentage levels had gone up. Again, one more study, Italian registry, 8 years, almost the similar results. So balloon expandable, almost 3% structural valve deterioration at 8 years versus 1.6% in self-expanding. Another data, Deutsch 7-year data, again, this is freedom from structural valve deterioration, 82.4% with core valve and 62.4% with sapien. So one thing pretty clear that structural valve deterioration probably accelerates more in balloon expanding as compared to self-expanding valves. This is another data almost showing the similar stuff. So design definitely matters. And this is the reason now we all know the Evolute has a supraannular valve opening, and that leads to better orifice areas at 1 year, 2.2. That's what we were talking, that it has to be more than 2 if we want to have an ideal situation long-term after the valve deployments. And this is sapien balloon expanding 1.7 centimeters square at the end of 1 year. So takeaway from these data and whatever we are discussing, the hemodynamics are increasingly important for TAVR as we move to more active patients and more younger patients, I would say. And the data will decide that how low we can come as far as the age is concerned. The smaller effective orifice area and higher initial mean gradient, the more likely and the sooner the patient will develop structural valve degeneration. And effective orifice area of at least 2 centimeters square is a worthy goal. I'll just show you a case which I've done about 4 or 5 months back. This was a very unique case, so that's the reason I'm presenting it here. This was a rare case of a unicuspid aortic valve, and while patient presented with the critical AS, unique aortic valve, I've gone through the literature also. So this is also under publication, but sorry, I'm presenting it here because this was too captivating. So this was 56-year-old male patient. Ejection fraction was 30-35% and hypertrophic ventricle. Patient had lots of comorbidities, and more so I remember patient had been really badly arthritic, and the surgery was refused because of comorbidities. STS score was falling. So things need to be thought in this case. Just half a minute more. So relatively younger guy, 56-year-old, longer lifespan. We need to think that which valve will give a bigger effective orifice area so that the long-term implications of structural valve degeneration are minimal, and we get a better long-term durability with these valves. Valve contributing to lower gradients and future. So there has to be a valve which also gives easy access. This is the procedure. With unicuspid, one tends to have a problem of anchoring. So the similar thing happened to me. It kept on popping out multiple times, almost 4 or 5 times. I have to recapture the valve, and still, whatever best position we could had was also not ideal. Finally, it was almost 0 on the left side and -1 on the right side. We waited a long after this position, kept on checking with T. So this was the position, but it was quite stable, and there was no leak, and gradients were minimal, almost 5 or 7. So we left it there and then checked it. Now this patient is almost 6 months post TAVR. He's doing great. I have done CT twice. The position is same, -1 on one side and 0 on the another. So it's a supraannular on one side, but it's a fairly stable valve, and orientation is also not giving us a trouble in terms of gradients or leak. So patient is doing well. Once the patient was admitted, almost we took 10-15 days to stabilize the patient and then go ahead with this procedure. So now today the patient is in my close follow-up. I keep on phoning him. So it's more than a year, sorry, not 6 months. And still I keep on asking the patient, and the answer comes that I am walking 6 kilometers a day. So he's symptom-free and doing good. So I thought this is worthwhile presenting this case here, as it was fairly unique. Thank you.
Thank you, Dr. Rajneesh. Let's open. I think we still have some time, although, of course, we are beyond the session.
Sorry to interrupt. Sorry to interrupt, sir. We are running pretty late, and the next session speakers are slightly at a disadvantage. Can you wind up the session, please?
Yeah, okay. Thank you so much. So thank you, all the speakers, all the chairpersons, Dr. Ramesh, Dr. Srinivas Kumar, Dr. Patil, and all the panelists. We have to move on, although we had some questions. But thank you very much for participation, and wish you a lovely and a successful session. Thank you very much.
Thank you, sir. The next session will be on the coronary physiology. The chairpersons for the sessions are Dr. S. Saran, Dr. V. S. Naren, Dr. K. K. Mitra, Dr. Ajay Kumar Mahajan. The expert panelists for the session are Dr. Sadanand Sethi, Dr. Sanjeev Roy, Dr. Smith Srivastav, Dr. Uday Jadhav, Dr. Sanjeev Katuria, Dr. Shaujato Chakraborty, Dr. Dipankar Ranjan Das, and Dr. Ashit Das. The session will be moderated by Dr. Ajit Mulasari. Over to you, sir.
Good evening, everybody. Without wasting any time through the session, I call on the first speaker on the impact of coronary physiology on contemporary clinical decision-making, Dr. Frank.
So due to some problem, we do not have Dr. Miroslav Ferenc. We will continue to the next speaker.
Okay. So we have the next speaker is future of culprit lesion detection based on angiographic derived FFR, Dr. Bernard Chevalier. Everybody knows Chevalier. He's very often in India, and he's a great speaker. Bernard. Is Bernard on the line?
Good afternoon. It's my pleasure to share with you this afternoon these thoughts about all of angiography-derived FFR for evaluation of culprit lesion. We know the classical debate between anatomy versus physiology in terms of evaluation of coronary lesion, meaning that we have two types of tools: the QCA, quantitative coronary angiography for evaluation of the degree of stenosis, and the physiology by FFR. The traditional way to evaluate this fractional flow reserve is the quantitative measurement of the functional severity using a pressure wire. Meaning this pressure wire allows us to evaluate the distal coronary pressure and to have this ratio between distal pressure and proximal pressure, what we call PD to PA. And we evaluate this at baseline and during maximum hyperemia. And if during a maximum hyperemia we have value below 0.80, we consider the lesion is significant and deserves treatment. This tool has been extensively evaluated in many clinical trials. FEM1 is one of them, but we have also DEFER, FEM2. And it has been shown that using FFR guided strategy, you save a lot of events at mid and long term compared to the classical angiographic guided strategy. If we consider the benefits and the drawback of this classical wire-based FFR, in terms of benefits, we have seen that we have extensive clinical validation. We have also good intra and inter-observer variability. And the wire which is used for evaluating FFR can be used also to do the PCI, meaning that we can evaluate FFR before intervention and after intervention as well. We have significant drawback as well. First, the cost of the device, which is relatively expensive. We have to inject adenosine to get some maximal hyperemia, and we have some side effects related to adenosine, bradycardia, sometimes atrial fibrillation. We have the risk which is related to the lesion wiring, which is usually relatively low in simple lesion, but could be more elevated in terms of complex or very complex coronary stenosis. And of course, it's also time-consuming, particularly if we have to interrogate all vessels if we consider a multivessel disease. Can we predict the FFR from angiography? It's not so easy. We know that the main factors influencing the result of FFR are, of course, the stenosis, the degree of stenosis using area stenosis, but also the lesion length, the myocardial jeopardy index, meaning the importance of distal runoff, which is supplied by the target vessel, and also the presence of chronic total occlusion with some collateral flow from the vessel we are interrogating, because it's increasing the risk of overestimating the degree of stenosis. So there are many attempts to develop a non-wire-based FFR. Some are using conventional angiography, some are using CT scan, some are using rotational angiography, OCT as well. Here we are considering the angiography-derived FFR using what we call the QFR concept. This is a combination of 3D QCA, where lumen contours are derived from two standard geographic projections at least 25 degrees apart. In a combination with some algorithm using contrast flow velocity estimated by frame count during baseline conditions. Using these two types of information, the software is able to evaluate the QFR. As you can see here, we have a case of high coronary artery with some lesion at the mid part. We use the contrast flow as the first information, the 3D QCE as the second information, and the software is combining these two types of information to evaluate the QFR or the QCA FFR, which is in this case 0.87 compared to the classical FFR, which is 0.85. This software has been evaluated in two important cohorts. First one was favored to China. You can see that the global correlation is relatively good with R value of 0.85, but we have, as we can see in the Blantal panel presentation, we have some outliers with patients with more than 0.1 plus or minus derivation from the FFR. So meaning that in these patients, the result of QFR is not so accurate. But at least when you compare the classical QCA, which is here, with the QFR, we improve a lot the evaluation with the receiver operating curve, which is much better when using QFR. In favor 2, we have more or less the same kind of result. As you can see, the global correlation is relatively good. R is 0.83, but with a few outliers again in two directions, which is minoring or majoring the FFR value. In terms of duration of evaluation, you can see that we save a little bit of time. It's a little bit quicker than the classical FFR using the wire, the mean time of 5 minutes compared to 7 minutes. And when you compare the QFR as assessed by investigator versus the QFR as assessed by core lab, we can see that we have relatively good correlation It's even a little bit better for investigators. When we look at the meta-analysis from this favor 1, favor 2, Europe, Japan, and favor 2, China, we have a global cohort of almost thousands of vessels, 819 patients. The global correlation with the classical wire-based FFR is 0.85, and some standard deviation is 0.07. So meaning that the area under the curve is extremely good, as you can see, 0.92, which is really a good value. We need now to validate not only versus classical wire-based FFR, but also to clinically validate this result as we did for the classical wire-based FFR. And we have two important trials which are ongoing. Favor 3, Europe and Japan, which is randomizing symptomatic patients between QFR guided intervention versus FFR guided intervention. Very important trial with 1 year primary endpoint in terms of MACE evaluations. Favor 2 China has a little bit different design, but it's also a clinical validation. Same type of patient. We have patients with significant coronary artery disease and symptomatic coronary artery disease, and they are randomized between QFR guided strategy versus angiography guided strategy, meaning that the control group, there is no FFR evaluation. And again, the primary endpoint is at 1 year, and it's a MACE evaluation. So two very important trials which are ongoing. Regarding the question we discussed at the beginning, which is the capability of this QFR to evaluate non-target lesion, non-culprit lesion in multivessel disease patient. We have this trial coming from Italy, which is evaluating the result of QFR versus FFR. Again, we have a good correlation with FFR, as you can see, and we have few outliers. But what we can see in this cohort is a drop in terms of accuracy around the cutoff value, which is 0.80. As you can see, this is really an area between 75 and 85, where the accuracy of this QFR is a little bit less satisfactory compared to patients with very low FFR or very high FFR. On this drop around the cutoff value, we also found it in this meta-analysis, which is, as I said, combination of favor pilot, Wi-Fi, favor 2 China, and favor 2 Europe and Japan. Again, overall accuracy is good, area under the curve is good, but we have this drop in terms of accuracy around the value of 0.80. This is the reason why some investigators have proposed to use an hybrid strategy, meaning that you can rule out coronary artery disease using QFR when this value is more than 84. You can consider that you have definitely a significant lesion when the QFR is below 0.73. But in this range, 73 to 84, you have to add a classical FFR evaluation to be sure to have a good classification of your patient, meaning that you need to use a FFR wire and to inject adenosine in that case. Definitely, this QFR is a good way to stratify multivessel disease patients. And if we go from classical syntax score to functional syntax score using FFR, you can see that the capability to reclassify this patient is really equivalent with functional syntax score using the classical wire-based FFR. Again, we have some significant impact on the long-term outcome when you have the value in free vessel disease. You add the free vessel QFR value and a cutoff of 275. when you are below 275, you have significant impact on the long-term outcome in terms of mortality, meaning that we have a start of clinical validation of this tool. So to conclude about these tools, we have good statistical correlation with wire-based FFR. The clinical validation studies, meaning favor-free China and Europe and Japan, are ongoing. Our experience has shown the importance of training to limit variability and the potential deleterious effect of bifurcation and ostial lesion on data reproducibility. Individual accuracy is suboptimal around the cutoff value, inducing some misclassification. This is the reason why it seems wise to use an hybrid strategy combining FFR when QFR is below 75 and 85. I thank you for your attention.
Very nice presentation on QFR and FFR in contemporary practice. I think we'll take all the 3 lectures and then go for the discussion at the end of the session. So I would ask Ramesh Dugupati to now talk on post-stenting invasive coronary physiology for precision medicine. This is based on the DEFINE PCI study. Ramesh.
Thank you very much, Ajit. Great to be a part of CSI NIC. I'm trying to share my screen. Okay, good. So I think you can see my slides.
Yes, we can, and we can hear you too. Yeah.
Very good. So let me just swap that. So I have no disclosures for this presentation, and this also has come out of an interesting paper, the state-of-the-art review from invasive coronary physiology after stent implantation by Barry Ritzky's group, as well as Campo's group from Italy. And we have this great use of FFR nowadays, and as we always see in NCDR, still it is not 80% in our cath labs. It's probably about 20%, and we feel that it is due to utility of other tests such as stress testing before the patient comes to the cath lab, or the rise of CT and CT FFR, as Dr. Chandrasekhar has spoken earlier. And obviously, Dr. Cavalier also spoke about the utility of QFR. So most importantly, why is there FFR is not being performed? There is minimal discordance between FFR value and angiography at the upper extreme of the stenosis spectrum. And we know that. And I think somehow people are not comfortable performing FFR after PCI. And you can see that in stenosis classification by angiography, this is pre-PCI FFR. There is no doubt that once it is above 0.8, there is more consistency. And once it is above 91% occlusion, and there is also definitely more correlation. And so the lesions that we now see mostly are 50 to 70%, or even you can go higher up, but there is concordance above 90% lesions and less than 50% lesions. So the other thing that we talk about is probably rational not to perform FFR after PCI is that we are becoming comfortable just based on angiography and then or imaging, and we are not actually taking into consideration the physiology and how we can actually add physiology to be precise in optimization of the PCI results in this group of patients. So there is minimal discordance between FFR value and angiography at the upper extreme of the stenosis spectrum. However, this is not necessarily true at the lower end of the stenosis spectrum. Sometimes we see that as well. So the rationale to perform FFR after PCI, to answer the most important questions, is are we finished? Or stated more elegantly, has ischemia been eliminated? Because even recent papers have suggested that in diffuse disease, CABG is superior to PCI. And maybe we are just looking at the most critical lesion and just stenting that critical lesion and leaving everything else. So residual ischemia is obviously an association with major adverse cardiac events. Let me show you one quick case, 84-year-old man with the class 3 angina on good medical therapy. Angiography showed 50% proximal, 60% middle AD stenosis, and 100% RCA with the collaterals from the circumflex. And you can see that this LAD does not look that bad. And, if you want to say what should be done, there's a mid LAD that is 60% lesion, you can assess with the FFR. And so let's go ahead and do FFR in this patient. If the cursor is placed distally, the transducer, it was 0.62, and pull back at each level, you can see how it has improved, and only at the proximal LAD it has normalized. So there is diffuse disease in this patient's LAD all over, even though it appears that maybe there's one critical lesion here and here, So then you go ahead and stent proximal stenosis with 3023 and drug-eluting stent, and then what happens to the FFR is still the same, and so then the mid lesion was stented. And now let's look at the FFR. And so we have normalized almost everything except the most distal part, which is 0.79. The rest of them is 0.8 and 0.88 up to the mid to distal portion. So this is where we have to think about whether we could do more to optimize this patient or not. And maybe the choice should have been maybe maximal medical therapy versus actually surgery then, right? So the major causes of ischemic FFR after PCI are diffuse disease and also residual stenosis that you might leave, underexpanded stents, geographic miss, edge dissections, and large collateral supply by index vessel to a CTO territory. And technically, there are other problems that probably drift is not being seen that much, but it can happen, and vasospasm and extreme vessel tortuosity, wire bias artifact or accordion effect for these patients who might have that. So most important is the diffuse disease and the drift in this group of patients where you have still ischemic FFR. So in the previous patient, obviously doing an IVUS or OCT might help. And you can look at it where you have stented and how much of a plaque there is distally, and also whether the stent is well expanded or not. And you can see that the stent here could be expanded a little bit more. And even here, you can see from 2 to 8 o'clock, there is a reason that you can post-dilate that stent much better. And what is the incidence of ischemic FFR? You can range from 1 to 36%. In the Agarwal study, it was shown at 21%. And the pressure transducer location in this study actually is distal in a vessel at a location where stenting might be performed. So how does ischemic FFR relate to long-term outcomes? And so a post-PCI FFR, you see that the values have been different. And Dr. Barry Uretsky's initial study said that any value of more than 0.86 has correlated with better outcomes than less than 0.8. Bare metal stent did not make. Even if you put a bare metal stent and if the post-PCI FFR is more than 0.86, those patients did much better than putting a drug-eluting stent and having an FFR value of 0.86 on post-PCI. So please remember, it is not correlating to the stent alone. You can see that in 966 patients by Johnson, where FFR values are 0.83 post-PCI, major adverse cardiac events for about 40%, versus actually in people who have 0.98 post-PCI, MACE adverse events are much lower, about 20%. And it is obviously, we know that there's more data, as I mentioned, from Agarwal and Barry Udritsky's here, that 0.86 is been the cutoff point. And drug-eluting stent or bare metal stent did not matter. Any value of more than 0.86 actually is more important than the type of stent that you have chosen. And there's been a study meta-analysis of N equals 1,337 patients, where it showed that low post-PCI definitely predicts a major adverse cardiac event. So having major adverse cardiac events by PCI can be reduced if the post-PCI FFR can be increased. So if post-PCI FFR predicts MACE, can a final FFR be improved if it is low after PCI? So what can we do about just measuring it? There is definitely an improvement if you can do baseline FFR from 0.63 has been increased to 0.78, and you do some subsequent intervention and increase it to 0.87, the event rates have actually come down. And you can see whether what is the subsequent interventions. It could vary from post-dilatation in about 42% of the patients, additional stenting in about 33%, both of them in 18%, and actually just doing an IVUS or OCT to know what is going on in about 9% of the patients. I think this number of 9% definitely has to increase. And I think in people who have post-PCI FFR, which is low, we need to understand better. And precision medicine is only if you combine both modalities of physiology and anatomy and imaging. And here is a case to patients, a 47-year-old, class 3 angina again, and RCS shows some 80% stenosis and PDA at 40%, 80% PDA and 40% distal and mid lesions. And after PDA stenting, FFR was 0.69. And you can see that there is a diffuse disease here, and FFR was 0.29, very much distal into the PDA. But you don't have to go that far, but you see 0.69 after the PDA stent. And you stented the RCA and you measure it. Actually, now the FFR value has gone up to 0.89. So you after proximal, mid, and PDA lesion stented, FFR pressure transducer was placed in the PDA during hyperemia. And that's how we measure it. I think I'll skip, in view of time, this FFR small registry. And let me talk about what are the lessons that were learned from this registry. Was that after angiographic optimization, post-PCI FFR in the ischemic or low normal range is frequent. As we said, it can be up to 36%. A higher post-PCI FFR is associated with decreased MACE rates. And so this is what we have to achieve by trying to do aggressive imaging in all these patients and maybe ballooning or extra stenting. So the two studies that are very recent have come out is FFR React. The studies are not published yet. Post-PCI FFR of a value of here, they chose 0.9 and randomizing 1-to-1 in IVUS-directed FFR optimization versus a control group. And it has 84% completion was achieved in 2019. And we still have to wait for long-term results in probably this year or next year. Target FFR is another study that came out and looking at this is from UK and about 238 patients post PCI FFR, and the physiology integrated optimization strategy has been shown that further events such as whether post-dilatation or another stent was required in about 38.1% of the patients. And in the Pierce group, actually, the value of more than 0.9 was achieved in 38% of the patients, versus in the control, only 28% of the patients had FFR values of more than 0.9. So how did they optimize here? Again, as the additional post-dilatation in 57.5% and additional stent implantation in about 30% of the patients. So with that, I thank you for your attention, and I look forward for any questions at the end.
Thank you, Ramesh, for a nice, elegant presentation of post-procedure FFR. We go to the last presentation, after which we take the questions. I'd like my good friend Balbir to now present, do we need novel indices as alternatives to FFR? Can we have Balbir?
Good evening, friends. So today my discussion is about the novel indices for determining the coronary physiology. Do we need novel indices when we have an FFR? That is a major question. We know FFR has been there for a long time now, and we know the achievements that is done with FFR. So FFR basically relies on PT by PA during maximum hyperemia. So when we get hyperemia, the PDPA is measured and the least value is defined as the FFR. So we know this, all of us know the benefits of FFR, the benefits proven through 3 landmark studies, the DEFER, the FAME, and FAME2. So we have a large data supporting it, making it a guideline, directed, accepted indication for treating borderline lesions, for treating multivessel disease, for treating left main disease. So all important categories of coronary artery disease have been accepted with FFR being the gold standard. But we always strive to do better. and better is where the human race will progress. What are the problems with FFR which can be solved with other novel indices? And do we have those novel indices who solve these problems? FFR takes extra time. There is an extra cost involved. There is the risk of invasive instrumentation. We need to inject an agent such as adenosine, which could be intravenous, causing quite a messy dose calculations, checking lines, or it could be intracoronary with their antecedent side effects such as flushing, headache, breathing difficulty, and a feeling of extreme uncomfortableness. So these are some of the drawbacks of FFR. And we need to understand, can we do it better without these extra problems? However, despite all these shortcomings, if there was an operator survey done in US, which looked at operators who select a physiological way of assessing intermediate lesion, it was seen only 21% used FFR, 71% still used angiography, and the rest other novel indices. So if somebody uses a coronary physiology in US, it's generally an FFR. So we still think that FFR is a well-accepted method. So what are the other novel indices apart from FFR which can help us take this decision? We could have invasive, we could have non-invasive methods. So in the invasive, we have the wire-based, we have the IFR, we have the DFR. So IFR is by Philips, DFR is by Boston. DPR is not yet there, but is being practiced in some parts. Then the resting whole cardiac cycle, the REST PDPA is not a great index, not so well used. Contrast FFR is again an FFR not using adenosine, but using contrast. Then we have RFR, again by Abbott, again using the same system. So the advantage of RFR is that in the same patient, you can do RFR and FFR using the same machine. You don't need to change your machine. Then we have coronary angiography, which is QFR, which has been tested in India also. And then we have FFR angio. These are the two accepted indices. What we are looking into future is IVUS FFR and OCT FFR. They look very exciting, and I'll show you how. Then we have the CT FFR, CT-based, which looks very elegant that patient undergoes a CT, gets a diagnostic, a morphology of the lesion, and also the FFR of the lesions. Looks elegant, but we have to understand what it actually means. So we in India have IFR, RFR, we have QFR, and CT FFR is still not very well accepted in India, not too many softwares helping it. OCT has not arrived. So what are these resting indices which do not need hyperemia? They're also called non-hyperemic resting indices because they don't need an adenosine. So these are IFR, DPR, RFR. So these indices use different forms of measuring the ratio, and I will just show you how they do. So let's go for the IFR. So IFR looks at, as we can see in this diagram, in the diastolic wave-free period. So in this wave-free period, it looks at the PD by PA and measures that. So there are two big studies with IFR which compare it against FFR. So you can see about 2,500 patients were randomized to IFR group and FFR group. And the patients were guided to treatment based on what the value was. And you can look at the 12-month outcome of hazard ratio or the MACE events in these patients were almost equal, about 6% MACE rates. So there was not much difference. This was published in 2017, New England Journal of Medicine. Another study, again published the same year in the same journal, about 10,000 patients were taken from the SCAR registry, and then 1,000 were randomized between FFR and IFR. And you can look at these results. The hazard ratio in IFR was a little higher, 6.7, compared to FFR of 6.1, but not statistically significant. Now there comes a group. The group is very interesting because this group of patients will is a group of patients which will have IFR and FFR in the same range. That means if the FFR is high, the IFR is high. But if it is low, it is low. But there's a group which has a high IFR. That means IFR is normal, but FFR is low. And similarly, there's a group which has low IFR and high FFR. What do you do for this group? We don't have an answer. What about this discordance between IFR and FFR? So if one patient, you do an IFR and then you do an FFR, they come discordant. What is the outcome of these patients? We do not exactly know. So there was a study published in 2019 in JACC from Japan, which tried to look at these group of patients who were discordant. So this group of discordant patients, they calculated the CFR. So the CFR in FFR positive and IFR negative patients resembled that with FFR negative, IFR negative patients. So you can see that. So they are likely to have good outcomes. But does this decide? Does the coronary flow reserve decide the outcomes? So they looked at these outcomes of these patients. So this is again very interesting. So they had 4 groups. Group 1 was high IFR, high FFR. That means negative, both negative. This group had from 2000 days, that means at 5 years, they had a MACE rate of 7.2%. While a group where both are low, that means both FFR and IFR are positive, very high MACE rates. But the group in between, the discordant group, if FFR is positive, they had higher MACE than if it was negative. So IFR and FFR did have some discrepancy. But if you put all these 3 groups together, you come to a conclusion that they were not statistically significant. At the moment, we do not know the right answer of this discordant group. What should be done? In my opinion, you should go with symptoms at that point in time. Do look at the morphology of the lesion, the risk that can be created by those lesions, and then take a call rather than to decide based on FFR or IFR. What extra advantage these resting methods give you, like IFR? So you can do a pullback. For example, this is a lesion which has an IFR of 0.77, which is significant. You pull back the wire, and at this point, you get an IFR of 0.99. So you know the lesion length is from here to here, and you know that you need to stent from this point to this point. So it gives you some rough idea as to what the length of the lesion is likely to be. And this is the post-procedure, you get an IFR of 0.96 in the distal vessel, which is great. So weighing IFR, advantages: no adenosine is required, reduces time, allows for pullback and co-registration. Disadvantage, one of the biggest disadvantages, wire drift during pullback can happen, leading to some changes because it is very sensitive to noise and hemodynamics. So in a hemodynamically unstable patient, this may be unreliable method of estimating. What about contrast FFR? It's a very simple method that you inject a bolus of contrast and then look at the hyperemia which it produces and look at the PDPA ratio at that time, or look at the FFR at that time. 3 big studies have shown good results comparing it against FFR, but the cutoff is 0.89 in such cases. So if you do contrast FFR, if it is positive 0.83, you have FFR, you perform PCI. If you have 0.89, you defer PCI. If you have borderline, you perform FFR. So this is a very simple method. So we do it every day in lab, that first you put the FFR, give a bolus of contrast. You would know immediately if it is less than 0.3, you know what you are dealing with. What about RFR? So RFR is very interesting that it looks at the entire cycle. It is a resting non-physiological index, does not need hyperemia, but it checks throughout the cardiac cycle, unlike IFR, which looks at the wave-free period. So this is the wave-free period. It looks at the wave-free period. RFR looks at the entire period. So this is how an RFR value would look like. Very similar cutoffs as IFR, almost similar. And this is how this RFR goes. Now, if we look at RFR, we know the procedure time is reduced, patient discomfort is less, like IFR. And the stress is quite simple. So in our lab, our dictum is to do first a contrast FFR. If contrast FFR is less than 0.83, we're going to stent it. We go straight to RFR, take a pullback with an RFR, estimate the lesion length, and go and stent it. If the contrast FFR lies between the range of 0.83 to 0.89, or even if it is more than 0.89, we go for RFR. After having seen a positive FFR, we pull back with an RFR wire, because the same machine does both the functions and estimate that too. So the question remains when to use the resting indices versus FFR. Resting indices are validated in simple patients compared to FFR. FFR data is more robust for left main proximal LAD multivessel disease. We have to understand that thresholds for IFR and RFR are different than FFR, and it's very important to understand that. What about QFR, which is an angiographic-based method? So it requires two orthogonal views, constructs a 3D impression of the artery, and then with that reconstruction, it looks at how fast the flow of the contrast was and calculates the QFR. This is a new method which is called an OCT FFR. So OCT FFR does OCT and estimates FFR with it. It's been validated against FFR and looks very elegant because you're getting morphology with FFR, and should become a choice because we need both. We need morphology, we need functional assessment at one time to give us the right answers in right patients. For example, this patient, OCT run has been taken. The branches are marked with OCT, and the FFR is based on these branches and how the contrast flows through the artery. It calculates an MLA of 2.76 and finds OCT FFR of 0.80, which is right on dot that now you know this lesion is significant, both with OFR and by the morphology, and needs stenting. So it's to summarize all that, what we have seen, we see there are different cutoffs with the IFR, RFR, and FFR, which we know very well. FFR or contrast FFR needs hyperemia, as we already discussed. Procedural time is reduced by these novel indices because you're not injecting adenosine, so the procedural time is lesser than FFR. Patient discomfort is not there because no adenosine is going. The procedural costs are reduced because of no adenosine being used. But the question remains, the randomized controlled trials are available only for FFR and IFR. RFR has two studies, validate and revalidate studies, which look very elegantly comparable to FFR, and so has DFR. But they don't have large randomized studies, so a surrogate that they compare against FFR may be used. IFR and RFR allow you to do a pullback and allow you to treat tandem lesions, which is a great advantage. There is hemodynamic dependence of resting PDA, PA. IFR also is to large extent dependent on hemodynamics. Learning curve is not much in any of these methods. However, coronary angio, CT angio, OCT will need a learning curve and will have different results in different centers. So I would thank all of you. And in summary, I would say that in my lab, we do a contrast FFR by giving a bolus of contrast injection. If we get a positive result, we know we don't need to do anything. And we then just proceed to RFR to pull back to look at the lesion length, and would do FFR only if we are unsatisfied with the RFR and the contrast FFR result. Thank you very much for your patient hearing.
And for a nice lecture. And I'd like to open the session for a few questions. We are a little running short, so any of my co-moderators and chairpersons could ask all three of them questions, please, the speakers.
Can I have a query?
Please go ahead.
We have, many of us have experienced that today's non-culprit lesion we live becomes a culprit lesion 2 years after. So how these coronary physiology parameters would be utilized to predict this future event? Whether this is better than imaging of plaque through IVAS or OCT, or the coronary physiology parameters are better to predicting future event in a non-culprit intermediate lesion.
Balbir, can you take that question? The question is, what is the predictability for the non-culprit plaque on progression? Is Balbir there, or is Dr. Ramesh there? Okay, maybe I can answer that. The predictability of non-culpritable vessels for these physiological tests are pretty much validated. And most of these tests which have been done are for non-culprit vessels and not for culprit vessels. So clearly what we're talking all these 3 lectures is for the non-culprit vessels, where we take the functional tests for them. And we know clearly that if the FFR is less than 0.8, it is predictive of revascularization in the future. And IFR of 0.89 is predictive of revascularization in the future. A contrast FFR of 0.84 is predictive of revascularization in the future in 1 year's time. So clearly these functional tests tell us, that the non-culprit vessels will progress and therefore you need to stent them now. If they are negative, then we don't need to do, we can just leave them. And this is validated up to 5 years with the FFR in the FAME study. Any other questions from the...
Can I ask a question, Dr. Roy, here?
Yeah, Sanjeev, tell me.
Yeah, I think none of the speakers are here, so the question is for you. How do you feel, like this angio-based FFR, it has a potential, I contemplate a potential role in, post-PCI study? Because not every time we open up the FFR, but possibly if it can be validated, as a post-PCI parameter, I think we can do in more of the cases and look at the gradients. How do you feel that its potential use?
I think, Sanjeev, that's an excellent question. And I think what we need to, I have no experience with QFR, but we are just now running a Siemens VFR, which is another software similar study, and validating it to FFR. I think that will be great to do the procedure, not open a wire and check whether you've done a good job with a non-invasive, no wire implantation technique to check the functional status of the vessels and then decide whether to do something or not. That's one thing which is very, very important. I think it's also very good to, in a non-culprit vessel, like the previous question was asked, and say a STEMI patient who have an ACS, if you can, without a wire, check on the other side how things are at the time, say 48 hours after STEMI, without even looking at the, putting a wire in. So these, I think, are the very good tests which can be used without wire opening. And I think that these have to be validated. I agree with Bernard, but that there's a window in many of these tests where you still need FFR to validate it further. I think the large studies have to come. The favor trials did show some good data, but I think we need much more data validated like FAME over a long time with the FFR with these newer tools.
And I think, what about in a situation that Dr. Ramesh Dugavati showed, that diffuse disease, where at the end of the LAD you have a ischemic FFR, but let's say a situation where at the end of the stent you have an FFR which is quite above 0.89, but at the end, and there is no sudden step up and step down. You go for an aggressive management, or what do you do?
I would do a very non-aggressive way. I would treat it medically, because there's no point chasing this too hard. I think the best thing is to treat it medically and not go very aggressively after that, because you can't do much. We saw with the DEFINE PCI study that 25% is before, 25% is after the stent, and 25% is within the stent. But many times you won't get a good result despite doing what you have because of diffuse disease. So I think, Sanjeev, and with everybody, I think we'll close this session and hand over to the next session. I thank all the speakers and the moderators for joining in, and I'll hand over to Dr. Bansal for the next session.
So one question, sir. One question we have.
Okay. Yeah.
Yeah. So what do we consider as now a false negative or a false positive FFR? Like in MI, we'll expect it to have false negative FFR.
Correct, because LVDP may be high because of microvascular issues, so you may get a false negative, but FFR may be positive because of microvascular blocking. So your their gradients may be low falsely. So you don't do it for 48 hours.
But we can do it for the non-culprit vessels, sir? It
Not immediately.
For the
We can do it in the non-culprit vessels, provided the myocardial infarction is not very large. We know that, say, a large wraparound LAD can create problems in the non-LAD territory also. It's important that it's better to do it a day or two later. 48 hours is a good time. We could do a non-culprit if there's data to suggest, but definitely not in the culprit vessel.
Yeah, that's for sure. And the false positive probably more with the proximal LAD or a large artery which is being taken care of by the particular vessel. That's the
that would
indication.
really not be a false positive, but it is a positive because the collaterals are high and providing the other side. It means functional problems in that area of the myocardium. There are certain areas where we have to be very careful. Diabetic patients who have distal microvascular disease, you may get a false negative FFR. These small groups of patients are there, which we know in a big right coronary artery, you may get that. Many of these we need to have multiple tests sometimes to make a difference. But end of the day, I think the FFR is a very validated test under any heart rate, under any setting, except in acute coronary syndrome scenarios.
Thank you. Thank you.
Dr. Mulasari, thank you very much for moderating this session, and all the speakers, they have done an excellent job. May I request, and we'll now move on to the next patient. May I request the persons, Dr. Enu Bansal, Dr. Jayachakul Rao, Dr. Karthik Jain, Dr. P.K. Ashokan, moderator Dr. C.N. Manjunath, and the expert panelists Dr. I.B. Vijayalakshmi, Dr. Manik Chopra, Dr. Nagendra Singh Chauhan, Dr. Manish Kapoor, Dr. Sanjay Mehrotra, Dr. Ravinder Singh Rao, Dr. Sachin Singh, and Dr. Sanjay Mandal to be on screen, please. Over to you, Dr. Manjunath, to start the prospects. Thank you.
Dr. Manjunath, you're muted, sir.
Muted.
Dr. Manjunath, please unmute yourself.
Yeah, unmuted.
Yeah.
Can you hear me now? Hello, can you hear me?
Yes, we can hear you.
Yes,
we can hear you. We'll go ahead with the presentation, and at the end of the presentation, we'll have a discussion. Okay?
Thank you.
Okay. Because it's a live in the box. So in between, anyway, we'll, if necessary, we'll interrupt. And anyway, the presenter is going to present as if he's doing a live case. So we'll go ahead.
So thank you, Dr. Manjunath, and thank you, Dr. Roy, and Dr. Vijayalakshmi, and all the chairpersons. Let me start with a great thanks to CSI NIC, and see if this one plays. So please stop me. This is about mitral clip, and I told Dr. I'm not able to get a tricuspid clip actually, even though we did several of those. So here my colleagues get a venous access. We with use ultrasound and still.
Dr. Ramesh, can we have some brief history and some findings? Some echocardiographic findings of this case.
Right. So this patient is an 83-year-old male patient who had a prior surgery and felt to be highly high risk for redo or mitral valve repair, and henceforth, actually, one surgeon had to see for mitral valve clip procedure in the United States, and so we had one surgeon and one interventional cardiologist who saw, and the patient was brought to the table for mitral clip. And he had been having class 3 symptoms of heart failure for more than 6 months. And he was admitted one time in the 6 months into the hospital and was on guideline-directed medical therapy. So before we try to do mitral clip, we also see if the patient is reasonable to be enrolled in any clinical trial, such as Summit, which is a mitral clip versus Tendyne, or a direct catheter mitral valve replacement alone. And so this patient was not enrolled in the Summit trial. He was not felt to be At that time, we had an Intrepid, which was a transcatheter mitral valve, Medtronic valve placement, but we did not feel that he was a good candidate for that mitral valve replacement as well. And we'll go along the video as echocardiogram and findings will be shown. So here we started off with the transeptal puncture, and a Baylis catheter was advanced, and this is a radiofrequency needle.
Transeptal, we go a little above fossa ovalis, or?
Yes, it has to be about 4 centimeters, 4.5 centimeters above the mitral annular plane. So you have to be in the upper part of the fossa ovalis, superior and posterior.
Okay.
Dr. Ramesh.
Yes, ma'am.
For the transeptal puncture, do you think the intracardiac echo is better or transesophageal is better?
Yeah, so normally we do for other procedures such as any valvuloplasties, and of course in India I've seen most of you do without any intracardiac echo as well. But here we depend upon transeptal ICE for transeptal punctures for valvotomies. But if it is a mitra clip, we always depend so far only on transesophageal guidance. We are now getting a Philips 3D ICE, which is going to probably helpful. But for Watchman or Amulet and all mitral valve procedures, we do use ICE, but except for TMVER or TIA, transcatheter end-to-end repair, with mitra clip, we use TEE. So here we measured it actually, I think about 4.7, 4.93. That is a great distance from the mitral annular plane. And you can see you can gain more height by going posterior, so by clockwise rotation. So this is administration of radiofrequency energy. And as soon as it punctures, you can see the bubbles in the left atrium on the TEE. And then we introduce this either protract wire or what you normally call as almost similar to a safari wire. And you can see the left atrial measurements are very high. V waves are up to almost 50 millimeters of mercury.
Almost a ventricularization of the atrium.
Right, yes, sir. Yeah, absolutely.
Dr. Ramesh, in India, we call it a jalebi wire because it
is jalebi wire, right. That's true, man. That was called the jalebi wire, right, yes.
Spring guide wire. Yeah.
So that's actually the wire is it's stiff enough to advance the guide, which is around 24 French guide catheter. So now our surgeon is prepping the guide. As you can see here, this is a guide catheter, and you have to, there's a valve at the end, and he's going to pass the dilator through the valve to exercise it for a few times. Because of the risk of air embolism is high, you have to be very careful to make sure there's no air that could go through this big guide that is there. And so they are flushing it.
Yeah, that's a very important thing because more often it gets into right coronary artery.
Yes. Yeah, we did have one patient actually not with the mitra clip, but with I think a cryo balloon. The initial one of them had a complete air embolization. I think because these are attached also, you will see that a lot of saline bags, and the saline bags can be emptied very fast. And if they are spiked to room air, so we don't have any saline bag spiked actually to room air, because one time it just sucked the air from the room into the left atrium and the patient really collapsed. So this is they're testing an positive and negative. The negative ones make the guide more straighter, whereas positive makes it more a bend towards the left atrial free wall. So to enter into the right atrium, we want it to be more negative. So they're going to straighten that the tip here and advance it through the obviously through the femoral vein.
So even pre-procedure, you would you decide whether the patient requires one clip or two or three?
Yes, sir. I mean, absolutely. I think if it is really a flail leaflet, we think that most of the time those patients will receive 2 clips. And if it is really a big, orifice and annular coaptation is really bad, leaflet coaptation is really bad, then we go with the 2 clips. And the majority of the times in the studies, actually 1.5 clips have been associated with a great reduction in mitral regurgitation. So once the catheter, the guide catheter is advanced into the right atrium, we go the negative on the wheel of the guide catheter is taken off. So we keep it neutral, and then we place it on a sled, which is on the patient's thigh, as you can see here. And the guide catheter is in position without any movement. So we don't want that guide catheter to be moving in and out.
All the control levers work appropriately.
Dr. Ramesh, for the pre-procedural assessment, do you use just 2D echo or the 3D and the 4D are used to assess the collapses?
Absolutely. That's a very good question, ma'am. That I think a 3D echo has become a mainstay of a diagnostic tool in these patients with mitral regurgitation, especially TEE with the 3D is very helpful. And as Dr. Manjunath asked, how many clips, all depends upon either the 3D alpha view that we can get. In mitral clip, essentially, when it comes to the views that we need only 3 views. One is intercommissural or a bicommissural view. The other one, which is usually about 60 degrees and 45 to 60 degrees, and LVOT view, 120 degree, and actually a 3D alpha view. And most of us are getting comfortable with 3D alphas now that we are actually doing most of the work, as you would see in 3D alpha view. And you can also identify the leaflets, the scallops P1, P2, P3, and in the 3D view. So here, these are the salients that are being attached, and so they come at initially a very high volume, and then we have to reduce the volume. But this is where I was saying that if somebody is not looking at the bags, they can be emptied, and initially we did have one episode of air embolism. So there are several knobs on this. It's called clip delivery system, or CDS, and I'll just go a little bit back so you can see this says M and L, medial and lateral, and on that it says on the top it will say A and P, anterior and posterior, and we'll show that actually.
How much heparin do you give for preventing the clot or embolization?
So obviously, when before we advance any transeptal puncture needle in the right atrium, we give about 50 units per kilogram body weight heparin, and once we cross, we give another 50 units per kilogram body weight. So they're completely heparinized. At every time after heparin injection, we monitor ACT 2.5 minutes after that. We immediately obtain an ACT to know that whether we could move forward or not. So if it is not 250, we wait until it is above 250. And obviously that is very important to avoid thromboembolism. And as far as the air embolism, as we said, continuously flushing them is very important. So these are wheels that actually slight change in the generation 4 or G4 system that we have. The white one on this side, which they're opening, is the clip locking system, and the one on the other side is the gripper line, which will be showing soon here.
You can test the clip. Grippers are up. The grippers came up. Unlocking the clip. Opening the clip. Locking the clip. Closing the clip. Trying to reopen the clip.
Dr. Ramesh, these clips are in different sizes or something like that?
Yes, sir. So we have NT and XT. XT means wider. NT is the normal ones. And then they come as an NTW or XTW, meaning wide clips. So the clip arms are much wider in the wide ones, obviously. And these are actually, this is a smaller one. This is an NT clip. Extra clip XT is longer and wider as well, XTW.
How do you make that decision which one to use?
Depending upon how much of the orifice, mitral valve orifice, if the mitral valve is less than 3.5, we go with the smallest one. In the studies, actually less than 4 centimeters square mitral valve, patients were not enrolled in the study. So it has to be more than 4, but sometimes if the mean gradients are still low and smaller mitral valve area of 3.5, we still go with a small NT clip. And if the flail leaflet is very big and wide, we go with XTWs.
Okay.
M mode, L is not functional as a design issue. It's just there, but it doesn't do anything. P mode.
Dr. Ramesh, does knowing the submitral structures, whether they are fused or not, does it have any impact on your procedure?
Yes, ma'am. Knowing that the chordae and the subvalvular apparatus, how actually, because we can easily get entangled. And if the cords are very close to the leaflets, you may not want to go too deep into the ventricle. You might just want to be just below the valve and capture the leaflets. So absolutely, that's a very good question, Dr. Vijay.
A mode, good.
So your TE helps there.
TE, definitely. Without TE, this is a procedure, 80% is by TE, and I think 20% is by the interventional cardiology or surgeons. But there are lots of modes, and and we are now loading up. We test the wheels because it's a very nice device, and once you know how to use the device easily. So now they're going to expose the clip for us.
Taking the bag that keeps the sheet. Pull the wire back into the dilator.
So here, before you pull the dilator, you need to make sure the wire is completely out into the dilator, because otherwise you won't be able to close the 2E, and there will be air embolism from the guide catheter again. That's another step where, see here, we don't have any air, and otherwise there is an air embolism that can happen. And now with the fluid-to-fluid connections, they are advancing the clip delivery system through the guide. There's a blue line that you have to match the blue to blue.
Making sure that
you can
the alignment is appropriate.
You can miss key. Sometimes if the blue line is not there and then you go into 180 degrees, then you can miss key. So how do you avoid that? There's a black fishbone kind of thing here. You have to keep that in the inferior portion.
Dr. Ramesh, when we are putting the device, we see whether there's a column of air. We check it by fluoroscopy. Do you do that here or no?
No, so we aspirate the whole guide a lot with a 60 cc syringe, and then we advance the clip delivery system carefully. Obviously, there's always a little bit of air that will go, but the major volume of air should not go though. And here, once the clip is advanced and what we call as a straddle on fluoroscopy, we can see that. And then they're going to place it in the stabilizer. So here, that is called straddling, where the 3 markers are next to each other, the guide and the clip delivery system.
Straddle a little bit better.
So here they lost a little bit of straddle, so they're going to advance it so that the guide in the middle is the larger radiopaque marker, and on either side the clip delivery system. And you can see that there's some changes now they're going to apply.
All right. Let me point a little bit more down. I'm going to give it a little more out.
Dr. Ramesh, the pacemaker is from the upper limb approach. Usually we go from the lower limb.
Pardon me, ma'am?
The pacemaker that you have kept, it is from the upper limb approach.
The pacemaker, yes, yeah. Usually we do it either way. That
internal jugular.
Anesthesiologist, yeah. So no, this patient did not have a. This is for he had a permanent ICD.
Okay.
Right. Yeah.
No, I was wondering whether you took the jugular approach or it is a ICD. That's the.
Yeah, that's an ICD, ma'am. Yes.
ICD. Okay.
Normally, pacemaker is there is no need, no? There is no need
for the pacemaker at all here. Sir.
Correct.
So he's opening up the clip. As you can see, the clip arms on fluoroscopy are opening, and as I mentioned earlier, the 3D echo is the most important. And they're looking at the 3D to see that the plane of the clip arms, they have to be perpendicular to the annular plane. So he's making sure that there is a little bit more, it was more medial, so he's letting go of M, that makes it more lateral.
I think I need to clock a little bit.
So you can see the arms are right now at about 11:30 to 5:30, and he wants to make it more 12 to 6. So he is wiggling it, advancing it a little bit in and out. So now it has moved to 12:16 in the 3D view.
Sure.
So this is the clip delivery catheter system that actually he advanced it and transmitting that actually very clearly. And now we are checking in intercommercial view and also an LVOT view to see where the jet is. And we are right in the middle of the jet, as you can see.
No. Looks great on fluoro. You sure? Yeah. Nice.
So you can see that the jet is actually right in the center where in this beautiful intercommercial view, you can see that we are where it should be.
I'm going to close a little bit. Okay. Wish I could see the arms better. Can you show me the LVOT view?
So in the intercommercial view, you should not see the arms. If you see the arms, that means you're not perpendicular to the annular plane.
Looks like it. All right, I'm going to start to pull back.
So he's pulling back the catheter clip delivery system. But still, it is not really very much visible. The arms are not clearly visible here.
Can't really see the posterior.
I'm sure at this stage you'd like to look at the subvalvular apparatus very carefully, that you are not hooked between the cordae.
Absolutely right. We want to make sure we're not stuck anywhere, and we also want to make sure we are not pulling the cords at the same time.
Dropping the grippers, closing the clip partially, giving it some slack.
So giving the slack means he's pushing back the device into towards the ventricle a little bit, and there's still a lot of. He hasn't closed it completely yet.
Close the clip to see what changes.
This is clearly A2P2.
I agree, we probably do not have to.
Yeah. So he did not have a posterior leaflet that grasped, and that is probably because we did not see the leaflets or the clip arms should be clear and nice and like that, and we did not see it.
Locking the clip.
So he's going to go for a second attempt. The anterior leaflet, you can see it is very clear. Now it is off. So you have to make sure that both the leaflets are good. And he's checking his clip arms orientation. So initially he was 12 to 6. Now it is more of about 11 to 5.
I think we should push it in just a little bit.
Yeah.
I don't want to.
Dr. Ramesh, we're not seeing,
Yes.
okay, they're withdrawing the TE probe. Okay, I got it.
Yes, they're looking at the TE probe.
Yeah.
So, and they're looking at mainly thinking that it is more medial, so they're going to go, more lateral, so they're going to go a little bit more medial here.
Looks good. Let's try it again. Nice.
So now you can see the anterior leaflet is coming and falling already, and but the posterior leaflet also is very close. And on once they're pulling it up, they're going to apply a little bit posterior torque. In this hand, my colleague is applying a posterior torque on the guide catheter so as to capture the posterior leaflet.
Dropping the grippers, closing the flip partially.
Dr. Ramesh, do you consider the heart rate as an important factor when you're going to deliver the clip?
Yes, sometimes it is been shown that you can give adenosine to make the heart go slower, and maybe it is easier to capture the clips.
Because some of these people may be fibrillating, and with the instrumentation, the rate could accelerate.
Yes, sir. We have.
That could make the job a little difficult.
Yes, sometimes extra PVCs, and we have given more lidocaine as well or amio, and to reduce the PVCs. But the moment that you're having too many PVCs, that's a bad sign. That means you're irritating one of the cords, or you're too deep. So this doesn't look, still they're not happy because everything looks good on the fluoro and intercommercial view. It looks like we did capture the posterior leaflet, and anterior leaflet is very much in.
That leaf was very mobile.
Dr. Ramesh, how do you avoid damage in the submitral apparatus here, like say chordae or papillary, while entering the LV?
Yeah, very good question, Dr. Ashokan. Actually, if there is a very much calcified cords, and you have to visualize with the TEE while you're going in, don't go too deep, and just having the leaflet arms open, and under TE guidance, whether it is 3D or 2D itself will be enough. You just go just below the annular plane, and if you take your own sweet time with MitraClip, it goes very smoothly. If you try to finish it very fast, then actually it takes 3 or 4 times that much time. So once you get caught in the cord, it is very difficult to take it out.
Dr. Ramesh, the knobs, they appear almost like our TE probe. Can they demonstrate how exactly the knob is turned and to position the device?
Yes, ma'am. Actually, you're right. It's similar to the TE probe. All these wheels that we're talking about, medial and lateral, and how many degrees is depending upon, similar to the TE probe. So 2 attempts have been made so far, and now the 3rd attempt, you can see the clip arms very clearly here. And so now they're pulling it back. Before, we could not see the clip arms. And I think without seeing the clip arms, how much ever we do, try to capture, we may not get a good result.
Dr. Ramesh, we are not seeing on the screen. Those images we are not seeing.
Okay, sir. Okay.
We are seeing each other.
Oh, you're not seeing the screen now?
Yeah.
Okay. So here, this is the clip arm that you can see, anterior leaflet and the clip arm. And,
still we are not seeing the images. Screen is not shared.
Oh.
We're able to see.
You're able to see me, sir, or the screen?
We're able to see the screen, which is frozen, and Ramesh also, both.
Okay. So this is the clip arm that I'm pointing to with the cursor on the anterior side with the anterior leaflet here. And the gripper is right here on both sides. And what we are trying to do is we are going to bring the clip arm from below, from the ventricle. And on the atrial side is the fish hook gripper, which is a metal gripper. And when you drop the grippers, they are like fish hooks which will catch onto the leaflet. And the leaflet is captured between the arm and the gripper. So here, at least now you can see finally the leaflet, the clip arms are well visualized compared to before. And so they captured They're bringing it back again.
Dropping the grippers.
And now he dropped the grippers and closing the clip to 60 degrees.
Giving it some slack.
And then loosen it, push it in a little bit to reduce the slack, or to create a slack. And you can see that there is still MR, obviously, much better than before.
Looks like I'm dividing the jet, so I think I got both leaflets. Only 30 degrees. I'm going to close all the way now.
There is a significant reduction of MR.
Right, and that was only 60%. Now he's going to close all the way tight.
That's closed all the way.
So now that actually has come down a significant from severe to about maybe 1 plus MR.
We do a 3D, see if we're in the middle, and then we'll go through the state.
And it's a great reduction. There is a little bit of jet on the lateral side, but nothing to worry about that actually.
Small medial jet.
Yeah, small medial jet.
Now the anterior leaflet is nicely exposed.
Nicely, yes, nicely. Yeah.
That looks fine.
So they're looking at mitral valve gradient. And the gradient, anything more than 5, we have published the data that it is going to be a little bit more admissions.
2.
And here mean gradient is 2. So in case if we need to put a second clip, we can put it as long as it is below 5. And they're looking on 3D, they're making sure that end-to-end repair is done, and it is right in the middle between A2 and P2.
Dr. Ramesh, in case you decide to put the second one, do you release the first one and then try the second one, or you keep intact and then release both together?
Yeah, so if you're if the jet is coming more medially, and you can place one clip lateral and put in a second clip medially. So here there's a 4th attempt that they're doing because they are able to get it, but they were not happy. So now the anterior leaflet is quite falling into that arm, and the posterior also you can see that it has fallen into the clip arm.
Dropping the grippers. Closing the clip.
Looks like one clip may suffice in this case.
Yeah, what we are trying to do is we can trying to adjust it to in such a way, taking our own sweet time with the 4 attempts, rather than just going in the first one and being suboptimal result. So
show me the worst of the MR and I'll close it all the way.
So if it is one clip can suffice, that will be great actually.
Dr. Ramesh, talking about the mitral gradient, it's more
Yes,
than 5, you won't proceed further. Have you come across any iatrogenic mitral stenosis where there's a significant gradient after the mitral valve clipping?
Yes, we have, with patients who did not have gradient more than 2, we actually took it up to more than 5 sometimes. And people who had 6 or 7 did not do quite well. They actually had more symptoms. And so we treated mitral regurgitation, but now we gave them mitral stenosis, which is not good. So ultimately, one patient had to go back for surgery. Because of the increased symptoms. So I think mitral stenosis and regurgitation both are important to be treated, and do not give mitral stenosis to just reduce mitral regurgitation.
I want to get more of the. Okay.
Yeah, that's correct. It becomes both stenosis and regurgitation.
Yes. So here, Dr. Manjunath, you can see the clip arms very clearly here, right?
Yeah, that's correct. It's nice.
So this is so sometimes these long ones, they escape. So they're going down a little bit more into the ventricle to make sure, but they are missing the anterior one. So they're coming back with the anterior. Now it's falling, and now they'll move the guide to capture the posterior leaflet. Yeah. So
that looks nice.
And then they grab the leaflets.
Grippers are down. Closing the 60 degrees, giving it some slack.
I think now both are caught.
Both are good. And even though earlier we are not actually getting the most of the leaflet. That's
Yes.
Stay right there. It just makes it better.
Now this looks better.
Definitely got
Yes.
less. Closed all the way. I think
So this is our echocardiographer who's
that's right. That's right. I think you're in the middle, man.
so John is our echocardiographer, and he has been doing quite well, and with his protection and putting his hands in the back and managing it, and anesthesiologist is getting tired, and but look at the left atrial pressures now from 45 or so, of, sorry, 49 or 50, it has come down, VVF have come down to 20. So this is also a hemodynamic measurement is very important, and that's the only time that we actually make sure that it is clear.
That's a great result.
Yes.
How did you measure this pressure now? Do you have a second catheter or there is a side hole in the system?
We have a side hole, we can measure it with the guide. And,
so you can do it continuously?
Yes, sir. Yeah.
Right.
Some people put pigtail, a Cyball likes that, but it's okay, we can use it. So I'll stop here and take any questions, and I'm sorry that it has been a little bit longer than expected.
It is nice that it has been longer, that we could see how you need to position and really spend the time so that you are, at least from your side, most perfect.
Yes.
And you have shown us a very good hemodynamics, that from 49 LAP, it has come down to 20 LAP, which itself speaks that your clips are in position and the infestation has reduced.
Thank you, Dr. Ramesh, for this wonderful live in the back case. Perfect, clipping and virtually eliminating significant MR, and also the steps were nicely shown. And basically, you should have a lot of patience. Patience is also skill, and patience has to be go together here.
Yes, sir. Yeah.
Congratulations. That was a great show. Though
Thank
it
you.
was late, you showed us how to hold the valve so well. That was nice maneuvering.
Thank you very much, ma'am.
Nice.
You said the patient of a major surgery.
Yeah. Yes.
Dr. Ramesh, there are cases of embolization or losing those clips in the process of capturing and delivering them?
Yeah, partial detachment can happen, sir, but it is now much less. Partial detachment also has been reduced, and because the new generation is very, very good in grasping the leaflets. But very rarely you can have complete detachment. That is really it is iatrogenic, meaning we haven't done a good job.
Mm-hmm.
Yeah. So thank you for all the participants who have been there, and I appreciate all the questions.
Congratulations. Thank you.
It's a great learning case. Thank you.
Thanks a lot.
Thank you, sir.
Dr. Ramesh, of course, this is not a mitral clip. How is COVID situation back in US?
Oh, much better now, sir. Only people who are getting infected are the ones who are not vaccinated. Yeah, but otherwise it's really great now. Yeah.
That was
Are you all concerned about the Delta variant?
Yeah, the people we are seeing increased cases of Delta variant, and but if you're vaccinated, the incidence of infection, morbidity, and mortality is much lower, even with the Delta variant. Yeah. And I can vouch for that. I got the Delta variant myself.
But we have another live in box.
So any other
by Dr. Subhash Banerjee.
Thank you, Dr.
As well. Thank you, sir.
Thank you.
Anyway, I thank all our panelists for interaction, and I think already we are late by about 5-6 minutes. I think we'll close this session. Thank you.
Thank you, Dr. Manjunath.
Thank you, everybody.
Everyone, sir. Thank you very much.
Thank you, madam. Seeing you after a long time.
I know.
is the end of this program. The session, I think today's program is closed.
The time is given was 9:20. Maybe we had 10 more minutes for discussion.
For interrupting, but we have a live in a box session by Dr. Subhash Banerjee.
So after this?
Yes, sir. So should we start with that?
Yeah. So we didn't know actually. It's fine. Otherwise, we would have stopped about 3-4 minutes back. Go ahead, please.
We have two cases, sir. 2 live-in cases. This is the second.
Good morning, and thank you for inviting me to the CSI National Interventional Council 2021 TAVR case presentation. Here are my disclosures, none particularly relevant to this presentation. I have 2 TAVR cases briefly to share with the group. Here is the first case. This is regarding a 72-year-old male who has had prior coronary bypass surgery and aortic valve replacement with a trifecta 25 millimeter bioprosthetic valve in 2012 and presents with symptoms of dyspnea, exertion, and advanced heart failure, and was diagnosed with a severe prosthetic valve aortic stenosis. This is his 3D TEE demonstrating circumferential pannus and leaflet calcification. We embarked after adequate workup for performing his valve-in-valve TAVR. The angiogram on the screen demonstrate aortographic images obtained during the TAVR procedure and during multiple prolonged attempts of crossing the valve, which was unable to be crossed even with transesophageal echocardiographic guidance. And after spending about an hour on trying to cross the valve and taking images in multiple projections, we embarked on a transeptal approach. TE-guided transeptal puncture was performed, and antegrade crossing of the bioprosthetic valve was attempted and successfully performed. This is the EP Agilis transeptal sheath through which a GR4 catheter was advanced over a glide wire, which was then antegradely crossed through the aortic valve and snared from the common femoral arterial axis and externalized. And a pigtail catheter was then placed in the ventricle, and retrograde balloon was then advanced over that same guide wire. Those steps are not shown here, but this is the image of the balloon aortic valvuloplasty of the trifecta valve with a 22 millimeter Z-med balloon with rapid ventricular pacing. You can see the waist of the balloon, and after balloon valvuloplasty, the balloon is removed. But immediately after, the patient faces acute hemodynamic decompensation, and is quickly put on ECMO support and connected to the CardioHelp. Both arterial and venous cannula, as you see, are placed into the patient because of sudden hemodynamic decompensation and collapse. This is the standstill image, just to exclude left coronary angiogram to rule out coronary injury during prolonged retrograde valve crossing attempts. As you can see, his coronaries are patent, and none of the grafts that are also injected are shown here. However, the no coronary obstruction especially to the left main and to the branches originating from the left main were visualized. To treat the acute insufficiency that was diagnosed with TE as a result of the balloon valvuloplasty of this heavily degenerated bioprosthetic valve, as you can see, an Evolute R 26 millimeter self-expanding valve was deployed within the bioprosthesis to treat the acute severe aortic insufficiency that was diagnosed. This resulted in some transient stabilization, but the patient still remained in acute pulmonary edema, and the left atrium was required to be vented. We ultimately wanted to go towards a tandem heart cannula, but it was not immediately available, so the Watchman sheath was placed to vent the left atrium, which was later exchanged for a tandem heart cannula in the left atrium, and the patient remained on CardioHelp circulatory support. The patient was stabilized and taken to the University Hospital's intensive care unit, where the patient was finally decannulated on day 2, status post-TAVR, extubated the following day, and discharged after a permanent pacemaker placement on day 7 post-procedure with no intermediate or long-term sequelae. That is the first case, and the second case is another interesting TAVR, which I may have shared with some of you once before, but I think it's worth repeating in the sense that this is a unique case of a late valve migration after a self-expanding valve implantation in a patient with severe aortic stenosis. And the ventricular migration of the valve led to partial coronary obstruction, and hence was the indication to pull the valve up and implant a second valve if needed in that position. As you can see, these are snaring efforts to snare the evolute valve from bilateral radial axis, and multiple attempts were made to do so after the valve was retrogradely crossed and a safari wire was placed in the ventricle. These are two attempts to further show the removal or upward migration or movement of the valve using snares. The right panel shows that ultimately we were able to successfully remove it, and upon removal of the valve into the ascending aorta, there was sudden hemodynamic decompensation of the patient, and the TE quickly diagnosed severe acute aortic insufficiency, which was treated with implantation of a second self-expanding valve within the previous one, as shown here. This is a 29 valve, along with cardiopulmonary resuscitation being performed. And on the panel right, you can see the second valve implanted in the aortic position. The patient's hemodynamics became slightly more stable. However, the patients did require infrequent, however, continue to require some cardiopulmonary resuscitation and chest compression. TEE was performed that showed sluggish left ventricular function, which was supported with a impella catheter placement through the two recently implanted valve. And but although the impella was placed, the impella flows were very diminished. And the TE image that I'm going to share with you will show that although the left ventricle had the impella placement, there was no flow because of severe dilatation of the right side from prolonged requirement of cardiopulmonary resuscitation. And that led to the placement of an RP impella into the to support and improve the right ventricular function. As you can see in these echocardiographic pictures, the left ventricle is completely collapsed. There's an impella catheter in place, and the RV is severely dilated, providing the RP impella now in the right ventricle. You can see that the flow towards the LV is better, and the LV is slightly more better filling, and the cardiac output on the left side significantly improved, and the patient became more stable. Here is a subsequent picture of the same hemodynamic consequence after placement of initially left and then right-sided impella support to this patient. The patient overall did well. He was extubated and was off mechanical circulatory support by day 3 and was discharged after permanent pacemaker placement on day 6 post-procedure with no intermediate sequelae. I am delighted to share these two complicated cases of transcatheter aortic valve replacement with you. I hope you enjoyed it. It's unfortunate that I'm not able to join you live, but I will hopefully be able to receive through the moderators questions and comments to these cases. Again, thank you for inviting me.
Can you hear? I think there is some connection is lost.
I think it was recorded. We were not able to interact with him.
Must be recorded, Ansate. Hello, can anybody tell us?
It was a, ma'am, it was a.
Sanjay can tell us.
It is totally recorded or is still, I mean, is on live?
Ma'am, it was a pre-recorded talk.
Okay.
Oh.
Sanjay can answer my question because I'm ignorant about
Actually, the pulmonary edema must be because of acute AR.
Correct.
Because the valve was pre-dilated with the 22 mm balloon and patient has developed severe acute AR. That is the reason for pulmonary edema.
Yeah, and I thought that the calcification was a bit too much, and then I was anticipating some problem because both in echo as well as on fluoroscopy, the calcification score was very high.
The problem here is these valves, which are bioprosthetic valves, when you dilate them, and you have to dilate them, they're extremely fragile. So we expect that they would go into a severe AR because the valves will just dehisce. It is so horrible. And I think one has to be very ready for the ECMO to go on. And that's why in our hospitals, every time we do a TAVR, there is an ECMO ready. There's a perfusionist who's inside the lab. Because who will do that even otherwise is very difficult to predict. And I have lost, of course, one patient despite putting him on ECMO. Not ECMO, but they took him for surgery. But what he did was amazing. I mean, you're putting a right ventricular impella, you're putting a left ventricular impella, and ultimately you're showing somebody who's coming out after 1 week and walking out of the hospital. Many of us will feel, oh, this patient is gone, and we will have a lot of kinds of concerns about how to face the family. But I think these are all kind of what you call it cowboy cases in US, and these guys are especially, we have a lot of responsibility in terms of costing and patient sickness, family. It doesn't just end here when you have a complication. It goes on for months into your head. Isn't it, Dr. Manjunath? What do you think?
Yeah. The whole week you'll get depressed, totally depressed. And so, in fact, the diagnosis is made at home. Sanjay, I just wanted to ask, particularly this degenerative aortic stenosis, can we underdilate them rather than using 22 mm balloon, maybe 15, 16 mm balloon?
So normally
even with that, there can be severe AR, right?
Normally we don't dilate at all, but here is a situation he can't cross because it is so bad. Then he had to go retrograde, and he has to cross, snare the wire, and of course he thought that you have to dilate these valves. Now I will not dilate that much, but if you ask a surgeon, and I have discussed with our surgical colleague that these valves, if you dilate, they will just dehisce. Please don't even touch them. So what I have done is deploy the valves directly without pre-dilatation. You don't pre-dilate them. But I think his was a situation where he cannot just go directly because there's no orifice. It's a tiny pin there. So first of all, very difficult to access. And the other thing is that when you have an artificial valve which is hanging in the aorta, when you bring the device out, it tends to sort of hit the outside of the valve and will not go in. So you have to snare the valve in. So you put two snares, you pull the wall, one snare is pulling the whole device towards you, and then you go inside. I have done at least 3 or 4 cases like that now. You have to snare, otherwise it will not work. They don't go inside. Especially the core valve or the evolute valve, they don't have a flex. The Sapiens and the MyValve, you can flex the device. But the results of a self-expanding valve in a valve-in-valve situation is much better as compared to the a valve-in-valve, which is a balloon expandable valve. Yes, sir.
I think the fragile valve and the calcification both are very challenging. So
very challenging. Although it looks easy, but if you have a patient like that who arrests, then you have to put an ECMO and then you have to continue to do. It is not an easy thing. And I do expect that when you take that valve out, which is now you have put in, you would have AI because there is no support of that valve. You have to put in the second valve quickly. So I'm pretty sure that they keep the other valve ready to go in. It is in the descending aorta. You pull the other valve and bring the other valve quickly down, because the pulling of the valve is done from the other sources like the radials or the brachials. You have to pull it up. Otherwise, you cannot, and then you have to bring the other valve ready in the descending aorta, just advance and deploy quickly.
So how often you do retrograde nowadays?
Nightmare, and nightmare is back into the sweet dreams, So I'll
sorry, Dr. Ashokan, you said something?
Yeah. How often nowadays we do retrograde approach?
No, I have never done. I have only done in a pediatric case when I was called. There was a unicuspid valve. They wanted to dilate. They could not enter from the antegrade. I said, okay, let's go integrate from the aorta. Puncture the septum and you float a PTCA wire that just comes out from the ventricle and then you snare it out. So
in that situation, apical is preferred? Apical approach? No.
Apical approach has higher mortality, so I don't think it is a very comfortable process. No. But a retro, probably what I would suggest is that in such situation, probably you be ready to snare out and then go back. And if you can track the valve without pre-dilatation, would be still a good idea. Most of the valves you can enter, even if suppose they are very, very tight, because this device which you're carrying in is a very stiff device. And I think in this situation, I will probably put a Lundquist wire rather than a Safari or a Confida wire or an Amplats wire, because the Lundquist is the strongest wire in terms of pushing it across. So you have to have a better support to go inside. And I would probably, if possible, I would use something which is, easy to go in, maybe a Edward here, but Edward will always lead to a little more chances of prosthesis mismatch because there's already a valve inside. So the valve cannot be expanded more than what the size of the previous valve is.
Sanjay, I have one last question because we have to finish by 9:30. The pacemaker lead was in RVOT in both the cases. Do you prefer in the RVOT or in the Apex?
No, I have not tried to put in. I think that patient probably might have had a septal, previously a pacemaker. I don't know. That was an AICD most likely. You know that there was an AICD.
It appeared like that,
Yeah, so but nowadays most of our electrophysiologists prefer to screw it into the septum, because then you have a better, activation of the septum. Because the results of a RV pacing or a septal pacing are different. The septal pacing is much better as compared to the RV apex pacing.
Yes.
Most of the electrophysiologists put the AICDs in the septum, especially if the ventricular function are not very good.
It's long since I met you. It's nice seeing you.
Yes, ma'am. Yes, ma'am. But you look the same. You look exactly the same. I can't differentiate a Dr. Vijayalakshmi, whom I saw probably some 20 years ago.
Thank you so much. Good night, everyone. It was a pleasure.
Thank you.
The great cases. Thank you.
Thank you, ma'am. Thank you. Thank you, sir. Thank you, Dr. Manjunath.
Thank you very much.
Thank you.
This LV wire can be used as a pacemaker, no, nowadays?
Yes, sir. Yes, sir. It can be used.
There is no need
I have not
a venous side pacemaker. The LV wire itself can be. You can
one of the poles. One of the poles.
Poles, yeah. So without a venous puncture.
Extra pacemaker. Yeah.
So the next session is industry symposium. Anyone from biosensors?
Thank you, sir. Thank you, all of you. Good night, sir.
Yes, sir. Please carry on, sir. Hello.
Okay. Hi. Well, I'll share my screen with you guys. Can you see the screen?
Yes, very much. Please go ahead.
Great. Well, thanks again. So my name's Keith Oldroyd. I'm an interventional cardiologist at the Golden Jubilee National Hospital in Glasgow and have a personal chair at the University of Glasgow. I'm also the Chief Medical Officer for Biosensors International and also a structural heart company called New Valve Technology. And so this is my conflict of interest in relation to this presentation on the management of high bleeding risk patients. So the story of high bleeding risk, of course, really kicked off in 2015 with the publication of the Leaders Free trial in the New England Journal of Medicine. I was one of the investigators and a co-author on this manuscript. And you'll remember that this was a randomized comparison of bare metal stent against the biolimus coated stainless steel stent, the BioFreedom. And of course, it was double blind because the packaging was done by the company, and so it was possible to conceal the identity of the stent. So it was one of the rare double blind stent trials. And this was the primary efficacy endpoint, clinically driven TLR. The prediction was based on previous data to be 10% with the bare metal stent, and the drug-coated stent, of course, was dramatically better at 5.1% in 1 year, hazard ratio of 0.5, highly superior. So the polymer-free drug-coated BioFreedom stent performed as you would expect for a drug-coated technology. What was a little bit more surprising was the primary safety endpoint, which was a combination of cardiac death, MI, and stent thrombosis, predicted to be 8% at 1 year in this high bleeding risk population, who of course also have a high ischemic risk. Actually, it was 12.9% of the bare metal stent group. And the drug-coated stent was again dramatically lower at 9.4%, hazard ratio 0.71. Now, this was set up to show non-inferiority. It wasn't anticipated that the drug-coated stent would actually be safer, because as you will recall at the time, there was a lot of concern about using short DAP. This was only 1 month DAPT in both arms. But it turned out that the drug-coated stent was actually safer with a almost 30% relative risk reduction. So that set the standard for the management of high bleeding risk patients undergoing PCI. The BioFreedom stainless steel device became the device of choice in this population and was included in all of the major international guidelines. Just to show you that in the ACS population, of course, there was some concern about whether or not you could get away with 1 month DAPT in an ACS population who might have other vulnerable, albeit non-target culprit lesions. But again, you can see that the primary efficacy endpoint, clinically driven TLR, the benefit was preserved. In fact, if anything, it was accentuated in the ACS population. And this is out to 2 years follow-up now. So a robust long-term result, 55% relative risk reduction. And again, in terms of safety, the cardiac death, MI, stent thrombosis, safe combined safety endpoint, again, the effect was magnified in the ACS population with a hazard ratio of 0.56, so a 44% relative risk reduction. So far from there being a loss of benefit in the ACS population, actually the benefit was enhanced. Now that brings us right up to the more recent situation with the Onyx 1 trial. So this is a trial that was sponsored by Medtronic. It was a head-to-head comparison between the BioFreedom stainless steel and the Resolute Onyx. I was also an investigator in this trial. Just to remind you about the two devices. So the BioFreedom is stainless steel. It has biolimus A9. There is no polymer. Because it's stainless steel, it has slightly thicker struts at 114 to 120, depending on whether it's the small or the medium-sized device. The Resolute Onyx is a cobalt chromium stent with a platinum iridium core, which gives it some enhanced radio opacity. It has zoterolimus. It has a durable polymer, so not even a biodegradable polymer, but a permanent polymer. The strut thickness is 81 to 91, and it has a slightly larger range of stent diameters. The design of the Onyx 1 trial was a one-to-one randomization of approximately 1,000 patients in each arm. It used the same safety endpoint as Leaders Free, cardiac death, MI, or stent thrombosis, but it had a slightly different efficacy endpoint. Instead of just clinically driven TLR, they had target lesion failure. So a combination of cardiac death, target vessel MI, or clinically driven TLR, and various other secondary endpoints, as you'll see. So this trial, which was the first head-to-head comparison of a drug-eluting stent against the BioFreedom, recruited a very high-risk population. Of course, high bleeding risk, one of the major criteria is age over 75. So you can see the average age was high at 74. Just under 40% diabetes in both groups. 30% of the patients with previous revascularization, 30% with atrial fibrillation, which again was, of course, one of the selectors for high bleeding risk because these patients were on anticoagulation. And again, just over half the patients with an acute coronary syndrome. So not a lot of STEMI, only 5 or 6%, but a lot of non-STEMI and unstable angina. The criteria for qualifying patients into this study were pretty well identical to leaders free. The number one was age over 75, number two was oral anticoagulation, and in equal third place was anemia or a need for previous transfusion or chronic renal failure. So very, very similar populations to the population studied in the original leaders free study. Now here's the 1 year outcomes, and I'm sure you'll have seen these because they were published in the New England Journal of Medicine at the end of 2019, along with a presentation at TCT by Stefan Windecker. You can see that at 12 months, there was absolutely no difference at all between the two groups, 17.3% in both groups for the cardiac death MI and stent thrombosis endpoint. This was actually much higher than they had predicted from leaders free. One of the reasons probably is that they used a different definition of myocardial infarction in Onyx 1, and I'll come back to that shortly. For the target lesion failure, where you might have expected some signal of better performance of the more modern Resolute Onyx with the thinner struts, actually there was no difference again whatsoever, 18% against 17.9. Again, this was higher than predicted based on leaders free, but again, it's probably because of the MI definition. So absolutely no evidence that Resolute Onyx was better than BioFreedom at 1 year follow-up in this study. Now, in April of this year at the ACC, Stefan Windecker presented the 2-year data. This hasn't been published yet, so what I'm going to show you now is our slides from the ACC, but they are publicly available. So you can see the 1 year data, and then out to 2 years, absolutely no difference. So no evidence that Resolute Onyx was beginning to perform better than BioFreedom in the long term. In fact, if anything, there's a slight tendency for the cardiac death MI and stent thrombosis rate to be slightly lower with the BioFreedom at 2 years, although clearly that is a very small difference and it's nowhere near being statistically significantly different. For TLF, again, we see almost the opposite of what you might have imagined, although it could be a benefit of having no polymer. That from 1 year to 2 years, there is a little separation of the curves. It's in favor of BioFreedom, so a lower target lesion failure rate at 2 years. But again, absolutely confirms that the Resolute Onyx does not have any advantages over BioFreedom in this setting of high bleeding risk patients with 1 month DAPT in both groups. Now, when you look at the clinical outcomes and break them down at 2 years, there are some very, very interesting results. And I don't think these have received as much publicity as perhaps they deserve. So if you look at all-cause mortality, so there's a 3.5% absolute risk reduction in all-cause mortality in favor of BioFreedom, and that is statistically significant with a p-value of 0.025. On the other hand, when you look at spontaneous MI, there's a higher incidence of spontaneous MI in the BioFreedom group. Now, if you look to the left, you'll see that all myocardial infarction is no different. So we're not entirely clear what counts as spontaneous MI in this study because the data hasn't been fully published. But I think you can guess that if the all MI rate is the same, but there's more spontaneous MI, then there must be less periprocedural MI with the BioFreedom. And as you'll see, that is indeed the case, although it's not reported on this slide. I'll show you in a moment. At the end here, we've got clinically driven TVR. Now, this is TVR, not TLR. The clinically driven TLR rate, which was part of the composite efficacy endpoint, shows no significant difference. The clinically driven TVR does show a difference. And again, it's in favor of Resolute Onyx, but that was not part of the efficacy endpoint. So what do we think about this reduction in all-cause mortality in favor of biofreedom in the Onyx 1 study? Well, as I said, it's a 3.5% absolute risk reduction. That is large. If you saw that difference in a trial of 2 pharmaceutical agents, that would be headline news. It equates to a 22% relative risk reduction in all death, which is statistically significant. And half of this is cardiovascular death. So there's also a 22% relative risk reduction in cardiovascular death. Now, that alone is not statistically significant. But this is not the scenario of the XL trial, for instance, where there was excess mortality in the PCI arm, but it was all non-cardiovascular. This reduction in mortality in favor of biofreedom in Onyx 1, at least half of it is cardiovascular death. And you can calculate the number needed to treat with a biofreedom to avoid a death is 29 patients, which is a low number in the context of modern randomized clinical trials. Of course, it's an underpowered secondary endpoint. We have to accept that. But it is pre-specified. It is the hardest endpoint in all clinical trials. There's no equivocation about whether you're dead or alive. And of course, half the reduction is cardiovascular. If we go back to the myocardial infarction, the increase in spontaneous MI with biofreedom doesn't fit with the mortality reduction. So that raises a red flag about how the myocardial infarctions have been adjudicated and defined. There is no excess in all MI. So what is the explanation for this apparent increase in what they describe as spontaneous MI? Well, yes, there is a 1.8% excess in type 1 MI, but there's a 1.5% lower rate of type 4A MI, in other words, periprocedural MI. Now, this is a little bit counterintuitive. I'm sure that the investigators, including me as one of them, kind of thought that a thinner strut stent might result in less periprocedural MI, but in fact, that was not the case. There was also a 0.8% excess in type 2 MI events in the biofreedom arm, but of course, type 2 myocardial infarctions are highly unlikely to be related to the intervention. So that's probably just statistical noise. And I just want to close by reminding you that actually stainless steel stents do have mechanical advantages over both cobalt chromium and platinum chromium stents. If you look here on the left, this is recoil. So recoil is greatest for cobalt chromium stents. It's a bit less for platinum chromium, and it's much less for stainless steel. And if you look at percentage recoil here, on the left, we have the biosensor stainless steel stent platforms at different nominal pressures and balloon diameters. Then we have our own cobalt chromium platform, the Xience, the Synergy, the Resolute Onyx, the Ultimaster, and the Orsiro. Now, there are trade-offs in stent design, of course. You sometimes, what you gain on the swings, you lose on the roundabouts. But here you can see that the stainless steel platform has the lowest recoil. Similarly, again, if you look at the left here, it's the same comparison. The stainless steel platforms have the greatest crush resistance. In other words, they have the best radial force. So the radial force of stainless steel is greater than cobalt chromium, which is greater than platinum chromium. You can see the radial force with the Synergy is the lowest of all of them. And finally, for stent cell opening diameter, and this is for a 3x18, you can see that we've got excellent cell opening diameter with the stainless steel platform of the Biomatrix and the Biofreedom stent. And this is larger than any of the other available stents on the market, including some very thin strut stents like the Synergy and the Orsiro. And it's all to do with the geometry of the stent design. So to conclude, the Biofreedom stainless steel and the Leaders 3 studies set the standard of care for high bleeding risk patients undergoing PCI. Onyx 1 confirms that Resolute Onyx is no better than Biofreedom stainless steel. Onyx 1 shows a significant mortality reduction in favor of Biofreedom stainless steel. And the Biofreedom stainless steel stent has mechanical advantages over both cobalt chromium and platinum chromium stents. And I would put it to you that it remains the standard of care in high bleeding risk patients undergoing PCI. Thank you very much indeed for your attention.
Thank you. Thank you, Dr. Keith, for that excellent presentation. And as you have emphasized, the high bleeding risk patients are on the rise because the geriatric cardiology is catching up. We have got more and more elderly patients coming for PCI and more of patients with renal failure also. Now, I would like to ask you one question. What are your thoughts on drug-eluting balloon in people with high bleeding risk because there is no need of intense dual antiplatelet therapy?
Yeah, no, it's a great question, and I think particularly as limus eluting balloons begin to become available, and of course there are several limus eluting balloons commercialized now, and we also have a bi-limus coated balloon, and we hope to show the first in human study data with that at a late-breaking clinical trial at TCT later this year, leaving nothing behind at all. So no stent, not even a polymer-free stent is, of course, an attractive option in certain high bleeding risk patients. Now, it won't be possible in all patients, as you know, but I certainly have no objections, and sometimes I do this myself. Try and get a nice result with a drug-coated balloon, and if you get a nice result, then fine, leave it.
Yeah, exactly. In selected cases where there is no stent thrombosis and DAPT can be given only for 90 days. Sure. Any comments from my co-chair, Dr. Kali Chelvan, Dr. Balaji, Rajagopal? You are muted, Balaji.
I just wanted to know, how about the stents, regarding the outcomes, clinical outcomes you have fine, but compared to the newer, the cobalt chromium and platinum chromium platform, how comfortable are you in using the stainless steel platforms, irrespective of large size from left main to tortuous vessel? How comfortable over there? Because was there any subset analysis in that study with respect to that biofreedom coated stent with respect to the lesion subset?
So we haven't seen any subgroup analysis in Onyx 1 yet for for instance left main or if you want to call it complex PCI, but certainly, for instance, in the situation you describe in the left main, then the stainless steel platform has tremendous advantages in the left main because it has probably the best overexpansion capability. It has the best cell opening, and it has the best radial force. And this is what you need in the left main. And this is, for instance, why when Boston evolved the Synergy stent with very thin 74 micron cobalt chromium platform stent and tested it in the left main, in the ideal left main study, for instance, of which I am the co-investigator, and what was also presented at TCT recently, the results weren't great. And Boston themselves have moved from the Synergy to the Synergy Megatron. They've increased the strut thickness of the Synergy specifically for use in large vessels like the left main, like for instance, the osteo lesions in the right coronary artery, because they've realized that what you lose by going to thin strut cobalt chromium in terms of radial strength and overexpansion capabilities, that compromises the performance in the left main. So again, I think the stainless steel platform has a lot to commend it. We do have a cobalt chromium version of biofreedom, of course. It's not available in India, and so I haven't talked to you about it today. But with all stent designs, there are trade-offs. But I still think that stainless steel has a lot to offer in certain situations.
Would you like to, when you switch over to a single antiplatelet after maybe 3 months or 6 months, would you like to continue the aspirin, or would you like to continue the ticagrelor or clopidogrel?
So just to emphasize that both of these studies were 1 month DAPT, so not 3 months. So this is quite aggressive discontinuation of the dual antiplatelet therapy. It's at 1 month, not 3 months. It has generally been the case up till, I would say, the last couple of years that we've continued with aspirin as monotherapy. Of course, some people can't take aspirin, so we leave them on clopidogrel. Clearly, there's more and more data now for monotherapy with a P2Y12 blocker other than clopidogrel, so either prasugrel or ticagrelor. We've got global leaders, we've got Twilight, there are several Korean studies with monotherapy with either prasugrel or ticagrelor. So my guess is that over the next 3 to 5 years, we're going to see a series of studies showing that actually the best outcomes are obtained when you drop the aspirin altogether and use either prasugrel or ticagrelor.
Thank you.
Dr. Keith, I have one doubt. See, we have two set of stents. One is polymer-free stents, another is durable polymer. And these polymer-free stents, after some time, it will become a bare metal stent, isn't it? Once the drug is so definitely that is inferior to a durable polymer stent because fluoropolymer and everything is highly thrombus resistant. So definitely once the drug gets eluted, it will become a bare metal stent. So it is inferior to a durable polymer stent. What are your views?
Well, the point of biolimus is that because it has 10 times the lipophilicity of the other limus drugs. For instance, if when you talk about fluoropolymer, you're talking about the Zion stent with a permanent polymer. The drug stays in the tissue for a very, very long time, even though there is no polymer to control the release. So certainly the release of the drug is faster without a polymer than it is with either with a durable or a biodegradable polymer. But biolimus was specifically designed to have a very long tissue half-life and very long bioavailability. And all I can say is that that's a randomized trial of Resolute Onyx, a very, very highly considered state-of-the-art DES against Biofreedom stainless steel. And at 2 years outcome, 2 years follow-up, there is absolutely no difference, except for the mortality benefit. Now, the mortality benefit may be a reflection of the unique properties of biolimus. I mean, we can't prove that, but we've always thought that the unique properties of biolimus was specifically designed, specifically designed for local drug delivery. And it may be that this is what you're seeing in the Onyx 1 trial at 2 years.
What about your idea about absorbable polymer thin stent 4th generation when compared with the Biofreedom in high bleeding risk? Is there any data needed or?
Well, I mean, it may be that some of the companies will do comparative trials against Biofreedom. I mean, obviously, this trial was not conducted by Biosensors; it was conducted by Medtronic. I think, my own view is that the evidence base for polymer-free drug-coated stents in high bleeding risk patients is very, very strong, and the Zion's data is not based on randomized trials. And the synergy data that they say that you can use short duct, it's not based on randomized trials. It's based on registries and historical comparisons. So I think randomized trial data is what we should use to guide our practice, and that's why I concluded by saying that I still think the Biofreedom is the standard of care.
Any more comments from the co-chair? If there is no comments, we will close the session.
Okay.
Thank you, Dr. Keith. Thank you, Dr. Keith.
It's a pleasure. Thank you for the opportunity. Have a great meeting.
Thank you. Bye-bye.
Bye-bye.
Hello.
Hello. Yes.
The next symposium is on AstraZeneca Evolving Dynamics of Oral Antiplatelets in ACS Management by Dr. Kamal Sharma.
Hello, good evening, everyone. Thank you, organizing committee, NIC, for giving this opportunity. Respected chair, good evening from Ahmedabad. So I'm going to touch upon the evolving dynamics of ACS and look at the DAPT, and we had a fantastic discussion in the previous session, which looked at the and DAPT, some debate on the chair as to when to stop, what to choose, and some interesting comments coming as to why aspirin may be out soon. If not later. So I'm just going to cover a brief history of antiplatelets. We'll move beyond standard dose of clopidogrel aspirin, look at prasugrel, ticagrelor, or prasu or ticagrelor, and we'll also touch upon monotherapy with oral antiplatelets, which will look at stop DAPT2, smart date, global leaders, twilight, and PICO trial. So brief history is, we all know DAPT, that is aspirin and clopidogrel, was started in CURE trial in 2002, which looked at the composite of death, MI, and stroke, which was reduced by 21% at 30 days compared to aspirin alone in relative risk reduction, and with a significant increase in a major bleed from 3.7% to 2.7%. And PCI cure showed even greater reduction of 30% in 2,658 patient angioplasty subgroup. So this moved us to DAPT arm, and then of course we have to continue. What next? We'll have to look for efficient active metabolites, rapid and consistent inhibition of platelet, and we were also looking at the recommended loading dosages of 60 milligram with 5 to 10 milligram maintenance dose of ACH with PCI is prasugrel coming in as also a thienopyridine. So, but though it was more potent, efficient generation of active metabolite, look at the inhibition in terms of intraton TIMI with the primary composite endpoint showing benefit with the pre-specified time to point and persisted to end of the study as well. And prasugrel did much better in terms of MI. We all know this, that the 24% relative risk reduction, though CV death or stroke did not reach statistical significance, but MI drove the composite endpoint also towards statistical significance of the primary predefined composite endpoint. But the superiority was offset by increased rates of bleed. So we know that the non-CABG related bleed, including fatal bleeds, were higher, and even secondary CABG related bleeds were also higher. So prasugrel has shown to increase the risk of fatal bleeds over clopidogrel, but its efficacy by reducing MI actually gave it the upper hand, and that's how it came to be used, with overall subgroup analysis showing that more than 75, less than 60 kg or history of TIA doing actually worse with more evidence of bleed, including major bleeds. And we all know that it's an irreversible inhibitor. That's why probably we needed a black box warning of increased bleed in these subgroup of patients and CABG for at least 7 days that you need to stop this drug prior to it. So then science moved to first non-thienopyridine ADP blocker, which is analyzed both in ST-ACS as well as NST-ACS, primarily looking at a reversible direct P2Y12 inhibitor with more rapid action compared to clopidogrel, and higher level of platelet inhibition with more rapid reversal, which was ticagrelor. And that's how in Plateau trial, we all know the combination actually significantly reduced major events and resulted in 21% relative risk reduction in mortality at 12 months compared to aspirin with clopidogrel in the Plateau study. There was no significant difference, however, in the major bleeds, which was a concern with the prasugrel arm. And of course, we all know that the inclusion included patients undergoing a revasc as well as not undergoing a PCI, whether they had STMI or NSTMI. And the Plateau major bleeds, TIMI major bleeds, bleeding from RBCT, fatal bleeds, ICH, as well as CABG related bleeds were not significantly different. Only minor bleeds were slightly higher when they were slightly statistical significant. Major bleeds, there was no difference. So significant 21% reduction in death with ticagrelor being the only P2Y12 inhibitor to demonstrate mortality benefit in ACS as compared to clopidogrel. And this was driven not only by MI, but also by as an independent predictor in CV death. Of course, the composite of the same, hence was also significant in favor of ticagrelor. So when you look at short and ultra short DAPT, you're moving towards a monotherapy with oral antiplatelets, and what determines it will depend on the patient who has a high bleeding risk or whether he doesn't have it. So high bleeding risk, of course, is defined by age criteria more than 75, concomitant morbidity like renal, liver, or active cancer, presence of anemia or low platelet, presence of intracranial hemorrhages, bleeding diastasis, prior transfusion, patient already on OAX, and said steroid planned for a DAPT or trauma-related surgery. So this is a paper from Philip Urban, which looked at defining the same in the ESC, and that's how this paper took like the leaders-free, polymer-free Hepalimus A9 superiority to bare metal stent in high-risk bleeding group, which actually showed that the cumulative incidence of composite of death, MI, or definite and probable stress thrombosis beyond a year in high bleeding risk, the safety efficacy of PF biolimus AVA was superior to BMS in those who received 1 month of DAPT as compared to who did. So STOP DAPT2 was designed, which looked at the prospective multi-center randomized comparing 1 month versus 12-month DAPT after cobalt chromium everolimus eluting stent, which included 2 arms, the clopidogrel alone arm and the clopidogrel aspirin arm at a year, with the primary analysis for non-inferiority. And we all know that the net clinical benefit, including CV death, MI, stroke, or major bleeds, was statistically significant, achieving a superiority, though designed initially for non-inferiority, with 36% reduction in cumulative incidence of a day from the index event of the composite endpoint. Again, major secondary ischemic points or the clinical outcomes at one year or major secondary bleeds also achieved a superiority independently in the arm. So then SMART date trial, which was looking at 6 month versus 12 month of longer DAPT after PCI in patients with ACS, again a randomized open label multicentric trial, 2,700 plus patients of ACS with everolimus, zotarolimus, or everolimus eluting stent, biolimus eluting stent, were randomized either to DAPT for 6 months or DAPT for 12 group for 12 months or more, with P2Y12 inhibitor given for that duration. And you can see even in this subgroup, the hazards ratio, though not reaching statistical significance, with the DAPT12 was 13% lower, and hazards for the single was 6 months was higher, but this was not statistically significant. Again, same was the case with the BARC2 bleeds, however, again, not reaching statistical significance. But the patients who were on 12-month therapy had a higher hazards ratio of a BARC2 to 5 bleed, and intention to treat analysis showed risk of MI also being statistically significant. So 6-month DAPT was non-inferior to 12 months for longer DAPT for primary endpoint for MACE at 18 months after the index procedure with DES. However, increased risk of MI with 6 months DAPT prevented us from concluding that the short term is safe in ACS in patients undergoing PCI with the current DES. Then came the Twilight, which looked at TICA with aspirin or alone in high-risk patients with coronary intervention. And this was analyzing ticagrelor DAPT versus ticagrelor monotherapy beyond 3 months. And this is the composite endpoint, which look at the BARC type 2, 3, and 5 with the bleeding during 3 to 15 months, with the key endpoint being all-cause death, non-fatal MI, stroke be in this phase of group. And remember, these were all high-risk patients, which included at least one criteria from angiographic or clinical criteria for the inclusion, which included age, female gender, TROP positivity, polyvasculopath or established vasculopath, diabetes or CKD, and angiographic lesions of multivessel disease, long stents more than 30, thrombotic lesions 111 Medina classification, requiring more than 2 stents and a left main or a proximal LAD, or a patient undergoing atherectomy. All these high-risk patients were analyzed in Twilight. At least one of them was a compulsion to be inclusion criteria. And there was a significant reduction in monotherapy compared to DAPT with a reduction of almost 44% in the BARC2, 3, and 5. And when you look at the difference in ischemic rates, they were not very different. So this goes on to prove that you can actually switch on after 3 months to a single antiplatelet in the Twilight-like criteria with only ticagrelor, with same amount of MACE or event rates with lesser bleeding rates. So in a patient with PCI at high risk for bleed and ischemic events who were tolerated DAPT for 3 months, TICA significantly reduced BARC type 2, 3, and 5 bleed by 44%, and type 3 or 5 bleeding reduced by 51% as compared to DAPT that included ticagrelor arm. Monotherapy was non-inferior for composite endpoint of all-cause death, MI, or stroke, and in patients who have undergone PCI with clinical angiographic characteristic, TICA monotherapy after 3 months of DAPT can be an option to reduce the bleed risk. So then came the TICO trial, which also looked at the 3 months in whether this 3-month DAPT improved upon TICA-based 12-month DAPT for ACS undergoing ultra-thin bioabsorbable or Ciro-like stent in terms of NACE, which is net adverse clinical event, which included combining the risk of ischemia plus bleed, and hence the NACE of TICA would be, hypothesis was, would be superior to 12-month therapy. And this was 1:1 randomization at the time where patients undergoing the stent implantation of 3,000 plus patients, and 3 months, they all received DAPT. At 3 months, one arm had only TICA, the other arm had the DAPT. And you can see that the NACE, as was predefined, there was 34% reduction in TICA monotherapy. So 12 months versus 3 months, even landmark analysis, you can see that the 90 days, the curves were not very different. They were pretty much matched because they all had secondary re-randomization, as you can call. At 3 months, they both were receiving, both the control and the arm were on the same line of therapy. And hence, once you stopped aspirin, the NACE rate went down by 59%. So significant 44% reduction in the bleed alone. And the 3-month landmark also showing another 0.13 of hazards, which is a huge difference in terms of the 3-month landmark analysis compared to hazards of 0.56, which goes on to again establish that the ticagrelor monotherapy after 3 months of DAPT significantly lower risk of net adverse events than currently recommended DAPT of 12 months, primarily driven by the major bleeds. And this indicates that ticagrelor monotherapy could be an optimal strategy, not only in balancing ischemia as well as bleed risk, but even for the new generation stents, it might be biodegradable polymer sirolimus ultra thin stents can be a good choice. So DAPT duration should be chosen irrespective of the type, as for the treated with PCI. And you can see that the ESC also talks about this flow chart, which is now very easily available and everybody amongst us is aware of, which look at the stable CAD, high bleeding risk, then you can do a 1 month of DAPT, not a high bleeding risk, 6 months of DAPT. ACS, of course, you can go to 12 months of DAPT with the combination of prasugrel or ticagrelor or clopidogrel. But in patients who are high bleeding risk, 6 months is class 2A/B indication of continuing this 6 months of DAPT and then choosing a single drug. So what do we know and where are we headed after this? So shorter DAPT duration invariably involves a trade-off between ischemia and lower bleed. Optimal duration seems strongly dependent whether the clinical presentation of PCI was an ACS or a non-ACS setting, and ultra short DAPT duration after stenting and high bleeding risk is encouraging, but trials comparing different DAPTs in high bleeding risk are lacking, and 1 month may not be the sweet spot. Synergies between short and ultra short DAPT of monotherapy, a true high potency monotherapy, would be preferred, as we know from Twilight and TECO studies, which have shown that this actually balances off the bleeding risk and also gets you the benefit of preventing ischemia. So these are the packaging inserts of the drug. Thank you very much for patient hearing. Over to Chair. Thank you.
Thank you. Thank you. Thank you, Dr. Kamal, for your excellent presentation. And as you have explained very clearly, 1 month is not the sweet spot. See, I don't think any interventional cardiologists are confident to stop DAPT at the end of 1 month. 3 months is a reasonable period of time. Absolutely. 3 months is a reasonable period. However, all these studies has given us some confidence that in a particular patient, if we are forced to stop it after 1 month, these studies give us some confidence to stop it because we have got evidences. Absolutely. And secondly, the stop DAPT trial has used all science stents only. So we don't know whether we can extrapolate it to other kinds of stents. Absolutely. And it is said that the highest risk of stent thrombosis is the first 30 days, 1%, the first 30 days. Then from the end of 30 days to the end of 1 year, it's only 1%. That's why the aspirin is very much needed in the first 30 days. And secondly, aspirin is the most potent agent to prevent thrombotic tendency due to the collagen. So, and aspirin problems comes in long term. Long term produces gastric erosions, bleed and everything. So aspirin is a must initially, and it is reasonable to continue it for 3 months. After 3 months, it's okay. However, as I emphasize that the study gives us some confidence. Suppose in a year you may get 1 patient where you are forced to stop after 1 month. Again, this study gives us some confidence to do that.
I completely agree. I think there is no better antiplatelet agent than the endothelized coronary artery. And I think the previous 2 sessions were looking at that aspect as well. Polymer, I think I was listening to your discussion with the previous speaker. I think it's not just the polymer, type of polymer, when it degrades, how much it degrades. I think it's also important to look at from the Reno Money's analysis that endothelization is the most important factor that actually drove the first generation of stents out. If you could endothelize early, probably, maybe that's where the sweet spot lies. So unless that data emerges, your point, I completely agree with what you're saying, that we don't know whether it's 1 month, 3 months. That will vary from stent to stent. You can't probably extrapolate data from Zions to maybe say or zero.
Definitely. Again, we are able to do that because more and more of image-guided PCI, so that stent malapose is not there. We use high-intensity statin plus the stent designs, or we are able to reduce the DAPT because of that. Thank you. Any comments from any co-chair? Anybody? Any comments? Okay, Kamal, anything you would like to add?
No, that's it, I think. Thank you very much, Dr. Suresh.
Thank you very much. Thank you. Good night.
Thank you, sir.
Bye-bye.
Thank you.
So that brings to the end of our session today. It was a very wonderful discussion today, and we are hoping for further more interesting cases tomorrow and more academic discussions tomorrow. So good night from our side. Thank you. Thank you all.
Thank you.